The handouts or review materials must be treated with utmost confidentiality. It shall be the responsibility of the person whose name appears therein that the handouts or review materials are not photocopied or in any way reproduced, shared, or lent to any person or disposed in any manner. Any handouts or review materials found in the possession of another person whose name does not appear therein shall be prima facie evidence of violation of RA 8293. Top-notch review materials are updated every 6 months based on the current trends and feedback. Please buy all recommended review books and other materials.
Good day to everyone. Welcome to Pearls Physiology. Okay? So, just a few days na lang to go before your board exams. Doc, again, para saan itong Pearls na to? Ano yung purpose niya? Okay? Meron po ba tayong handout uli? Meron po ba tayong lectures uli? Okay? So, we've been doing this top-notch Pearls for the past 17 years. Ever since batch 1, meron na talagang Pearls. Ang instruction na binibigay ko sa mga teachers ninyo regarding sa Pearls, ang instruction sa kanila ganito. Kung yung kapatid mo kukuha ng board exams bukas, paano mo siya tuturuan at anong ituturo mo? So with that in mind, kung kapatid ko kukuha ng board exams bukas, syempre tuturo ko na lang dyan core concepts, principles. I'll probably do it in a question and answer format para mas mabilis, mas palatable. Okay? So we each have our own strategies for the Pearls. You will see the 12 teachers doing different tactics for the respective subjects. But all of them will try and tackle the top 20% most important concepts and principles na nandun sa main handout ninyo. Okay? And it's going to be in a manner na mostly question and answer format. So, exactly kung ano yung nasa PowerPoint, yun yung nandun sa handout. Wala nang additional readings. Okay? So, ano yung purpose, Doc? There are two purposes dito sa Pearls. First purpose is to reinforce core knowledge from the main handout and main lectures. You're not supposed to learn anything new during the Pearls. Kakabahan ako actually pag sinasabi ng mga estudyante na, "Uy, Doc, ang saya-saya ng Pearls, I learned something new." Kakabahan ako, Doc, kasi hindi dapat ganon. Dapat ang nararamdaman nyo sa Pearls parang ganito. Ay nako, ang boring-boring ng Pearls. Alam ko na yan. Okay? Kapag ganon yung pakiramdam, we've done our job. Okay? To reinforce the important concepts and principles. Okay? Pagdating doon sa main handouts, main lectures ninyo. So you're supposed to have a feeling of deja vu. You're supposed to feel it's familiar. It's at the tip of my tongue. Naalala ko yan. Ngayon, at least ngayon, Doc, ano siya? Mas kumakapit. Okay? Magagamit ko talaga for the med boards. Okay? So, the Pearls will basically act as your second or third reading of the main handout. So, if you have done just one reading or you have done 2 readings for the 12 subjects, we'll consider the Pearls as your second or third reading by design. Okay? The other purpose of the Pearls is to address the backlogs. So some students will still have backlogs. We estimate probably in your batch, anywhere from 80 to 90% will have done 1 or 2 readings of the main handouts. And then around 10 to 20% will still not be finished in several subjects. Significant pa rin yung number of backlogs nila. So the purpose of the Pearls is kahit paano, para siyang fail-safe na kung hindi mo natapos man yung main handouts or main lectures, at the very least, you are given a fighting chance for the med boards. So the Pearls will discuss the core 20% of the main handout. So if you look at, for example, may Physio Pearls, okay, tapos i-compare mo siya doon sa main Physio handout, you will see, okay, Doc, there are similarities. Parang kinuha nyo yung very best portions ng main handout, nilagay nyo doon sa Pearls. That is by design. It's to address the backlogs of the students. So that's the second purpose. Now, ano daw ang relationship ng Pearls dun sa buzzwords namin? Your Pearls are based on your main handouts and main lectures. Buzzwords are not. Buzzwords are similar to your flashcards, but they have accompanying lectures. So if you look at the Physio Pearls handout, yung dulo niya, nandoon na rin yung buzzwords ng Physio. Yung buzzwords ng Physio, ako yung magdi-discuss sa inyo. Okay? So yung buzzwords ng Physio para siyang nasa flashcard format, question, answer, question, answer. And then, ang difference niya dun sa top-notch flashcards talaga is i-discuss ko at i-lecture ko sa inyo. Okay? Yung mga flashcards, yung buzzwords na yan. So your buzzwords are based on the March 2023 med boards given student feedback. So with this strategy, na nyo kung paano natin dinesign yung program sa Top Notch. Binigyan kayo ng foundational knowledge using the main lectures, main handouts, practice test. And then ngayon, parang nire-reinforce natin with the pearls. Okay? And then to acclimatize you for the med boards, we have the flashcards and then the buzzwords. Buzzwords being based on the most recent med boards. So Doc, paano ang gimmick? Paano po namin naararin yung pearls? For this part guys, you have to please follow our recommendations. Very strict. Don't play around with it anymore. Don't try to be creative with it. We've been doing the pearls for the past 17 years. Na-analyze na namin. This is how you will do it. Okay? First is to drop everything else. You have a backlog in the main handout. During the pearls week, 6 days, drop it. Hindi ka pa tapos sa practice test, don't do it during the pearls week, drop it. Iniisip mo mag-flashcards during this time, don't do it, drop it. Drop everything for the pearls lecture and the pearls handout. Okay? Give your complete concentration, okay, to the pearls week natin. So talagang imagine, this is basically parang NBA playoffs. Okay? Survival time na talaga to for the med boards. Core 20% na kailangan nyo for the med boards. So please drop everything for the pearls. Walang maggagawa ng backlogs nila, whether for the main handout or the practice test during this time. Doc, paano gagawin? Pwede bang basahin na lang namin yung pearls handout? No. It wasn't designed that way. Ever since batch 1, ng pagkakadesign ng pearls handout, kasabay niya dapat yung lecture. Okay? Whether it was on-site or online, unbroken line ever since batch 1. Okay? You need to watch the lecture video. Okay? At the same time, utilize the handout. Kasabay. It's as if nandun ka talaga sa classroom, nakikinig ka. At yung nandun sa sa Pearls handout nyo is exactly the same as the PowerPoint. Talagang kinopy and paste na yun diretso. Okay? Wala nang additional material, unlike your main handouts. Talagang ito straight. Kung anong nandun sa PowerPoint, yun yung makikita nyo doon sa handout. Okay? So now, in an online setup, play the video lectures just once. Okay? You don't need to repeat, do a second watching. Okay? Please, don't do the pause, rewind technique kasi babagal kayo, hindi nyo matatapos yan. Assume na nandoon kayo sa tunay na classroom na kapag na-miss mo yung sinasabi ng teacher, na-miss mo. Simple as that. It will train you subconsciously na makinig. Okay? It will train you subconsciously na to pay attention. Play it on a TV. Don't play it sa iPad ninyo or sa laptop ninyo. Supot yan. Hindi kayo makaka-absorb properly ng video lectures pag masyadong maliit yung screen. We've seen it. Okay? Iba nung plinay talaga namin sa malaking projector, ibang-iba yung experience. Actually, for me, superior pa siya to an on-site lecture kapag projector yung ginagamit. So play the lecture videos ng Pearls on a large TV or on an actual projector. Use loudspeakers. Do not use your tiny headphones. Okay, for that. Play it at a normal speed or siguro 1.25x lang at most. Not too fast. Okay. Next, try to use red ballpens only. No more highlighters, guys. Okay, you need to wean yourself off highlighters. You're going to be licensed physicians soon. In the real world, stop using the highlighters. Just use the red ball pens. Print the Pearls handout, red ball pens alone. Check. Okay, and then write small notes at the side. Okay? Do 2 subjects per day during the Pearls. See the schedule that we've provided for you. Okay? Right now, we've experimented your schedule for the Pearls reverse sequence ng actual med board. So, this is the first time we're conducting that. We've done that to see whether kung yung mga biochem, yung mga first lectures nyo, kung scheduled sila very close to the med boards, kung may impact. So we're going to assess that after your batch. Next, again, there's no second or third reading for the Pearls handout. Just do 1 reading. So ganito yung mangyayari. Nanood ka ng lecture, yung handout nasa harapan mo, by the time na matapos yung lecture, yung buong handout from page 1 all the way to the last page, may notes na yon. Okay? Kasi basically kung anong nasa PowerPoint, yun yung nasa handout. So pag natapos na yon, guys, you let it go. Okay? You relax na. So probably in a single day, you'll be working for, since most of the Pearls are about 4 hours each, anywhere from 3 to 4 hours. So you'll be watching lecture videos for anywhere from 8 to 10 hours. Pag natapos yung 8 to 10 hours na yon, okay, you can already relax. Siguro na lang yung titingnan mo, yung parts na hindi mo pa rin maintindihan doon sa Pearls lecture, yun yung sisilipin mo ng mabilis doon sa main handout. Okay? So you place your Pearls handout and your main handout side by side. At the end of the day, pag natapos ka na with the two lecture videos, two subjects, okay? Place it side by side. Parts na hindi mo maintindihan at di mag-get sa Pearls, sisilipin doon sa main handout. The Pearls lectures are basically what you can consider as grand summary lectures. Di ba may summary lectures kayo doon sa after our main lectures? Guys, yung hinahanap kasi ninyo, yung during the Master Doc summary lecture, hindi dapat yun kasi the Pearls will actually serve as your grand summary lectures. Take a look at them right now. Okay? Take a look at your Physio main Pearls lecture and main lecture. Okay? As an example. So, okay, place your Pearls handout, main handout side by side at night. Parts that you don't understand, refer to the main handout. Again, these rules, follow them strictly. Don't play around with it anymore. Na, Doc, babasahin ko na lang handout ng Pearls. Doc, pag gagawin ko na lang, manunod na lang ako ng Pearls lecture videos. Doc, I will just skip the Pearls, use other materials. Okay, please do not do that. Okay? The Pearls, just imagine the scenario kung ginawa mo properly to, all 12 subjects will be basically, you'll be able to absorb the 20% most important information within 6 days. Tapos ngayon, meron pa tayong buzzwords that will acclimatize you to what happened during the March 2023 Med Boards. Guys, para kayong napiprito, naluluto na talaga properly for the Med Boards. Para kayong manok panabong na pinapausukan at pinapatapang for the Med Boards. So don't get creative with the Pearls lectures, Pearls handouts. Just follow strictly our recommendations. Concentrate only on the top-notch materials. Concentrate specifically only on the Pearls handout, Pearls lectures during these 6 days. After the 6 days ng Pearls week, it's an elective period. That's the time that you can do your summary lecture, your quiz masters, the bonus lectures. But for now, 6 days, okay, drop everything, okay, follow our recommendations here. Okay? Again, I've told you about this during my main lecture in physiology, but I'd like to reinforce, I'd like to, again, reiterate, okay, kung ano yung mga sinabi ko during that time. What has happened during the March 2023 Med Boards? Okay? First, Doc, may Physio BRS questions pa ba? You've told us na a lot of batches had Physio BRS questions integrated in the actual board exams. Do you still see that? Okay, with the Med Boards? Yes, we do. Okay. About 5 questions. Not unlike before na parang mga 40 or 50 questions talagang Physio BRS. Tuwang-tuwa yung mga estudyante na nangyari yon. Now, it's just around 5. Okay. But even though 5 questions na lang, most of the other questions na Physio related can still be answered using Physio BRS, can still be answered using Guyton and Burnett-Levy. So okay lang. Maganda actually yung Physio BRS na libro. If you take a look at it, the core concepts and principles are actually discussed very well in that book. Okay? In the March 2023 batch, we've noticed that they are reutilizing questions from previous Med Boards. Ang repeat rate ng mga questions sa Med Boards for most of the subjects is just 1 to 2%. Meaning, okay, sana, at paulit-ulit ko naman sabi sa inyo to, di ba? Sana yung mga practice test, hindi nyo iniisip na, uy, sagutin ko yung practice test kasi baka lumabas uli sa board exams namin. I told you, okay, it won't happen. Okay, the chances of that happening is just 1 to 2%. Ganun lang ang repeat rate ng mga questions sa Med Boards. However, yung practice test is still useful because it will give you the style of the exams, the content coverage of the exams. So related topics may be asked, okay, based doon sa mga questions na yan. And it's good practice. That's how you should treat the practice test. Okay, treat them as practice tests and not as the traditional samplex that you had during med school. Okay? Now, mas mataas ang repeat rate dito sa physiology. Yun ang napansin namin. 1 to 2% lang for most subjects. Okay? Upon analysis, at least 6 yung nakita, okay, for the March 2023 batch na na-repeat. Okay? There are still, it's a mixture. There are easy questions, there are trivial questions. Crossover questions are present. When you say crossover questions, mga questions na mas appropriate for anatomy, okay? Diyan din natatanong, mas appropriate for IM or for pato, dito natatanong. So, I'll be showing it to you doon sa buzzwords ko, some of these crossover questions. Okay? So, we've also noticed for the March 2023 batch that having a core knowledge in physiology will help you for the other subjects. May mga physio-related questions sa pathology, sa IM, for example. For most students, they will require 2 to 3 readings para ma-master talaga yung physio sufficient for the board exams. Now, if you've done just one reading of the main handout, that's okay. Makinig lang kayo properly, mag-notes kayo properly ngayong PEARLS. Mahahabol natin yan. Now, the MedBoards is not perfect. The Medical Act of 1959 does not specify quality assurance processes that can help create and evaluate questions in the MedBoards. So some of the things that can be improved pagdating sa MedBoards na nakita namin. Some of the questions are repeated twice. Some of the choices in the questions are repeated twice. For example, this one does not fix complement, and then you have A, B, and C being both the same. Another something that can be improved for the MedBoards, double negative questions are present. So take a look at how they ask double negative questions. If fertilization did not occur, which will not happen, A, no sloughing of endometrial tissue, blah, blah, blah. So basically, just like what I have told you during the testmanship lectures, you need to rephrase double negatives or triple negative questions in the MedBoards. Then finally, another point for improvement, impossible questions do exist in the MedBoards. What do I mean by saying impossible questions? Walang tamang sagot. Inherently, mali yung tanong or may mali doon sa choices. So, you have to apply again testmanship strategies natin, like yung virtual letter A, okay, for questions like this. Okay? Ano uli yung virtual letter A? Just arrange, since set A, set B kayo, you arrange it A, B, C, D. Okay? You arrange it alphabetically. Kung ano yung 1, kung ano yung virtual letter A, yun yung pipiliin nyo. Why are you going to do that virtual letter A? Okay? It's not because, Doc, pag sinagot ko yung virtual letter A, parang yung dating sinasabi na choose letter C if you don't know the answer. We're recommending to use the virtual letter A to take advantage of the fact that if everyone in the population taking the MedBoards for impossible questions will choose letter A, lahat kayo either tama doon sa question na yun or lahat kayo mali. Basically, ngayon, okay, it's a workaround in terms of the MPL. Okay, you will basically nullify that question if you all answer the same. Kasi wala magiging differentiating factors in the population eh. Hindi siya magiging point of differences. Pare-parehas yung sagot. Pare-parehas yung result for that particular item. Okay? So it's a testmanship strategy. Again, you can review yung testmanship tips natin regarding that particular recommendation, the virtual letter A. So this is the feedback and our analysis for the March 2023 batch. In terms of difficulty, if we will rate it from 1 to 10, okay, 10 being the most difficult and 1 being the easiest, okay? So probably physiology will be at 6 or 7. Sabihin mo 6.5 in terms of difficulty. Okay, now trend breakers can happen, okay? Or subtle changes in the MedBoards can happen. Doc, kailan siya magiging mahirap? Magiging mahirap ang physio MedBoards nyo pag maraming crossover questions, pag maraming trivial questions, okay? At pag maraming questions outside of physio BRS, Guyton, o Bird. Okay? So mainly crossover questions talaga at trivial. Okay? Dumadali ang questions sa physiology kapag yung tanong talaga is physio lang. Okay? Kasi kung physio lang, guys, yung physio BRS, Guyton and Byrne, the very best content nila, sinaksa ko na dyan sa main handout nyo eh. Na-lecture ko naman properly yung concepts and principles. So, the moment na dumami yung crossover, sabihin mo, naging 10, 20 items yan, nahihirapan na yung mga estudyante. Pag yung mga trivial questions, umakyat yan ng 10 to 20, mahihirapan na rin yung mga estudyante. But anytime na talagang mag-gear sila towards asking more physio-related stuff, nadadalian yung mga student. Nadja-jackpotan niya pag physio BRS, talagang sobrang magiging madali na for the students. Okay? In terms of difficulty, physio is similar to pharma. It's not the easiest, it's not the hardest. Okay? Just right. The hardest subjects in the med boards, past 2 years, will still be patho, prev med, and anatomy. The easiest subjects, kahit siguro hindi ka mag-aral, kahit USMLE First Aid, papasa ka na, will be anatomy and legal med. Okay? You need to get a very high, anatomy, ang easiest is legal med and micro. So the way to compensate for the expectedly lower grades that you may have in the most difficult subjects is to get high grades in legal med and micro. So wag iaala yung dalawang subjects na yon. Your main handout, for example, sa legal med, okay, it's all you need for the med boards, guys. Gold standard yung handout na yan. Dahil yung content niyan, it's going to be responsive to most, not all, but most of the questions pagdating sa legal med ninyo. Okay? So, let's begin now. Okay? First, okay, unang-unang slide dyan sa handout ninyo are the physio equations. I've actually given you a poster also for this. Please take note. Okay? Do those physio equations. You need to memorize everything in this slide. Okay? Everything in that poster. Kailangan. Lahat yan, guys, natanong na before sa MedWords. Past 5 years. So, I've included all of them. Okay? There are a lot more questions sa Byrne and Levy, sa Guyton. Hindi ko na muna in-include yon. Pag natatanong sa exam, dun lang siya nasasama. So, eto na yung mga natanong so far for the exams. Okay? Utilize them. Okay? Now, let's begin. Same sequence as in your main handout. Okay? Main lectures. I'll be discussing completely neurophysio, so baka magtagal ako ng konti for that part. Okay? Let's begin. First, let's discuss Module 1, Cell Physiology. Okay? So the Q&A here are actually based doon sa mga questions, MCQs na nandun sa Physio BRS, converted into identification. So you can use your red ball pen, check nyo lang yung mga sagot na nandoon. Answer with me, okay? Habang nandito sa lecture, try and answer with me. Take a look at the video lecture now. Intercellular connection that permits current flow and electrical coupling between the myocardial cells. So these are your gap junctions. Gap junctions, again, you will find them only in 2 sites. You will find them in the heart, specifically in the atrial and ventricular muscles. And you will find them in unitary smooth muscles. Unitary smooth muscles, for example, that found in your uterus. Okay? Gap junctions, whenever you have gap junctions, you will have syncytium, the ability of muscle cells to contract together as one. Other intercellular junctions, macular adherence or desmosomes. Remember, they are for tight intercellular adhesion. They're like stapler wires. Okay? So, you will find them, for example, in your skin, contributing to the waterproofing ability of the skin. Zonular occludence, adherence, increases the surface area for contact. Zonular occludence are tight junctions. Okay? There's a leaky tight junction and a tight junction. The tight junction, the best example of that is your blood-brain barrier. When you say tight junctions, it won't allow water and electrolytes to move as freely. Okay? Tight junctions can divide the cell membrane into an apical and basolateral side. So when you hear the term apical border, basolateral border, basolateral membrane, the implication is that those cells will have tight junctions. Because only tight junctions will create cell membrane borders like that. Okay? And finally, again, gap junctions is for rapid intercellular communication. Okay? So, galactose is a competitive inhibitor of glucose transport. What is the carrier-mediated characteristic shown here? It's competition. Okay? D-glucose is transported by facilitated diffusion, but L-isomer is not. What is this carrier-mediated characteristic? Stereospecificity. Okay? Refresh, refresh. Okay? Carrier-mediated transport, that is your osmosis, facilitated diffusion, primary, secondary, active transport. They're characterized by SSC, stereospecificity, specific shapes allowed. Saturation, finite number will cause you to have a transport maximum. Okay? And finally, C for competition. Two or more substances may compete for the same carrier protein. Okay? So, transport across cells, cell membrane, will involve either non-carrier mechanisms or carrier-mediated mechanisms. Non-carrier, we have your simple diffusion, endo, and exocytosis. Okay? Simple diffusion is not the same as osmosis. Okay? Simple diffusion will involve solutes. Osmosis will involve water. So never say that water can undergo simple diffusion. Key terms. Simple diffusion, okay, is downhill, meaning from high concentration to low. It is utilized by lipid-soluble substances. So what are those lipid-soluble substances? Oxygen, carbon dioxide, and nitrogen. And your steroid hormones, that based from cholesterol, that will include your aldosterone, cortisol, sex hormones, vitamin D. Okay? So, pag simple diffusion, wala silang saturation, wala silang stereospecificity, wala silang competition. The higher the concentration of the solute, the faster the rate of simple diffusion. Okay? Wala silang limit. Okay? Dahil wala silang saturation, for example. Okay? Endoexocytosis, endocytosis papasok, exocytosis palabas. Yung exocytosis, for example, hormones and neurotransmitters. Okay? Carrier-mediated transport, we have osmosis. Okay? Osmosis will utilize water bridges or water channels, also called aquaporins. So these water channels, water bridges, or aquaporins will allow water to be transported from ICF to ECF and vice versa. Remember, water cannot directly penetrate the cell membrane because the cell membrane is lipid soluble. Okay? Facilitated diffusion, okay? It's downhill from high concentration to low concentration, similar to simple diffusion. Okay, the only difference is that facilitated diffusion is carrier-mediated. And therefore, it can have the concept of saturation. It can have a speed limit in terms of transport. GLUT 1, 2, 3, 4, 5 are examples of those that will utilize facilitated diffusion. Remember the mnemonic for GLUT 1, 2, 3, 4, 5? GLUT 1 and GLUT 3 are found in the brain and RBC. GLUT 2 is found in the liver and pancreas. GLUT 4 is found in the muscles and adipose. GLUT 5 is found in the small intestines. Facilitated diffusion. GLUT 1, 2, 3, 4, 5. Okay? Next, we have primary and secondary active transport. Take note, the terms co-transport, counter-transport are not specific to secondary active transport. You can actually find co-transport, counter-transport in both primary and secondary active transport. Primary active transport siya pag gumagamit siya ng ATP as source of energy. Secondary active transport siya pag gumagamit siya ng sodium as source of energy. Okay? So both are called active transport because they're uphill ang transport niya. Meaning you're going to move a substance from low concentration to high concentration. When you do that, you either need to use ATP or you need to use a sodium gradient para mangyari yung transport na yon. Okay? So, kapag may ATP sa pangalan, it's automatically primary active transport. For example, sodium-potassium ATP is PUB. Pag may sodium sa pangalan at walang ATP, it's secondary active transport. Okay? In secondary active transport, okay, a substance, solute X for example, a substance can be transported uphill, okay, while sodium is transported downhill. Okay? Sometimes nalilito yung mga estudyante pag sinabi ko, ang secondary active transport, pwede siyang maging co-transport. Okay? One can be moved uphill and the others can be moved downhill. Naisip nila, Doc, wait, kung uphill po ba, tapos yung isa downhill, hindi po ba dapat opposite directions yan? Paano po tayo magkakaroon ng secondary active transport na co-transport? Okay? Uphill and downhill does not imply a direction. It implies just movement, okay, from high concentration to low, pag downhill, or low concentration to high, pag uphill. So, halimbawa, tingnan nyo to guys. Substance X can be moved from low concentration across the cell membrane to high concentration. Your sodium will be moved from high concentration to low concentration. So they are in the same direction. Even though substance X is transported uphill, okay, from low to high, sodium is transported downhill, okay, from high to low. Tingnan mo kung gaano mas maliit itong sodium na to compared dito to imply their concentration. So in here, you have a co-transport na secondary active transport. Okay? A counter-transport, of course, can happen. Substance X will be moved from low concentration to high, uphill, while sodium will be transported in the opposite direction, but still from high concentration to low. So this is an example naman of secondary active transport na counter-transport. So uphill and downhill does not imply directions because you can go uphill this way or you can go uphill this way. You can go downhill in this way, downhill also in this way. Okay, so be careful. Several students ask me about that. Okay, let's move on. So simple diffusion, permeability describes the ease by which a solute diffuses across the membrane. So factors that will increase the permeability across the cell membrane. Okay, high oil and water partition coefficient of the solute, basically describing how lipid soluble, okay, that substance is. The more lipid soluble, the higher the oil-water partition coefficient, the more permeable, and the faster the rate of simple diffusion. Low radius or size of the solute, okay, common sense. The smaller the size of the solute, the more permeable the membrane to that solute, the faster the rate of simple diffusion. And finally, low membrane thickness. The thinner the membrane, the more permeable the cell membrane to that solute, to that substance or solute, okay, the faster the rate of simple diffusion. Carrier-mediated characteristics has been discussed previously. Let's tackle the following, okay? No highlighters, please. Red ball pens lang, okay? Glucose transport in muscles and adipose cells is downhill and carrier-mediated, okay? What is the type of transport? Okay, facilitated diffusion. Okay, so muscles and adipose, so this is GLUT4. This is the one that is insulin requiring. Next, sodium potassium 2 chloride symport in the tal of LH, the thick ascending limb of the loop of Henle. Okay, so this type of transport is a co-transport symport ng secondary active transport. So ito yung complete na co-transport siya kasi same direction. Sodium, potassium, and chloride will move from the lumen to the renal tubular cells. So symport siya, co-transport, but specifically it's secondary because you use the sodium gradient for that to work. Okay? Sodium glucose co-transport. Glucose is transported uphill, okay, while sodium is transported downhill. Sodium gradient means you move sodium from high concentration to low. Makikisabay ngayon yung glucose, okay, matatransport siya from low concentration to high. And finally, the sodium-calcium countertransport. Where is the energy derived for this transport of calcium to happen? From the downhill movement of the sodium. Another way of stating this, synonymous, okay, it's from the sodium gradient. The difference between sodium from one compartment to the next. Okay? So, secondary active transport, sodium is the source of energy. Okay? Next, characteristics shared by simple and facilitated diffusion of glucose. So, both will occur down an electrochemical gradient. What does that mean, Doc? Basically, both of them are downhill. Both of them will move from high concentration to low concentration. Okay? Next, transport of D and L glucose proceed at the same rate down an electrochemical process. Same rate, despite the fact that they have different shapes. So what is the transport mechanism? This is simple diffusion. There is actually a trick question because the transport of glucose does not involve simple diffusion. It will involve facilitated diffusion. So dapat D-glucose and L-glucose will actually compete for the utilization of the transport transporter. So, facilitated diffusion dapat yun. Okay? But dito, tingnan nyo, para siya nagtatanong na, in another universe, where D and L-glucose are transported at the same rate. Okay? Same rate. What is the transport process? Simple. Kasi dapat different rates yan dahil iba ang shape nila. Stereospecificity should come in as a concept here. So, dapat isa lang yung papasok at isa lang yung gagamit. Hindi dapat same rate yan. Different rates dapat yan in our universe. Abolishing the sodium gradient across the cell membrane will affect which glucose intestinal transport process? Secondary active transport, that is co-transport. And finally, another previous board exam question from PHYSIOLOGY. Transport process blocked by the drug omeprazole and pantoprazole. So this is a proton pump inhibitor. Primary active transport. Ano specifically, Doc, yung binablock na transporter? It's your hydrogen, potassium, ATPase exchange pump. Okay, the hydrogen, potassium, ATPase exchange pump is an example of a primary active transport. The hydrogen, potassium, ATPase exchange pump also has another name. We call it the proton pump. H plus are protons. Okay, the proton pump, that's the synonym for hydrogen, potassium, ATPase exchange pump. What is the osmolarity of 1 mole of sodium chloride? Okay, solution. Okay, osmolarity is not synonymous with concentration. Remember, okay, osmolarity is the concentration, okay, times the number of dissociable particles. The number of dissociable particles in a solution. Sodium chloride, salt, when you place it in water, it will dissociate into sodium ions and chloride ions. So the correct answer for this, if you have 1 mole, it's actually 1 times 2. 2 for the individual ions of sodium and chloride. So that's the correct osmolarity of your 1 mole sodium chloride solution. Okay? Nerve cell membrane at rest is far more soluble to which solute? Another previous board exam question. Potassium rather than sodium. The resting membrane potential of the nerve is negative 70 millivolts. There are 3 contributors to this: the Nernst potential for sodium and potassium leak channels, and the sodium-potassium ATPase pump. The one that contributes the most is the Nernst potential for sodium and potassium. Okay? The one that contributes the least is the sodium-potassium ATPase pump. They've actually computed that the sodium-potassium ATPase pump will contribute negative 4 millivolts out of the negative 70 millivolt na RMP, the resting membrane potential. Now, between the Nernst potential of sodium and potassium, these are their equilibrium potential. You will notice that potassium, negative 85, is closer to the negative 70 na RMP compared to sodium na positive 65. So kung negative 70 to, negative 85 ngayon yung dito sa potassium, positive 65 itong nasa sodium, mas malapit si potassium dito sa RMP compared kay sodium. Implication, okay? The one that contributes the most to the RMP is actually potassium because of its potassium equilibrium potential that's very close to the RMP. Okay? Nerve cell membrane at rest is far more soluble to potassium rather than sodium. So in the nerve action potential, again, you have depolarization and then you have repolarization. Depolarization is caused by the opening of your sodium activation gates. Remember that? While repolarization is caused by the closure of your sodium inactivation gates and the opening of your potassium channels. The nerve action potential can be further divided into the following parts: an RMP, an upstroke or depolarization, okay, an overshoot, okay, meaning lumampas na siya ng 0 millivolts, okay, a repolarization phase, okay, and finally an undershoot. Pag undershoot, it means you went below the RMP of negative 70 millivolts. Okay? Simpler way, depolarization, upstroke, repolarization, downstroke. Okay? Next, occurs down the upstroke of the nerve action potential. net inward current and the cell interior becomes less negative. Okay? Why do they use the term, Doc, less negative? Sa halip na lang sabihin na naging siyang more positive. Less negative is technically the correct term kasi nagsimula ka from negative 70 millivolts. Hindi ka nagsimula from zero. So from negative 70 millivolts, okay, you become less negative during the upstroke. Okay? Pwede po ba namin gamitin yung naging siyang more positive? Pwede. Technically, pwede. Pero better term, best answer is during depolarization, okay, the nerve becomes less negative. Okay? Potassium is closest to which electrochemical equilibrium at which point? 0.5, negative 85 millivolts. Process responsible for membrane potential change between points 1 to 3. So this is sodium influx caused by the opening of the sodium activation gates. Process responsible for the membrane potential change between 3 to 4. So the movement of potassium out of the cell. Okay, so potassium efflux. And you can also add here the reason kung bakit nag-stop yung depolarization, the closure of the sodium inactivation gates. Next, if this is the nerve action potential, a stimulus happened at this stage. During this time that you made a stimulus doon sa nerve, sa neuron, bakit hindi nagkaroon ng action potential? The reason for that is because you are in the absolute refractory phase. It will not occur. No new action potential will happen. You are in absolute refractory period, ARP. Refractory means non-responsive. So if you have absolute refractory period, absolutely, no matter what stimulus you do, you cannot elicit a new action potential. The basis for this is the closed sodium inactivation gates. Relative refractory period, so this is the time that you have your relative refractory period. RRP, you can generate a new action potential during this time. If you conduct a stimulus during this time, pwede kang magkaroon ng new action potential, but it is conditional. What is the condition? You need greater than usual sodium inward current, meaning you need greater than normal stimulus. Why though? Because you are farther away from the threshold. Okay, this is basically the undershoot portion of the action potential. So you are farther away from the threshold. Next, effect of myelinating the nerve in the conduction velocity of action potentials. Increased myelination will cause an increase in the conduction velocity. So conduction velocity is basically the speed of transport. It is increased by the following: fiber size, myelination, and saltatory conduction. The thicker the fiber, the nerve fiber, the faster. The more myelinated, the faster. And the presence of saltatory conduction, the faster also. Okay? Myelin, remember, previous board exam question, it is an insulator. Okay? Signals are not transmitted via the myelinated portions. Instead, signals are transmitted via the unmyelinated portions. These unmyelinated portions, we call them the nodes of Ranvier. And in each nodes of Ranvier, you are basically regenerating the action potential. That's why no matter how far you are away from the initial segment, no matter how far you're away from the source of the action potential, the strength of the signal will not change. Okay? Dahil in each nodes of Ranvier, you regenerate the action potential. Okay? Another previous board exam question based on Physio BRS, 68-year-old with SIADH, syndrome of inappropriate ADH secretion. So, there's increased water retention, water alone, not sodium. So, nagiging hypotonic, okay, yung kanyang plasma, yung kanyang blood. So, the patient is treated with hypertonic saline, okay? But before the treatment, what will be the plasma osmolarity? The normal plasma osmolarity is 300 milliosmoles per liter. Okay? Those are the normal values agreed upon by physiology teachers. Of course, if you look at references, iba-iba yan. Normal plasma osmolarity, 290, 295, 300, 310. It's 300. Okay? So, if you have SIADH, we expect it to be less than 300. So, ano doc yung best na answer dyan? Between 290 and 235 na choices, of course, I will answer 235. Yun talaga ang hypotonic. Kasi sa certain books, 290, normal pa eh. So, hypotonic, hypoosmotic, 235 is the best answer here. Remember, the med boards will not ask you for the correct answer. The med boards, the instructions there is to choose the best answer. So, SIADH, you're going to have a hypotonic, hypoosmotic, ECF. Okay? Plasma osmolarity na mababa. So these are the various causes of SIADH. Most likely in your board exams, they will utilize this in the case. Okay? Yung ectopic ADH secretion seen in small cell lung carcinoma. Next. Solutions A and B are separated by a semi-permeable membrane, permeable only to potassium. Solution A has a higher potassium chloride concentration compared to solution B. So how will potassium move? If A and B, may semi-permeable membrane sa pagitan nila, ito 100, ito 1, and then naging permeable siya sa potassium lang, of course yung potassium mo will move from high concentration to low concentration. From high concentration to low concentration. So it's going to move from solution A to solution B. A previous board exam question. Next. Solutions 1 and 2 are separated by a semi-permeable membrane. Solution 1 contains a solute that is too large to cross the membrane. Solution 2 is pure water. So which solution produces an osmotic pressure? Of course, the one that is too large to cross the membrane, okay, it's probably mannitol or some other large polysaccharide or some large protein. So this is your solution 1. That will be the one to produce that osmotic pressure. Next, two solutions of sodium chloride are separated by a membrane that is permeable only to sodium but not to chloride. The sodium chloride concentration of solution 1 is higher than that of solution 2. What happens to both solutes? Okay, permeable only to sodium but not chloride. Tapos higher sa solution 1 than solution 2. Di parang yung question kanina, of course, it's going to move from solution 1 to solution 2. From high concentration to low concentration. Okay? Next, another previous board exam question. Pinalitan lang nila yung values, pero yung 10 and 5, pinalitan lang nila, pero yung actual answers and choices hindi nila pinalitan. It's separated solutions A and B with 10 and 5 na concentration ng urea respectively are separated by a membrane permeable only to urea. What will happen if I double the urea concentration? Okay, if I double the urea concentration, the flux, meaning the rate of transport, will increase by 3 times the normal value. Originally, 10 minus 5 equals 5. Yan yung rate of transport. Take a look at the formula in your main handout for this. Ngayon, ginawa mo tong 20 minus 5 or 15. So, 15 is 3 times greater than 5. So, ngayon, yung rate of transport will also increase by 3 times its original value. Okay? Next, arrange the correct temporal sequence for events at the neuromuscular junction. Release of acetylcholine, uptake of calcium in the presynaptic terminal, and depolarization of the muscle end plate. So it's 213. Okay? You first have uptake of calcium in the presynaptic terminal, release of acetylcholine, and then depolarization of the muscle end plate. Motor neuron, okay, doon sa pinakadulo, will secrete acetylcholine. That acetylcholine will happen once depolarization has reached the terminal botons. Voltage-gated calcium channels will open. Calcium will enter the motor neuron. When that happens, okay, that will cause exocytosis of acetylcholine. Acetylcholine will then bind with the acetylcholine receptor in the motor end plate. When they do, sodium goes in, potassium goes out. But mas maraming sodium na pumasok kaysa potassium na lumabas. It will depolarize the motor end plate. Okay? Magkakaroon ka ng miniature end plate potential or MEPP that will submit to form your MEP. Okay? And then cause depolarization across the sarcolemma. From there, remember yung mga nilecture ko sa inyo during the main lecture, magkakaroon ka ng depolarization sa transverse tubule. Ma-activate mo doon yung DHPR, dihydropyridine receptor. then ma-activate yung ryanodine receptors, found doon sa sarcoplasmic reticulum. Ryanodine receptors, okay, will then release calcium. Calcium will then bind with your troponin C. Calcium troponin C complex will then cause tropomyosin to shift to the side. Okay, then you will have cross-peak cycle. Okay, myosin heads binding to actin. Okay, then partial ATP hydrolysis causing your recocking of the myosin heads. Complete ATP hydrolysis causing the power stroke, so on and so forth. Once you want muscle relaxation to happen, remove calcium from troponin C, return calcium back to the SR, and then have acetylcholinesterase degrade your acetylcholine. Okay? Which channels are opened by acetylcholine at the muscle end plate? The sodium and potassium channels. Mas maraming sodium na papasok kaysa potassium na lalabas. So the steps, once again, in muscle contraction are listed here. I won't discuss them anymore. Okay, you can take a look at your main handout at that part if you want to learn it again. Important for you, again, as a testmanship tip, identify the first or last event. If you're able to identify the first or last event for sequence questions, you'll be able to narrow down the choices and increase your odds of getting the answer correctly. Okay? Next, occurs before the depolarization of the transverse tubules in the skeletal muscle, the depolarization of the sarcolemmal membrane. For this slide, again, important ha, dihydropyridine receptors are found in the transverse tubules. That's their location. Ryanodine receptors are found in the sarcoplasmic reticulum. Okay? The condition called malignant hyperthermia will involve a genetic defect for ryanodine receptors. When a patient is exposed to halothane, succinylcholine, kung meron siyang genetic defect ng ryanodine receptors, na-activate yung ryanodine receptors, na-release yung calcium sa skeletal muscles, na-overexcite yung skeletal muscles, at nagkakaroon ka ng increased temperature from the overexcited skeletal muscles. Dok, bakit? Heat is a product of inefficient energy conversion. So, overexcited skeletal muscles will produce heat. Treatment for malignant hyperthermia, Doc? Dantrolene, of course. Okay, anong effect mo ng dantrolene, Doc? It's a calcium channel blocker. Anong calcium channel, Doc, ang binablock ng dantrolene? This one, ryanodine receptors, to be more specific. In smooth muscles, it occurs after the binding of calcium to calmodulin. So smooth muscles do not have troponin C, troponin I, troponin T. The equivalent for troponin C is calmodulin. The equivalent of troponin I is caldesmone. So in the smooth muscles, after calcium binds to calmodulin, what do we expect to happen? An increase in your myosin light chain kinase. Myosin light chain kinase, anong gimmick niya, Doc? It will add, okay, phosphate to your myosin heads. When phosphorylated ang myosin head, what will happen, Doc? Okay, pag phosphorylated ang myosin heads, okay, magkakaroon ka ng smooth muscle contraction. What if you want smooth muscle relaxation, Doc? You will then use the other enzyme, MLCP, myosin light chain phosphatase, that will remove phosphate, okay, from your myosin head. Okay, pag dephosphorylated ang myosin head, in the smooth muscles, you will have smooth muscle relaxation. MLCK for smooth muscle contraction, MLCP for smooth muscle relaxation. Calcium calmodulin complex is the trigger for MLCK. Comparison of skeletal muscles, smooth muscles, and cardiac muscles are listed here. Okay. Again, the one with the greatest percentage of mitochondria are your cardiac muscles. The one with the greatest number of SR is your skeletal muscles. Okay? And the one that will use MLCK, that's your smooth muscles. Previous board exam question. Among the type of muscles, again, cardiac muscles will have the greatest number of mitochondria. And the one that lacking in a atrial myocyte, you have transverse tubules. Largest muscle, Gluteus maximus, another previous board exam question. Strongest muscle by weight, another previous board exam question. Masseter. And then, majority of muscle weight comes from where? Another previous board exam question. Myosin. Okay? So, types of muscles, we have skeletal, which is voluntary. Cardiac and smooth muscles, which are involuntary. Skeletal muscles are further divided into intrafusal and extrafusal. Intrafusal, remember, is synonymous with the term muscle spindles. They make up 5% of your skeletal muscle and they detect changes in muscle length. They are proprioceptors. They are for position sense. Okay? Intrafusal, special skeletal muscle fibers. Extrafusal, this is the ordinary muscle fiber. Okay? It's for voluntary contraction. Okay? Extrafusal is divided into two, type 1 and type 2. Remember the mnemonic, one slow red ox with a perfect posture. Type 1 is slow twitch muscle fiber. Type 1 is red muscle fiber. Type 1 is oxidative muscle fiber. Type 1, the best example where you can find mas predominant siya compared to type 2 are the postural muscles of the back. Type 1 is for endurance. Okay? It's red, previous board exam question, because it has plenty of myoglobin. Type 2 is just the complete opposite. It's for power. Okay? Type 2 is a white muscle fiber. Okay? With a fast contraction velocity. Okay? So, pag tinanong sa inyo anong types ng skeletal muscle, hindi type 1, type 2 ha. Types of skeletal muscle is intrafusal, extrafusal. Ang type 1 and type 2 are types of extrafusal muscle fibers. One slow red ox with a perfect posture. That will be your mnemonic for this one. Cardiac muscles, we have atrial, ventricular, and pacemakers. Pacemakers have autorhythmicity. Smooth muscles, two types. Unitary and multi-unit. Unitary, we're called unitary because they are united. They contract together as one because they have gap junctions. So they are for gross motor movements. When you want smooth muscles to contract together as one, you use unitary smooth muscles. Best example, uterus. Unitary ang nandyan. Multi-unit, no gap junctions. It's for fine motor control. For example, the smooth muscles controlling pupil size, multi-unit yan. What causes rigor in skeletal muscle? Decrease ATP level. So when you die, may rigor mortis kasi you don't produce ATP anymore. So remember ang role ng ATP sa muscles, provides of course with the power needed to contract, but ATP, kapag dumikit kasi siya sa myosin head, nag-unbind yung myosin from actin. So kapag ngayon kulang ka sa ATP, walang mag-cause ng unbinding na myosin head from actin. So you can have, for example, rigor mortis when you die because of that. Okay? So, myasthenia gravis. 42-year-old male with myasthenia gravis improves with acetylcholinesterase inhibitor. What is the basis for improvement? It's the level of acetylcholine at the muscle end plate. It increases. What do we mean? Myasthenia gravis, the pathophysiology is that there are antibodies to the acetylcholine receptor. So, halimbawa, ito yung motor end plate mo. Tapos, ito yung acetylcholine receptor. Ang problema is dumidikit yung antibody dito. Obviously, kung nakadikit yung antibody dyan, hindi makakadikit yung acetylcholine. Kung hindi makadikit yung acetylcholine, wala kang muscle contraction. So, you'll present with weakness in myasthenia gravis. So ideally, ang drug na ibibigay dapat natin, yung something na makakapagtanggal ng antibody na yan na nakadikit sa acetylcholine receptor. But we don't have that drug. So ang gimmick natin dito, indirect indirect treatment Doon sa mga acetylcholine na nakabind na sa acetylcholine receptor, ang gusto natin is that they stay longer in that acetylcholine receptor. So we're going to use acetylcholinesterase inhibitors. Okay? Iiwasan natin yung acetylcholinesterase para mas maraming acetylcholine, okay, doon sa motor end plate. Kasi hindi natin malabanan diretso yung mga antibodies involved in myasthenia gravis. Hindi natin siya matanggal basta-basta. Okay? So, some questions during the mastery period, one student asked, several students actually asked, which drug is for testing, which one is used for the treatment of MG. So, several students asked. So Dr. Gabby answered this. Let me read. Neostigmine can also be used for treatment, but because of its short half-life and short duration of action, peridostigmine is the one that is preferred. Edrophonium, okay, also called your tensilon, that's the brand name, is a drug more known as a diagnostic tool in the bedside tensilon test. But IV neostigmine has also been used as a diagnostic tool because of its short half-life and rapid onset of action. So please take note of that. Okay? Neostigmine, okay, peridostigmine, treatment, long-acting treatment, peridostigmine. Edrophonium, yun usually yung ginagamit for testing. But neostigmine can also be used for testing. Okay? Next, drugs that affect the neuromuscular junction. It's listed here, botulinum toxin, your Botox, will block the release of acetylcholine from the presynaptic terminus, decreasing muscle contraction, relaxing, okay, your wrinkles. Okay? Curare competes with acetylcholine for the motor end plate, so utilized for poisoned arrows in South American tribes. Inhibits acetylcholinesterase, you have neostigmine, and then blocks the reuptake of choline into the presynaptic terminal hemicholine. Okay? Some mnemonics to help you. Write this down. Okay? Botulinum toxin blocks the release of acetylcholine. Curare blocks the receptors for acetylcholine. Okay? Neostigmine blocks the enzyme, okay, needed to degrade acetylcholine. And finally, hemicholine blocks the reuptake, okay, of choline into the presynaptic terminal. So botulinum blocks the release, curare blocks the receptors, neostigmine blocks the enzymes, and hemicholine blocks the reuptake. So that's it for cell physiology. Okay? Thank you so much. Module 2, neurophysiology now. For the autonomic nervous system, remember our classic mnemonic given to you, plasma. Ano ulit yung plasma? Parasympathetic nervous system will have a long preganglionic tract. It will have a short postganglionic tract. It will utilize acetylcholine twice. Okay, once communication between preganglionic to postganglionic, and the other one from postganglionic to the target organ. Okay? The final receptors are muscarinic receptors. So para will have a long preganglionic tract, short postganglionic tract, utilize acetylcholine twice. Final receptor is muscarinic. Just do the opposite for SYMPA. SYMPA will have a short preganglionic tract, a long postganglionic tract. Okay? Will only utilize acetylcholine once for the communication ng preganglionic sa postganglionic. Okay? Final neurotransmitter is norepinephrine. And final receptor is adrenergic receptors. Fight or flight is SYMPA. Rest and digest is PARA. So let's take a look at the table. Okay? Thoracolumbar distribution is SYMPA. Craniosacral distribution is PARA. So thoracic nerves, lumbar nerves are utilized by SYMPA. Cranial nerves and sacral nerves are utilized by parasympathetic nervous system. Anong cranial nerves, Doc, ang ginagamit ng parasympathetic nervous system? The mnemonic is 1973. Cranial nerves 10, 9, 7, and 3. 1973. Okay, 1975, that's the mixed motor sensory cranial nerves. 10975, 1975. 1972, 10972. Those are your vitamin K dependent clotting factors. Okay? Final receptor of SYMPA and PARA. Adrenergic for SYMPA, alpha 1, alpha 2, beta 1, beta 2. And then for PARA, muscarinic. Okay? Tirahin natin mamaya yung alpha 1, alpha 2, beta 1, beta 2 na yan. For the adrenal glands, you have here a neuron secreting acetylcholine, binding with the nicotinic receptor, okay, causing the chromaffin cells of the adrenal medulla to release 80% epinephrine and 20% norepinephrine. So that norepi can also stimulate your adrenergic receptors in the target organs. Okay? So that adrenal medulla production of epi and norepi will supplement the norepi produced by the postganglionic neuron ng SIMPA. Okay? So, parasympathetic muscarinic receptor effect on the eyes is meiosis. Meiosis is pupillary constriction. Okay? Contrast that with mydriasis, which is pupillary dilation. Mnemonic, meiosis, yung bibig mo lumilit, meiosis, pupillary constriction. Contrast that with mydriasis, yung bibig mo lumalaki, mydriasis, that's pupillary dilation. Anything that happens to the body when someone points a gun at your head will be a sympathetic reaction, a fight or flight response. If I point a gun at your head, you'll have pupillary dilation, you'll have sweating, you'll have bronchodilation, you have tachycardia, you have increased sweating. Okay? All of those will tend to occur at the same time, what we call mass discharge of sympathetic effects. So, everything else, rest and digest, is parasympathetic nervous system. So let's take a look. Again, look at your main handout, the concept of singly innervated organs. Hindi lahat ng organs may simpa, hindi lahat ng organs may para. Sometimes singly innervated lang siya. So for example, sympathetic lang, walang parasympathetic. That will include the cardiac ventricles, the pregnant uterus, and most of your blood vessels. They will only have sympathetic and no parasympathetic innervation. So, sympa in the heart will increase your heart rate, ventricular contraction leading to an increase in stroke volume, and AV node conduction, increasing your conduction velocity. Para will do the opposite. Okay? Other things in this table, okay? Bronchioles, bronchodilation will cause by sympa, para will cause bronchoconstriction. Urination, defecation, that's para. Urination will involve contraction ng detrusor muscle ng urinary bladder, and it will involve relaxation ng internal and external urethral sphincters. Okay? So, fat cells, lipolysis is beta 1, okay, in adults, and then beta 3 in the neonates. Autonomic receptor involved in ejaculation is alpha 1. A previous board exam question. Point and shoot is our mnemonic for erection and ejaculation. Point and shoot. Para, point, erection. Simpa, shoot, ejaculation. Ejaculation, tinanong sa board, anong receptor ginagamit? Alpha 1 receptor. Okay? These are your adrenergic and muscarinic receptors. Remember, okay, look at your main handout. I told you, alpha 1 when stimulated will always cause smooth muscle contraction. Beta 2 when stimulated will always cause smooth muscle relaxation. Okay? Beta 1, prominently, you will find it in the heart and in the kidneys, puso at bato. Okay? Increasing in the heart, it will cause an increase in heart rate, stroke volume, conduction velocity. In the kidneys, previous board exam question, beta 1 when stimulated, that will stimulate RAAS, the renin-angiotensin-aldosterone system. Alpha 2 is found in several sites, but the most important is that you will find it in presynaptic nerve terminals. Alpha 2 is basically anti-sympathetic. When stimulated, it will cause a decrease in the release of your norepinephrine. Okay? Muscarinic receptors, well, you have M1, M2, M3. When you love someone, remember that mnemonic in the main handout? You love someone, use your brain, your heart, and your other organs in sequence. M1 is in the head and neck. M2 is in the heart. Okay? And M3, muscarinic receptor 3, can find it in the organs below. Okay? For example, in your sex organs. Okay? Next. Effect of atropine on AV node conduction velocity. It will increase your AV node conduction velocity. Remember, atropine is anti-muscarinic yung effect niya. So, it will cause a predominance of sympathetic effect, increasing AV node conduction velocity. Okay? Drug contraindicated in a child with history of asthma. Propranolol, beta agonist, a previous board exam question. It makes sense. In asthma, it is marked by bronchoconstriction and mucus plug production. So, mucus production. So, in patient with asthma, you don't want beta blockers because that will further, if it acts on beta 2, it will basically cause greater bronchoconstriction, which will further exacerbate yung condition ng patient. Next, a patient with pheochromocytoma was treated with phenoxybenzamine. What is the mechanism of action of this drug? So, phenoxybenzamine, okay, will inhibit alpha-1 receptors. Okay, it's an antagonist at your alpha-1 receptors. So, pheochromocytoma is you have a tumor producing very high levels of epinephrine. So, the adrenal medulla tumor producing high levels of epin or epi. So, it will cause a predominance of sympathetic effects. So, phenoxybenzamine, okay, can be used as a drug to inhibit some of the adrenergic receptors ng SYMPA. Okay, so with that process, it can decrease inositol 3-phosphate and calcium, yung mga second messenger systems used by each. Okay, remember the classic mnemonic KISS and KICK, alpha 1, alpha 2, beta 1, beta 2, yung mga G proteins nila, GQ, GI, GS, GS. And then for M1 to M3, GQ, GI, GQ. The second messenger systems nila are listed here. Okay. Cyclic AMP for alpha 2, beta 1, alpha 2, beta 1, beta 2. For alpha 1, it's IP3 calcium. Okay. And then for M1 to M3, it's IP3 for M1 and M3 and cyclic AMP for M2. Next, a 66-year-old male has chronic hypertension treated with prazosin. What is the mode of prazosin? It's an inhibitor of alpha receptors on vascular smooth muscles. This table, also found in your main handout, must know. Agonist, antagonist in one table. Next, autonomic receptor blocked by hexametonium at the ganglia but not at the neuromuscular junction. Cholinergic nicotinic receptors. Autonomic receptors that mediates an increase in heart rate. So that's obviously beta 1. Yun ang nakikita nating adrenergic receptor sa puso. Autonomic receptor activated by low concentrations of epinephrine causing vasodilation. Beta 2. Okay, vasoconstriction is alpha 1. Vasodilation is beta 2. Alpha 1 will cause smooth muscles in the blood vessels to contract, leading to vasoconstriction. Beta 2 when stimulated will cause smooth muscles to relax, leading to vasodilation. Autonomic receptors that mediate the secretion of epinephrine by the adrenal medulla, cholinergic nicotinic receptors. Next, in terms of nerve fiber, remember a nerve, synonymous with the term nerve fiber, is basically a bundle of axons joined together. They have different types, classified according to thickness, myelination. So, we have types A, type B, and type C. Type A is further divided into alpha, beta, gamma, and delta. The nomenclature, basically pag type A alpha, ikaw yung pinakamakapal, pinakamyelinated, pinakamabilis, pinaka-accurate and precise. Then as you go down the table, nagiging kang mas manipis. Okay, so kapag dating mo sa type C, ikaw na ang pinakamanipis, ikaw na yung unmyelinated, ikaw na yung pinakamabagal, ikaw yung least precise, least accurate. Okay? So type A, alpha, beta, gamma, type A, alpha, beta, gamma, delta, type B, and then type C. Okay? This table is must know. For anything else, you need to know the modalities involved in each nerve fiber types. Proprioceptors. The one for position sets, your muscle spindle and Golgi tendon, they will utilize the best nerve fibers possible. Type A alpha, the fastest, most accurate, most precise. Pre-ganglionic nerve fiber is type B. Post-ganglionic nerve fiber is type C. Okay? Type A delta is for fast pain. Okay? Type C is for slow pain. Okay? Itch, tickle, Sexual sensations are also type C. The sense of smell is also type C. Okay? So, those are previous board exam questions. Anong modalities ang gumagamit ng which particular nerve fibers? So, which one will have, let's answer the following, which one will have the slowest conduction velocity of any nerve fiber type? Yung pinakasupot, type C. Okay, muscle stretch leads to a direct increase in the firing rate of this group of nerve, group 1A fiber. An alternative naming classification, instead of using types A, B, and C, for sensory modalities, we can use types 1, 2, 3, and 4. So, equivalent lang yan dito sa A, B, and C mo. So, take a look on yung mga equivalent nila. Type 1 is basically type A alpha. Type 4 is basically type C. Next, AP conduction velocity is enhanced by what? It's enhanced by the following: rapid sodium channel gating, wide axons, myelinations, and saltatory conduction. Bumibilis ang transmission ng signals kapag makapal, myelinated, at may saltatory conduction. That's why type A is the fastest because it's the thickest, it's the one most myelinated. Increase in what motor neuron activity will increase the sensitivity of your muscle spindle? Gamma motor neuron activity. Remember the classic mnemonic AGES. Alpha motor neuron will innervate extrafusal muscle fibers. Gamma motor neuron will innervate intrafusal nerve fibers. Okay? S was just added to complete the mnemonic. AGES is an 80s or 90s band. Next, the function of nuclear bag fibers. Okay? So, they detect dynamic changes in muscle length. Okay? So, nuclear bag and nuclear chains, okay, they are the types of muscle spindles. Muscle spindles, again, is equivalent, synonymous with the term intrafusal muscle fibers. Muscle spindle, they detect changes in muscle length. Remember this mnemonic? Muscle spindle, length. Compare that with Golgi tendon, tension. Golgi tendon, tension. Muscle spindle, length. So detects changes in muscle length, muscle spindle. Detects changes in muscle tension, okay, Golgi tendon. Those two, muscle spindle and Golgi tendon, are collectively called proprioceptors. They are for position sense. Okay, muscle spindles, two types. Nuclear bag that can detect dynamic changes in muscle length, and nuclear chains that can detect static changes in muscle length. Why were they called nuclear bag and nuclear chain, Doc? It's the arrangement, okay? Nuclear chain will literally look like a chain. Yung nuclear bag will look like a bag of nuclei, okay? Mnemonic. Imagine isang girl, inattempt na kawan ng magnanakaw, kinukuha yung bag niya. So, lumaban yung girl, hinampas ngayon ng girl ng bag niya, yung hold-upper. So, nag-move siya ng ganon. So, dynamic, di ba? Kasi hinahampas niya, ginagamit niyang panghampas yung bag. So, nuclear bag, dynamic. Nung nakita ng taong bayan na sinubukang nakawan yung girl, inupakan nila yung yung magnanakaw, tapos nilagyan nila ng chain para hindi na siya makagalaw habang hinihintay yung pulis. So, ngayon yung magnanakaw nandun sa gitna ng kalye, may chain sa kanya, hindi na siya makakilos. So, static na siya. So, chain, static changes. Previous board exam question. Function of nuclear bag, they detect changes in muscle length. Dynamic changes in muscle length. Next, the potential is graded in size depending on stimulus intensity. So, this is your receptor potential or generator potential. Receptor-generator potentials are not true action potentials. Okay? They are not true action potentials. They increase the probability of having a true action potential. Why are receptor potential not considered true action potential? Because they are sub-threshold. Okay? So, hindi sila nag-all or none. So, receptor potentials merely increase the probability of having an action potential. Next, the concept of slowly adapting and rapidly adapting receptors. When you adapt, basically you become non-responsive. Nag-adapt ka na sa stimulus, nagiging non-responsive ka. Nagiging kang refractory. So there are two types of sensory receptors, slowly adapting and rapidly adapting. So pag slowly adapting, ibig sabihin nito, as long as the stimulus is present, there will always be a response. Hindi siya namamanhid. Okay? So, slowly adapting receptors are also called tonic receptors because there is a continuous response. Pwedeng bumaba yung frequency, okay, but there will always be a response. Okay? Matagal sila bagong mag-adapt, matagal sila bagong maging refractory, matagal sila bagong maging non-responsive. Rapidly adapting receptors are also called phasic receptors. Itong mga to, rapidly adapting, mabilis silang mag-adapt, meaning mabilis silang maging non-responsive. So, ibig sabihin nito, even though the stimulus can still be present, if you are rapidly adapting, okay, there's no more action potential being generated. So, rapidly adapting receptors, when you stimulate them, they will only detect the onset and offset of the stimulus, meaning the start and the end. Even though the stimulus is still present, between the start and end, hindi na nagiging responsive, wala nang action potential na nag-generate in between. So, slowly adapting receptors, Doc, para siyang martir. Basta, mahal mo pa, basta kung magmahal siya, kahit hindi mo na mahal, nandyan pa rin, palaging may steady response. Yes. Ito namang rapidly adapting receptors, Doc, parang playboy, playgirl. Gusto lang nila start and end ng relationships. Kahit mahal mo pa siya, hindi ka na niya mahal. Yes. That's one analogy, martyr and playboy, playgirl. Okay? Now, tactile receptors, I want you to take a look at your main handouts for this also, yung part na ginawa ko. Mas matindi yung mga descriptions na nandoon. Okay? But, for the pearls, top 20% most essential things that I want you to remember. Okay? Take a look at how I classify them. FA is fast adapting. SA is slow adapting. 1 and 2 here refers to the receptive field. Okay, ano ba yung receptive field, Doc? A receptive field is a region in the skin controlled by a single neuron. Okay? So, kapag sinabi mong type 1, okay? Kapag type 1 receptive field ka, the region in the skin controlled by type 1. Ano ba? Gamitin natin hand. The region controlled by type 1 will be small and with well-defined borders. Okay? Yan yung receptive field. Isang sensory neuron lang nagkocontrol yan. Kapag type 2 naman, okay, it will be wider, yung region na kinokontrol ng sensory neuron, but with poorly defined borders. So type 1 receptive field, imagine mo ganito yung mnemonic. Type 1, parang ginaganon mo. Ang lalagay mo rito, dinududot mo is just a small region but with well-defined borders. Type 2, wider yung region but with poorly defined borders. Type 1, small, well-defined borders. Type 2, wider but with, nahihilo siya, with poorly defined borders. Okay, now, take a look. If you want two-point discrimination, the ability to detect two separate points as discrete areas, what do you want for that? Do you want type 1 receptive field or type 2 receptive field? So if you want to be able to detect two separate points as separate, gusto mo dyan is type 1. So sino yung involved sa, if you take a look at the labels here, sino ngayon ang involved doon sa two-point discrimination? Two-point discrimination now will be the tactile receptor with type 1 receptive field. So that will be Meissner corpuscle and Merkel's disc. Yung may type 2, Finis and Pacinian, okay, ano yan? Type 2 receptive field, hindi sila for two-point discrimination. And that has been asked in the med boards before, which tactile receptor is involved in two-point discrimination. Let me give you a mnemonic, okay? Remember what happened in World War II, di ba? Germany discriminated against the Jews. Okay? So, sino ba dyan ang mga Germans? Yung nagsa-start with the letter M, those are the Germans. Meissner, Merkel, sila yung Germans. The other two are Italians, hindi sila Germans, hindi sila for discrimination. Ruffini, Pasinian. So dahil ano lang sila, Italian sila, hindi sila kasing brutal ng mga German-sounding names dito. Okay, so hindi sila for 2-point discrimination. The one for 2-point discrimination are the Germans. Meissner, Merkel. Okay, the other two, not for 2-point discrimination. Okay, let's take a look at their individual functions also. Okay, Meissner, okay, is found in non-hairy skin. Okay, it detects low frequency vibration and texture determination. Okay, the one for high frequency vibration, tapping, that's Pasinian corpuscle. So low frequency vibration, Meissner. High frequency vibration, Pasinian. Texture determination, Meissner. Okay? Next, Merkel's disc is for continuous touch. Okay? And also for, similar to Meissner, for texture determination. Merkel's disc, you can stack them one on top of the other like donuts. When we do that, okay, you will form a structure that we call egodome receptors. Ruffini corpuscles, their function is to detect, okay, steady or sustained pressure. Okay, it also signals joint rotation. Pasinian corpuscles, I've already mentioned, they're for high frequency vibration, tapping also. And Pasinian corpuscles, onion shape. Contrast that with astrocytes, which is star shape. Okay, so yung mga natanong dati before, ano yung shape ng astrocytes? Ano yung shape ng Pasinian? Pasinian, onion. Astrocytes, star. Okay? Next, dorsal column, medial lemniscus pathway, anterolateral system. So the dorsal column pathway, okay, take a look. This is for touch sensations, vibrations, 2-point discrimination, position sense, and fine pressure. It will utilize the faster, relatively compared to the other, the faster nerve fibers, type 2. Anterolateral system, also called spinothalamic tract, will utilize slower nerve fibers, less accurate, less precise, types 3 and 4. Okay? So this is utilized by slow pain and temperature, also by light touch, tickle, itch sensation, sexual sensation. So hindi yung masyado yung mabagal siya tapos hindi masyadong accurate, precise. Okay? So decussation means crossing over. The one that will, remember, these are sensory pathways, ang anterolateral system at dorsal column. So they will start from the sensory receptor, okay, and end all the way to the cerebral cortex. Okay, and the parietal lobe of the cerebral cortex. So, ang distribution ng wires niya, pag enter nila ng spinal cord, itong anterolateral system, magdi-decussate immediately, meaning it will cross over to the other side after just 1 to 2 vertebral levels. Itong dorsal column pathway, pagkapasok niya ng spinal cord, aakyat siya ipsilaterally and will only cross over near the medulla. So, it will cross over or decussate later on, not immediately. Okay? So, mnemonic, anterolateral system. Okay? Imagine mo, sinampal mo yung kalaban mo. Pag sinampal mo siya, pak! What will they feel? Pain and temperature. How will their head move? Anterolateral. And their movement will be very, very quick. Okay? So, pag sinampal mo someone else, their head will move anterolateral system. They will feel what? Slow pain, temperature, okay? And there will be very quick movement. So, decussates immediately. Okay? So, that's our mnemonic, okay, for anterolateral system. Next, dermatomes. Region in the skin, shared with the other parts. So, it will utilize, of course, spinal nerves. Okay? So, so referred pain is secondary to the SORI, the sharing of second-order neurons in the spinal cord, and skin pain fibers, it follows what we call the dermatome rule. So, ano yung dermatome rule na yan? Ito yon. Okay? If someone will assume the original four-legged stance of animals, you can see here that the dermatomes are actually arranged in a very nice order from C1 all the way to C8, T1 to T12, L1 to L5, S1 to S5. Ganyan na magiging order niya. Ngayon, pag pinatayo mo siya, doon nagiging weird. Kasi ngayon, Doc, parang ang weird-weird ng distribution ng mga dermatomes. Your dermatomes, should you memorize them for your boards? No. Only the most important. What are the most important, Doc? T4, nipple. Okay. T10, belly button, umbilicus. Okay. C6, thumb. Okay. Down on all fours, L4, knees. And then S5, anus. Okay. T4 is your nipple. Okay. T10 is your umbilicus. Okay. C6 is your thumb. Okay. L4 is your knees. And then S5 is your anus. All of them, previous board exam questions. The rest, di na masyadong importante. Next, in terms of vision, okay? Remember, you're basically, all of you are avatars, yung cartoon na avatar, because you are light benders. When light enters the eyeball, the cornea and the lens will cause the light rays to bend at just a single point in the retina. From here, it's converted into an electrical signal that will go all the way to the brain. Okay? Now, what happens here is that this lens can change its shape. Okay? So, it can allow, if you're focusing on a nearby object or far object, it will allow you to focus on nearby and far objects, cause it to transmit at a single point in the retina. Okay? Normal vision is 20/20. Okay? When you have normal vision like that, the proper term for this is you have emetropia. So take a look at your physio handout. Natanong na yan dati sa boards. Emetropia. Now, disorders like myopia, hyperopia, astigmatism, presbyopia. Dok, anong nangyayari dyan? Okay, if normally, eyeballs should enter your eyeballs. Light rays should enter your eyeballs. Okay, cornea and lens should bend them towards a single point in the retina. In myopia, basically, the eyeball is longer than usual. So because it's longer than usual, the light rays will converge in front of the retina. So the corrective lens to use is biconcave. By using a biconcave lens na graded, it will force the light rays to converge once again at a single point doon sa retina. So myopia is caused by long eyeballs, light rays converging in front of the retina. Treatment, corrective lens is biconcave. Hyperopia, meanwhile, okay, happens when the eyeball is shorter than usual. So because it's shorter than usual, light rays will converge behind the eyeball. So corrective lens to use is convex lens. Astigmatism, what happens here? Okay, in astigmatism, basically, okay, there is an irregular curvature of the cornea. And because irregular yung curvature ng cornea, pag sinubukan pumasok ng light rays, there are multiple convergences of light in the retina, hindi single point. So, corrective lens is cylindrical lens, a previous board exam question also. Okay? Then finally, what is presbyopia? Presbyopia is the age-related loss of accommodation happening in those more than 40 years old. Okay? Certain societies ng OFTA will tell you it happens age 35, but for the boards, age 40. Okay? So, presbyopia is basically caused by the stiffening of the lens. Pag tumigas yung lens, hindi na siya nagiging flexible. So, you will need to use reading glasses na. You'll have a hard time focusing on nearby objects. So, corrective lens to use is convex lens. So, classically, I tell my students, there are very few things inevitable in life. What are the things that are inevitable in life? Death, taxes, traffic, and presbyopia, and arteriolosclerosis. So, inevitable, more than 40 years old, you're going to have presbyopia. And then when you become a senior citizen, probably this is the time you're going to have arteriolosclerosis. The stiffening of your blood vessels secondary to calcium deposition. The inevitable things in life. Next, previous board exam question, compared with the cones of the retina, the rods are more sensitive to what? They're more sensitive to low intensity light. Okay? Remember, rods, they literally are shaped like rods. Cones, they're literally shaped like cones. Rods is for nighttime vision. Rods will detect black and white vision. While cones is for daytime vision, cones is for color vision. Rods, black and white, cones, color. Rods, nighttime, cones, daytime. Okay? If you have, previous board exam question, vitamin A deficiency, what will you have? It will first affect the rods of the eyes. So you will have nyctalopia or night blindness. A previous board exam question. So vitamin A deficiency, nyctalopia, night blindness because it affects rods. Next, activates transducin in photoreception. These are metarhodopsin 2. Okay? And finally, cells in the visual cortex that responds best to the moving bar of light. These are your complex cells. Okay? So, take a look. These are the cells in the retina. Let me emphasize certain important things here. The pigment epithelial cells, what is that pigment, Doc? We're referring here to melanin. I don't know if you've naabutan nyo pa yung time na gumagamit ng film cameras. Film cameras work basically, okay, ang nangyayari is kailangan nating i-develop yung film inside a dark room para hindi sumabog yung image, may better contrast. Our eyes are basically cameras and it also has a dark room. The dark room is a layer in the retina, the pigmented epithelium. So that will function, okay, as the dark room of the eyes, okay, increasing contrast and preventing light from scattering all over the retina. Okay? Damage of the pigment epithelial cells is involved in macular degeneration, retinal detachment, and albinism. Okay? Rods, again, is for low intensity light, nighttime vision. Cones is for high intensity light, color vision. Rods is not present in the fovea. Cones is present in the fovea centralis. Okay? Ganglion cells are also a layer in the retina. Okay? The axons of these ganglion cells will form the optic nerve. Okay? Ganglion cells have P cells, M cells, and W cells. Those are their types. Okay? And these are their functions. Okay? Now, the action potential in the retina is clinically significant and board relevant. Why? Sa retina lang na ang action potential is caused by hyperpolarization. You make the cell more negative para magkaroon ng action potential. If you remember, ang action potential, dapat ang umpisa is depolarization. You make the cell less negative. You make the cell more positive. It happens in all the areas of the body except the eyes. In the eyes, ang action potential nangyayari opposite way pag nag-hyperpolarize. So the steps in the action potential of the retina is must know. Okay? The first step is probably the most board relevant. 11-cis retinal, a form of vitamin A, being converted to all trans retinal, a process that we call photoisomerization. Okay, basically, nagko-convert lang siya ng shape. It happens when photons, light particles, hits the 11-cis retina, converts it to all trans. From here, okay, may mga ni-skip dito sa PHYSIOLOGY. Basically, several intermediates are produced. The most important intermediate is metarhodopsin 2. Metarhodopsin 2, yan yung tinanong dito sa boards, yan yung tinanong dito sa part na to. Yung metarhodopsin 2 na yan. From this point, metarhodopsin 2, the following steps will occur. And if you will notice, these steps are all negative statements. Take a look. From metarhodopsin 2, it will activate transducin. Okay? Activate a phosphodiesterase. Okay? From here, ito yung negative statements. It will decrease your cyclic GMP, bababa. It will close the sodium channels. It will cause hyperpolarization. and it will decrease your glutamate release. The hyperpolarization causes the action potential in the retina, unique in the human body. Okay? In the visual cortex now, okay, the neurons here will detect the shape and orientation of figures. Okay, there are several cells involved. Simple cells respond to bars of light. Complex cells will respond to moving bars of light. Hypercomplex cells will respond to curves and angles. Okay? So, let's utilize this one. Okay? Doc, paano namin matatandaan yan? Okay? Simple cells, natanong na kasi sa boards to eh. Simple cells, okay, bars of light. Complex cell, gumalaw yung bar. Hypercomplex cells, okay, may curves and angles na. So, ganito yan guys ha. Simple cells, bars of light. Complex cell, gumalaw yung bar. Okay? Hypercomplex cell, naging curves and angles. Simple, bar. Complex, gumalaw yung bar. Hypercomplex, yung bar mo, naging curves or edges. Curves or angles. Okay? Previous board exam question. Simple, complex, hypercomplex. Bars, moving bars, curves and angles. Okay, next. So, visual field defects for your boards. Pinaka-natatanong, Doc, pituitary tumor, optic chiasm. Anong presentation niya? Optic chiasm, pituitary tumor. It will present with bitemporal hemianopsia. Of course, this one. Okay, nasaan na yung bitemporal hemianopsia natin? Eto, yung itsura niyan. Okay, non-homonymous bitemporal hemianopsia. Some other things that I want you to remember here. If you have a problem, if you cut at the level of the optic tract or geniculocalcarine tract, both of them will present with the same manifestation, a contralateral homonymous hemianopsia. So, both optic tract and geniculocalcarine tract. Now, there is a problem in PHYSIO-BRS. Kasi dun sa PHYSIO-BRS, okay, saan ba yung tanong niya dito? Tinanong niya, eto, blindness in the temporal field of the left eye and nasal field of the right eye. What is the structure damage? The answer given there is the right optic tract. That's one of the choices. Pero kasi meron ding choice doon na geniculocalcarine tract. So actually, dalawa dapat yung sagot doon. Okay? Kaso, Doc, anong gagawin namin? So obviously, may error doon sa question na yun sa PHYSIO-BRS. And it came out in the med boards. It was a previous board exam question also. Kinopya nila pati yung mali na question doon sa PHYSIO-BRS. So, we advise our students kapag ganun, pag alam mo ng Doc, pwedeng optic tract to, pwedeng geniculocalcarine tract to, di ba? Yes. Kung lumabas pareha sa board exams, Doc, anong pipiliin namin? Piliin nyo kung ano yung nakasulat sa PHYSIO-BRS. Kasi chances are, yun yung kinopya nila, yun yung nagamit, na reutilize, na integrate doon sa med boards. So, that will be the optic tract. Okay? Even though, clinically, alam nyo, okay, problems, cuts in both optic tract, geniculocalcarine tract will present with both homonymous hemianopsia. Okay? Next, take note of another error dun sa PHYSIO-BRS. Okay? It states there that the geniculocalcarine tract lesion will cause homonymous hemianopsia with macular sparing. Actually, mukhang nakalimutan ni Doktora. Dapat no macular sparing yan. Nakalimutan niya yata yung term na no. Okay? If you look at all the other references, wala dapat na macular sparing. Okay? Yung ano na yan, geniculocalcarine tract lesion na yan. Okay? Total blindness in the left eye, what structure is damaged? This is quite easy, left optic nerve. Blindness in the temporal fields of the left and right eyes, what structure is damaged? Of course, that's your classic optic chiasm. Next, this diadochokinesia, what is that? This diadochokinesia is the failure to perform rapid alternating movements. Okay? So, if you have this diadochokinesia, okay, or you have problem with balance, you have ataxia, okay, for example, okay, that's probably a cerebellar issue. So, cerebellum is involved in balance. When you read in your exam terms like ataxia, dysdiadochokinesia, okay, think of the cerebellum. So the cerebellum, its primary function is to coordinate the rate, range, force, and direction of movement. Classically, the cerebellum has been called the silent area of the brain. Why was it called the silent area of the brain, Doc? Because when we try to stimulate the cerebellum, nothing happens. So parang isipin mo, wala siyang kwenta. But when we remove the cerebellum, when we paralyze the cerebellum, problems will occur. Okay? So pag sinimulate mo, walang nangyayari. Pag tinanggal mo, may negative effects, silent area of the brain. So the function of the cerebellum is really for balance, to coordinate the rate, range, force, and direction of movement. Now, hearing. The human ear, sound can basically be described into having a sound frequency and a sound intensity or pressure. Sound frequency is pitch, how high or how low the sound is, while sound intensity or pressure is how soft or how loud the sound is. So hertz is the way to measure sound frequency, low or high. Okay? So the human ear can detect anywhere from 20 hertz to 20 kilohertz, 20,000 hertz. Okay, that's our hearing range. Other animals, iba yung hearing range ng mga yan. That's why animals can hear things you cannot hear dahil iba yung hearing range nila. So for example, hindi yan 20 to 20 kilohertz. Sound intensity is loudness. Okay? It's a logarithmic scale, ang decibel system used for measuring sound intensity or sound pressure. Magic numbers to remember, 60 decibels is the loudness of conversational speech. Okay? 85 decibels, that's the loudness, okay, the limit to prevent occupational hearing loss. If you work in an environment with more than 85 decibels ang loudness, more than 8 hours a day for more than 10 years, 85, 8 hours, 10 years or more, you can develop occupational hearing loss, the most common occupational-related disease. And then finally, a loudness of more than 120 decibels. It's a magic number that can cause pain. Okay? Take note logarithmic ang scale nitong decibels. Implication yan, from 60 to 70 decibels, for example, 10 unit increase lang yan, diba? 60 to 70. Guys, times 10 na yung loudness from 60 to 70 because of that logarithmic scale. Okay? In terms of hearing, we can divide the ear into having an outer ear, middle ear, and then inner ear. The outer ear is responsible for sound localization and sound collection. It's made up of the pinna and external auditory canal, okay, the auricle and the external auditory canal. It functions for sound localization and sound collection. It helps you hear better. Sound collection. Okay, that's why, di ba, kapag nakikipag-chismisan ka, you basically will do this to extend your auricle. Because the auricle will help in sound collection. The auricle will also help in sound localization. It tells you where sound is coming from. Why didn't God just give you holes at the side of your head? Bakit kayo meron pang outer ear in the first place? Okay? 1, to help you hear better. And 2, to tell you where sound is coming from. If I cut off both of your ears, and then you close your eyes, if a car is coming at you, you will know that a car is coming at you, but you don't know from which direction. So sound localization, that is through your outer ear, the pinna or auricle. Next is the middle ear. The middle ear is made up of the 3 smallest bones in the body, the malleus, incus, and stapes. In grade school, we used to call this hammer, anvil, stirrup. Okay? The malleus, incus, and stapes, okay, found in the middle ear, will basically connect the outer ear from the inner ear. The inner ear is the cochlea. Okay? So your malleus, incus, and stapes will basically connect the outer ear from the inner ear. Doc, bakit meron pa tayong middle ear? Bakit hindi na lang from outer ear, diretso tayo from the inner ear? The inner ear, made up of this cochlea, will have fluid inside, the endolymph and the perilymph. Sound does not travel very well in water. If you try shouting above the swimming pool, nalulunod ako, someone can hear you. But if you try shouting underwater, nalulunod ako, No one can hear you. Sound doesn't travel very well in water. Implication, kung hindi ka love ni God, tinanggalan ka niya ng malleus, incus, and stapes from outer ear, diretso yan to the inner ear. Okay? Ano ang mangyayari? Mababawasan yung sound pressure papunta sa inner ear mo because sound doesn't travel very well in water. So for example, if in the outside, the sound level is 60 decibels, mababawasan, sabihin mo, by 30 decibels by the time it reaches the inner ear kung wala kang malleus, incus, and stapes. The malleus, incus, and stapes functions for impedance matching. Anong ibig sabihin noon? Example, 60 decibels ang narinig mo sa outer ear. Yung malleus, incus, and stapes, i-amplify niya yan. Sabihin mo, gagawin niya 90 decibels for a moment. Para pag pumunta siya sa malleus, incus, para dumating siya ngayon eventually sa cochlea, pag nabawasan yung loudness because of the fluid, magiging uli siyang 60 decibels. So yung outer ear sound level, sound intensity, parehas na ngayon sa inner ear. You have just matched the loudness. That impedance matching is done, okay, by your malleus, incus, and stapes. Okay? The inner ear is made up of 3 tubes, okay, joined together. So you have here your scala media, scala vestibuli, and scala tympani. Okay, tympani, vestibuli, scala media. Okay? The scala media, the tube there, so these are like tubes, 3 tubes joined together, media, tympani, vestibuli. Okay? The media, the tube, that tube will contain endolymph. Okay? And that endolymph na fluid is very high in potassium. It is similar to intracellular fluid. The perilymph is found in the tympani and vestibuli. Okay? That perilymph is similar to ECF. It's very high in sodium. Endolymph, parang ICF, rich in potassium. Perilymph, parang ECF, rich in sodium. Okay? Ngayon, how does it work? Basically, you have here a concept called the place theory of hearing. What do I mean by that? Okay? Take a look. These are your scala media, scala tympani, scala vestibuli. Okay? They are just 3 long tubes joined together. If I cut that 3 tubes crosswise, okay, you will see here, okay, may scala tympani, scala vestibuli, scala media. You will see here a basilar membrane, okay, a tectorial membrane, and in here, the organ of Corti. Okay? Yung organ of Corti mo, may outer hair cells and inner hair cells. Mag-focus tayo sa inner hair cells. The inner hair cells are like piano keys. They correspond to a particular pitch. So ngayon, ganito yung gimmick. Okay? Kung ito yung cochlea mo, meron kang organ of Corti, basically, everywhere from this point near the middle ear all the way to this point. This point near the middle ear, okay, we call this the base. Okay, so this is the base of the cochlea. It is found near the oval and round windows. The complete opposite, yun na doon sa pinakadulo, we call it your apex. And that apex, okay, is in your helicotrema. Okay? Ngayon, ganito yung gimmick, guys. May inner hair cell ka all throughout, di ba? Organ of Corti, marami. Inner hair cells, marami. From the base to the apex. Naka-arrange yun like piano keys. They correspond to a particular pitch. Ngayon, ganito yung gimmick. Okay? From left to right in a piano, bass sounds, low frequency sounds are here. Okay? High frequency sounds are on the right. Left to right, low frequency sound is on the left, high frequency sound is on the right. Okay? Itong inner hair cells ng organ of Corti mo, reverse yung arrangement ng keys. It's a reverse piano. Yung high frequency sounds, okay, nandito sa left, near the oval window, round window. Okay? So, nandito yung 20,000 hertz. And then, as you go along, nababawasan siya ng nababawasan. Hanggang pagdating mo sa apex, nandoon na yung for the bass, for the low frequency sounds. Okay? Doc, pang boards po. Ano yung kailangan dyan? Bass. Near the oval round window. The bass, it encodes for high frequency sound. How high, Doc? 20 kilohertz. 20,000 hertz. Okay, then nababawasan yung frequency as you go along the organ of Corti. Pagdating mo dito sa dulo, pagdating mo sa apex, near the helicotrema, itong point na to, the inner hair cell will encode for low frequency sounds. Gaano ka low, Doc? 20 hertz. It's a reverse piano. A piano na yung keys baligtad. Okay? Now, Doc, what will be, of course, we know that loud sounds can damage the ear. It can damage kasi the inner hair cells. And when the inner hair cells are damaged, they die. Never to be replaced again. So, what is more damaging, Doc? Very loud na high frequency sound or very loud na low frequency sound? Mas delikado ang very loud na low frequency. Bakit? Kasi pag very loud na low frequency, tatamaan niya lahat ng inner hair cells na to. Hindi katulad na kapag loud na high frequency sound, ang papatayin lang niya is yung inner hair cells near the base. Okay? So, Doc, palaging frontliner itong inner hair cells near the base, yung for high frequency sound? Yes. If you're more than 20 years old, you cannot hear 20 kilohertz anymore. Simple as that. Unless you have lived in a environment na walang loudness, more than 120 decibels. Right now, the inner hair cell for 20 kilohertz is probably dead. Okay, if you're more than 20 years old, you've probably been exposed to an environment na more than 120 decibels, for example, yung sound. And as you grow older, it becomes worse. So, senior citizens, 60 years of living, okay, probably wala. 18 kilohertz, 19 kilohertz na lang yung naririnig nila na maximum. Okay? So, perilymph, again, is similar to ECF, high in sodium, endolymph, high in potassium. The sense of smell. Okay? Olfactory neurons are the only neurons capable of reproduction. Neurons are supposed to be permanent cells. They cannot reproduce. The sole exception is olfactory neurons. They can reproduce. Okay? The sense of smell will utilize type C nerve fibers, the slowest, least precise, least accurate. That's why the sense of smell can only detect presence or absence of odors. It cannot detect gradations. It cannot detect location. Kasi kung binigyan kita ng type A alpha dyan sa sense of smell, you can have gradations. Sir, may katabi is 10/10 bango, 1/10 baho. Okay? It can also detect location. Doc, I can smell someone is 100 feet, 200 feet away from me. In our evolution, we don't need that. We only need to detect whether something is present or absent in the vicinity. Okay? So, we evolve in such a way na, may kalaban, parating na. I don't know exactly where, but he's near. Okay? Or, may makakain. I don't know exactly where. Okay? Pero it's near. That's all we needed. So, we evolved to save on energy. We utilize type C for the sense of smell. The sense of taste, okay? So, taste receptors, take note, are not true neurons and are not synonymous with taste buds. Okay? Anterior 2/3 of the tongue is cranial nerve 7. Posterior 1/3 of the tongue is cranial nerve 9 and cranial nerve 10. Okay, so yung mga special sensations. Motor of the tongue is cranial nerve 12. Next, okay, in the tongue, there are taste receptors for sweet, umami, salty, sour, and bitter. Take note that the taste receptors are distributed all throughout the periphery of the tongue. Yung middle part ang actually tasteless. Okay? Take note that they're only in these areas more sensitive to particular regions. The tip of the tongue is most sensitive to sweet and umami. Sweet can be detected in the entire periphery of the tongue, but it's most sensitive at the tip. That's why when you lick an ice cream, you use the tip of the tongue and not the sides of your tongue. Okay? Sweet and umami is at the tip. Okay, sides, okay, is the best to detect salty and sour. Okay, and finally, the back of the tongue, that's the best to detect bitter. Among all the taste, we evolve to detect bitter the best. Okay, it's also no coincidence that it's most detected at the back to facilitate retching. Okay, six taste, trivial, fat. Okay, yun yung more or less accepted na may hindi lang lima ang taste. Okay, because fat is not umami, it's not sweet. Okay, it's a different taste, and evolution-wise, it helps for us to seek fat because it's high energy. Okay. Next, what is the effect of pathogens in producing fever? It will increase your interleukin-1, prostaglandins. It will increase the set point temperature, cause shivering, and vasoconstriction of blood vessels. Okay. Prostaglandin E1, prostaglandin E2. Okay, prostaglandin E1 will keep the ductus arteriosus open. Okay, but prostaglandin E1, prostaglandin E2 will keep the ductus arteriosus open. Prostaglandin E2 specifically is the one involved in fever. Okay, the one involved in fever. Mnemonic, prostaglandin E1. E1 mong bukas ang ductus arteriosus. Prostaglandin E2. E2 ang para sa fever. Okay? Take that with a caveat. Okay? Prostaglandin E1 and E2 will actually keep the ductus arteriosus open. Mas kilala lang yung prostaglandin E1. Prostaglandin E2 is the one specific for fever. Okay? The anterior hypothalamus is responsible for heat loss. Okay? Posterior hypothalamus is the one responsible for heat gain. Okay? Mnemonic. Okay? When it's hot, to remove the heat, you fan the anterior portion of the body. Anterior hypothalamus, heat loss, fan. Posterior hypothalamus, heat gain or heat conservation. When it's cold and you want to gain heat, you put on a jacket and you place a jacket first at the posterior part of your body, at your back. So jacket, heat conservation, posterior. Fan, heat loss, anterior. So those are mnemonics to help you. So that's it for neurophysiology. Sorry I spent a little bit more time with this one, okay, to cover yung parts din ni Dr. Prince Rubio from before, okay? Thank you so much. Let's now go to Module 3, Cardiophysiology, starting with our favorite Wigger diagram. So the Wigger diagram, again, it will tell you what happens in a single heartbeat, trying to relate heart sounds, ECG, ventricular volume and pressure curves, atrial and aortic pressure curves. There are 7 phases: atrial contraction, isovolumic contraction, rapid and reduced ventricular ejection, isovolumic relaxation, rapid and reduced feeling. Okay? So, let's discuss some questions asked in the previous med boards based on PHYSIOLOGY. So, in those 7 phases, which phase will the mitral valve open? So, the mitral valve will open actually during rapid ventricular filling. Okay, at the start of rapid ventricular filling. However, in PHYSIOLOGY, the answer that Dr. Costanzo chose was isovolumic ventricular relaxation. This is wrong, okay? Because isovolumic ventricular relaxation, all valves are closed, no blood is going in or out of the ventricles. So what Dr. Costanzo actually meant when she used that as an answer dun sa PHYSIOLOGY was the end of isovolumic ventricular contraction. That is where mitral valve will open. So hindi kasi naka-indicate whether start or end ng phase. So what Dr. meant here was at the end of isovolumic relaxation, which coincides with the start of rapid ventricular filling, doon nag-open yung mitral valve. Anong gagawin namin, Doc, pag sa board exams, okay, ang choice na nandoon is isovolumic relaxation o kaya rapid ventricular filling. Pagdating sa boards, you're going to choose this one, okay, as the correct answer if they got it from PHYSIOLOGY. So you can take a look at the main handout. Okay, yung question ng PHYSIOLOGY na nandoon, yung choices, if you recognize na galing siya sa PHYSIOLOGY, choose this one. However, take note kung ano talaga yung tama start of rapid ventricular filling, that's when the mitral valve will actually open. Next, among the 7 phases, the aortic pressure is highest when? Okay. So the one listed in Physio BRS is reduced ventricular ejection. That's actually not correct again. Technically, okay, if you look at the Wigger diagram that you have, aortic pressure and ventricular pressure are highest between rapid and reduced ventricular ejection. So yung pagitan ng rapid ejection and reduced ejection, doon highest ang aortic pressure, doon din highest ang ventricular pressure. However, for board exam purposes, okay, questions based on Physio BRS, choose reduced ventricular ejection. Okay? Ventricular volume is lowest in which phase of the cardiac cycle? Ito tama. Ventricular volume is lowest during isovolumic relaxation. If I change this, when is ventricular volume highest? So ventricular volume will be highest during isovolumic contraction. Okay, ventricular volume is highest during isovolumic contraction. Ventricular volume is lowest during isovolumic relaxation. So this is a nice summary table, okay, for the 7 phases: atrial contraction, isovolumic contraction, rapid and reduced ejection, isovolumic relaxation, rapid and reduced filling. Okay? So the P wave, take note, will precede atrial contraction. So medyo confusing yung isang quizmaster question. If I remember it correctly, someone asked, when will P wave occur? So let's organize this table nga. Isulat nyo yung term na preceded. Okay, so P wave precedes atrial contraction. QRS precedes isovolumic contraction. T waves precedes slow ventricular ejection. So nangyayari sila before those particular phases. Immediately before, the phase before. Okay? So this P wave, QRS, and T wave, nalagay siya sa table na to dahil sila ang triggers. What do I mean? Okay? So P wave will trigger atrial contraction. QRS will trigger isovolumic contraction, the contraction of ventricles. T wave will eventually trigger the relaxation of your ventricles. So S1 is caused by the closure of your AV valves. It will happen during isovolumic contraction. S2 is caused by the closure of your semilunar valves. It will happen during isovolumic relaxation. S3 happens during rapid ventricular filling. S4 during atrial contraction. A wave, C wave, and V wave. A for atrial contraction. C for contraction of ventricles. A V wave for venous blood. Going back to the atrium. So A wave, C wave, and V wave. A wave will happen during atrial contraction. C wave will happen during isovolumic contraction. V wave will happen during isovolumic relaxation. The incisorial dichrotic notch is the slight and transient increase in aortic pressure. So this will happen during isovolumic relaxation. In isovolumic relaxation, isovolumic contraction, in these 2 phases, all 4 heart valves are closed. In isovolumic contraction, ventricular pressure is increasing, but ventricular volume remains the same. Okay, because during this time, ventricular pressure is still less than aortic pressure. Okay, so during this time, ventricular pressure is less than aortic pressure. Okay, so hindi na i-eject yung blood. Okay, at rapid ventricular ejection, at the start of rapid ventricular ejection, ventricular pressure is now slightly higher than aortic pressure. Semilunar valves will open and there will be ejection of blood. Okay? In isovolumic relaxation, ventricular pressure is decreasing but ventricular volume remains the same because during this time, ventricular pressure is still higher than atrial pressure. Ergo, okay, blood in the atrium will not go to the ventricles. Okay, at the start of rapid ventricular filling, finally, atrial pressure is now slightly higher than ventricular pressure. AV valves will now open. Blood will now flow from atrium to the ventricles. I gave a much more detailed discussion of the cardiac cycle in the main handout and main lectures. There's even a QR code link for this one. So you can venture, okay, and take a look at that. Okay? So again, ano yung gusto kong tirahin dito? Ventricular pressure and aortic pressure are highest here between rapid and reduced ventricular ejection. Technically, yon. However, pagdating sa boards, okay, isagot niyo reduced ventricular ejection kung kinuha nila sa PHYSIOLOGY. Ventricular volume is highest during isovolumic contraction. Ventricular volume is lowest during isovolumic relaxation. Let's take a look at the ventricular pressure volume loop. Okay, in the x-axis, we have your left ventricular volume. Okay. And in the y-axis, we have your left ventricular pressure. Okay. So, take a look. From point 1 to point 2, this is basically isovolumic contraction because ventricular pressure is increasing. It's going up. But it's not going left or right. So it means yung ventricular volume is not changing. So this is isovolumic contraction. Point 2 to point 3 is basically ventricular ejection. Rapid and reduced ejection. Because you're going from 2 to 3, you're going to the left. So it means nababawasan yung ventricular volume. Point 3 to point 4 is isovolumic relaxation. Okay? It's isovolumic relaxation because ventricular pressure is decreasing, okay, but it's not going left or right, meaning the ventricular volume remains the same. And then finally, point 4 to point 1, so nag-i-increase yung ventricular volume, so this is your rapid and reduced feeling, okay? So with that in mind, let's discuss. Where is the isovolumic contraction? So isovolumic contraction is point 1 to point 2. Where does the aortic valve close? Okay. Ito yung mali again sa PHYSIOLOGY. Aortic valve, all 4 heart valves will actually be closed during the isovolumic phases. Points 1 to 2, 3 to 4. Okay. But if asked in the med boards, you're going to answer point 3. Okay. Where is the first heart sound heard? So the first heart sound is heard during isovolumic contraction. So in here, that will be point 1. Okay? Next, cardiac action potential. So your cardiac action potential, you have your phase 1, phase 2, phase 3, phase 4. Again, phase 0, 1, 2, 3, 4. Phase 0, this is your sodium influx. Phase 1 is potassium efflux. Phase 2, plateau, calcium 2 plus. We have calcium influx being equal to potassium efflux. Phase 3 is potassium efflux alone. Okay? Calcium channels are already closed during phase 3. And phase 4 is your RMP. So, where membrane potential is closest to the potassium equilibrium potential, that will be during phase 4, during your RMP. Okay? Remember, potassium equilibrium potential is negative 85 millivolts. Eh, yung RMP ng cardiac is negative 90 millivolts. So, doon closest yung potassium equilibrium potential. Calcium conductance is highest when? During phase 2. Okay, remember, phase 2, plateau, calcium 2 plus. And result of the inward sodium current, okay, so sodium causes depolarization, so this is phase 0. Not phase 1, okay, phase 0. Next. Compared to the SA node action potential, SA node action potential will only have 3 phases. Phase 4, phase 0, and then phase 3. Phase 4, okay, is your slow sodium influx. Okay, it happens using IF channels, your slow funny sodium channels. Okay, phase 0 is depolarization. This time caused by calcium influx. And finally, phase 3 is repolarization caused by potassium efflux. Okay, remember, the slope of phase 4 is the one that determines heart rate. Okay, the slope of phase 4 is not constant, kaya yan tinawag na unstable. Okay, the sympathetic nervous system stimulating the beta-1 receptors in this SA node will cause the sodium influx to become faster. Consequently, threshold is reached sooner. Consequently, the duration of the pacemaker action potential will become shorter because of sympathetic nervous system. So you will have more cycles per minute, tumataas yung frequency. So basically, with the sympathetic nervous system, tumataas yung heart rate. Okay? Parasympathetic nervous system will do the opposite. Okay? Yung slow sodium influx, mas lalo pa magiging slow. The duration of the pacemaker action potential will be longer. Consequently, with parasympathetic nervous system, okay, heart rate will decrease. Okay? Next, the ECG. The ECG describes the electrical activity of the heart. So the effect of decreased AV node conduction on the PR interval, the PR interval will increase. Rationale for the slow conduction through the AV node, what we call your AV nodal delay. This is to allow sufficient time for the filling of the ventricles. A previous board exam question. What is the basis, Doc? Bakit nagkakaroon tayo ng AV nodal delay? The reason for that is decreased gap junctions, decreased number of gap junctions in that area. This was by evolution to allow sufficient time to ensure din na basically yung atrium will contract first before the ventricles, allowing sufficient time for the filling of the ventricles. Ventricles are completely depolarized, during which isoelectric portion of the ECG. Okay, this will happen during the ST segment. Okay, so isoelectric portions is the PR segment and the ST segment. Segment 0. Okay, 0 millivolts, isoelectric. Okay, super basic questions. P wave is for atrial depolarization. QRS is ventricular depolarization, while T wave is for ventricular repolarization. Next, 70 kilogram male with an resting oxygen consumption of 250, arterial O2 of 20, mixed venous O2 of 0.15, heart rate of 72. What is the cardiac output and what is the stroke volume? So classically, you know, even from med school, that cardiac output is equal to heart rate times stroke volume. Okay? But you probably have forgotten that there's another way to compute for the cardiac output, and that is through your Fick equation. Fick equation, basically, oxygen consumption over the AV-O2 difference. Arteriovenous O2 difference. So that's the alternative way of computing for the cardiac output. Okay? So applied here, oxygen consumption over AV-O2 difference. Remember, the pulmonary veins will contain the oxygenated blood. Pulmonary artery, deoxygenated blood. So, ang mathematics niyan will actually be 250 over, 0.2 minus 0.15, giving you a value of a cardiac output of 5 liters per minute. Okay? Then, because you know already the value for cardiac output and you are given the heart rate, so you can now compute for the stroke volume. If cardiac output is equal to heart rate times stroke volume, then transmuted stroke volume now will be equal to cardiac output over your heart rate. So this will be 5 liters per minute divided by 72, giving you a stroke volume of 69.4 ml per beat. Next, computation once again. Increase in the ejection fraction causes a decrease in the cardiac parameter. So this is your end systolic volume. Explanation is in your main handout for this one. Wala dun sa choice yung end diastolic volume. Kaya ESV yung magiging best answer here. Ejection fraction, 0.4, heart rate 95, cardiac output of 3.5 liters. What is the end diastolic volume? So, way to compute for this one. Okay. Ejection fraction is equal to stroke volume over end diastolic volume. So transmuted, well, basically you have end diastolic volume being equal to stroke volume over ejection fraction. Okay? So, how do you compute now for the stroke volume here? Okay, so stroke volume will be equal to cardiac output over the heart rate. So this is 3.5 liters over 95, giving you 36.8. Once you have 36.8 as stroke volume, okay, and you are being asked for the EDV, so you just input the values. 36.8 8, your stroke volume, over the ejection fraction, which is 0.4, and you will get a value of 92 ml. This is a previous board exam question. Computations. Computations, in our experience, takot na takot yung mga estudyante. Pero actually, for physio, hindi kayo dapat matakot kasi yung computation nila, guys, hindi nila pinapalitan yung mga choices and answers. So actually, ang mga shortcut dyan, minsan yung ibang estudyante, minimemorize na lang yung talagang sagot sa physio BRS, 92 ml. Pag pinakompute ng EDV, for example, okay, they haven't changed the equations. They haven't changed the choices and the answers for formula questions in the physio med boards. So cardiac output equations are listed here. Stroke volume, EF, cardiac output, pulse pressure, and mean arterial pressure. It's listed also in your main handouts. Okay, so eto yun. Systolic pressure is your highest arterial pressure. Diastolic is your lowest arterial pressure. Pulse pressure is systolic minus diastolic. Or another way to compute pulse pressure is stroke volume. Ito yung tandaan niya for the exam. Over arterial compliance. So pulse pressure is stroke volume over arterial compliance. The higher the stroke volume, the higher the pulse pressure. The lower the arterial compliance, the higher the pulse pressure. As you grow older, ang pang-boards dyan, as you grow older, arterial compliance decreases, goes down. Therefore, as you grow older, pulse pressure increases. So as you grow older, arterial compliance decreases. It decreases because of arteriolosclerosis, the stiffening, hardening of the arteries from calcium deposits. Arterial compliance decreases as you grow older. Pulse pressure increases as you grow older. Okay? Most important determinant of pulse pressure is stroke volume. Formula for mean arterial pressure is 2/3 diastolic plus 1/3 systolic, or diastolic pressure plus 1/3 pulse pressure. Normal pulmonary artery pressure, 15 to 25 over 8 over 10. Normal ratio of systemic to pulmonary pressure is 3:1. Synonymous with right atrial pressure is CVP. Measured using Swan-Ganz catheter estimates left atrial pressure. This is your pulmonary capillary wedge pressure. So pulse pressure is determined by which cardiac parameter? Well, the main determinant is stroke volume. Therefore, the answer is stroke volume. So this is a table comparing causes of widened pulse pressure and decreased or narrowed pulse pressure. They've been asked before in the med boards, this table. It's easy to forget them. So please an asterisk and add this to your last minute notes. Yung titingnan mo 30 minutes, 1 hour before the exam. Try and memorize this today. You will forget them because wala siyang silbi sa clinical practice talaga. Okay? So kakailanganin mo na talaga siya for the exam. So lagay mo siya sa short-term memory. Okay? In exercise among cardiac patients, cardiac output increases mainly secondary to an increase in stroke volume, and increases when CVP increases atrial natriuretic peptide. Okay? So most of your yellow boxes and yung mga additional notes ko na ganito are based on previous board exam questions na relatively trivial or crossover. Diyan ko siya sinilalagay. Okay? What describes the distensibility of blood vessels? This is capacitance or compliance. Capacitance is inversely proportional to elastance. If something is compliant, it's not elastic. Compliant, if I put pressure, nag-change ka kagad ng shape. The same way that a plastic toy balloon, if I blow air there, it's going to change its shape rapidly. It's compliant. Elastance, the complete opposite. If I try to change you, you will go back, the elastic, go back to your original shape. So elastance is stiffness, the complete opposite of compliance. Veins are more compliant than arteries. Ergo, okay, most of your blood is found in the veins and not in the arteries. 64% of your blood is actually found in the veins, not the arteries. Okay? Decrease in venous capacitance effect on unstressed and stressed volume. Unstressed volume, veins. Stressed volume, that's the blood in the arteries. So decrease in venous capacitance. Pag nag-decrease ang capacitance ng veins mo, it means na nag-shift yung blood from the veins to the arteries. So it will decrease unstressed volume and increase the stressed volume. Again, the unstressed volume is a term about blood in your veins, kasi mababa ang pressure doon, unstressed. While stressed volume is the blood in your arteries, kasi mas mataas ang pressure doon. Narrowing of the arteries will lead to how much decrease in blood flow. So, if you have attended the main lectures, main handouts, you know this. Doc, 1/16. Paulit-ulit kayo noon. Yes. Has something to do with the application of the law of Poiseuille, okay, and the Ohm's law. So, remember, tingnan mo, kapag itong R is the radius, big R is the resistance. So, kapag ginawa mong kalahati lang yung radius mo, dahil raised to the 4th power yan, resistance mo will increase by 16 times the normal value. So ngayon, yung blood flow mo will decrease by 1/16 because blood flow is inversely proportional to resistance. Okay, based on Ohm's law. Effect of TPR, total peripheral resistance on exercise. Okay, it's going to decrease your total peripheral resistance. What is synonymous with the term TPR? TPR, or total peripheral resistance, is synonymous with the term SVR, systemic vascular resistance. Okay? So, during exercise, the skeletal muscle arterioles dilate. So, yung TPR, SVR mo, bababa. Okay, as a response. So, the decrease in TPR, the vasodilation of skeletal muscle arterioles, is secondary to the release of vasodilator metabolites. It will cause vasodilation in the muscle arterioles, decreasing your TPR. Okay? During exercise, what happens? Okay? Put a check on the following. Heart rate, stroke volume, cardiac output, blood pressure will all increase. Makes sense, Doc? Because of beta-1 stimulation. Pulse pressure will actually also increase because of the increase in stroke volume. Total peripheral resistance will decrease because of vasodilation of skeletal muscle arterioles. And finally, AVO2 difference. The difference in the oxygen in the artery versus the veins, okay, it will increase dahil magiging mas oxygenated yung arteries mo. Mas nagkumukuha ng oxygen from the blood yung mga muscles. So, kapag dating sa veins, bumababa na siya. So, tataas to, bababa to, overall AVO2 difference will increase. Compensatory change in the carotid sinus during acute decrease in arterial blood pressure. This is your decreased firing rate of the carotid sinus nerve. So, remember, you have baroreceptors found in the carotid sinus and the aortic arch. They detect changes in pressure. Their stretch receptors, they detect changes in pressure. They send a constant signal, a constant firing rate to the nucleus tractus solitarius, the NTS. Okay? Found in the medulla. Okay? Ngayon, kapag halimbawa, nag-bleeding ka, bumaba yung blood pressure mo, bumababa yung stretch doon sa carotid sinus baroreceptor. So, ano mangyayari? Yung signal na pinapadala niya, yung ping, 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 papunta sa NTS, bumabagal. Ping, ping, ping. So, NTS will detect that decreased firing rate and interpret that as bumaba yung heart rate. Okay? Bumaba yung blood pressure. So, ano magiging response ngayon sa mababang blood pressure ng NTS? It will stimulate sympathetic nervous system. That will now increase the heart rate, ventricular contraction, vasoconstrict the veins, vasoconstrict the arterioles. End of the day, all of these effects will increase the blood pressure back to normal. Okay? Status post sympathectomy. Tinanggal mo yung sympathetic nervous system, yung sympathetic chain, sympathetic fibers. So, he experiences a great fall in the arterial pressure when standing up. So, what is the explanation for this? So, press response of the baroreceptor mechanism. So, the sympathetic nervous system, you need it here. Okay? So, ang nangyari dito, kapag nag-sympathectomy ka na, parang wala na yung mga effectors mo. So, hindi mo na magawa yung increased sympathetic outflow. So, ano mangyayari, Doc? babagsak yung heart rate and BP. Nung bumagsak yung heart rate and BP mo, nawalan ka ng malay. Okay? So, or matutumba ka talaga kasi not enough blood pressure. Okay? Next, 24-year-old with severe diarrhea. Okay? Supine pressure, 90/60. Supine heart rate, 100. Standing heart rate now becomes 120. So what causes the further increase in heart rate upon standing? Okay? The triggering of the baroreceptor reflex. So decreased arterial pressure will increase the heart rate in a supine individuals from 100 to 120. The increase now, that will basically increase your BP, hopefully back to normal. Next, Starling equation. A previous board exam question. So capillaries are found between arteries, arterioles, and veins. Your capillaries will have an arteriolar end near the arterioles and a venous end. Ngayon, ang ginawang question dun sa medboard since sa Physio BRS, tinanong nila, okay, will there be filtration or absorption? So if you remember Starling equation, JV flux is equal to KF minus KF times capillary hydrostatic pressure minus interstitial hydrostatic minus capillary oncotic minus interstitial oncotic. So, you just apply the values supplied. Okay? Kapag positive yung JV mo, filtration occurred. Kapag negative yung value na nakuha mo, absorption occurred. So, at the arteriolar end, given these values, okay, look at your handout this time. So, if you input the values, this is 30 minus 0 minus 28 minus 4. So, you will get an answer of positive 6 millimeters mercury. So, positive number siya, filtration occurred. For the venous end, if you input the values, you will get a negative number. So, it means absorption occurred. A previous board exam question. Okay? So, fluid movement JV, if positive, again, there is filtration. If it's negative, there is absorption. And then finally, vasoconstrictors versus vasodilators. Vasopressin is the most potent vasoconstrictor in our physio textbooks. Surgery textbooks like Schwartz will tell you it's endothelin 1. Okay? But in physio kasi, endothelin 1 increases in ruptured blood vessels, only secondary to vasopressin stimulation then. So for us, vasopressin is the most potent vasoconstrictor of them all. Serotonin is also a vasoconstrictor that causes pain in migraine. Okay? Endothelin 1, released by ruptured blood vessels, by damaged endothelium. Yun yung ibig sabihin noon. Then we have thromboxane A2. Thromboxane A2 will cause vasoconstriction, and at the same time, it will cause platelet aggregation, increasing the chances of having strokes and MI. Vasodilators will include your prostacyclin, prostaglandin I2. Prostaglandin I2, okay, inhibits, neutralizes, antagonizes thromboxane A2. Nitric oxide, when you hear this, okay, associated with penile erection, associated with anong tawag dito? Sildenafil. So, involve ang nitric oxide dun sa mechanism yan. It's cyclic GMP mediated, nitric oxide. Okay? Nitric oxide is a gas synthesized as needed. It's a vasodilator. Okay? Vasodilator. Involved in penile erection, involved in sildenafil. Prostaglandin E1, prostaglandin E2 are vasodilators. Lactic acid will cause vasodilation in the skeletal muscle arterioles. Lactic acid is produced by anaerobic glycolysis. Okay? H+, carbon dioxide, potassium, and ANP are also vasodilators. Okay? Coronary blood flow, ano yung kailangan yung tandaan dito? Check this one. The coronary blood, when the cardiac muscles contract, they compress on the coronary vessels. That's why yung heart will only get its oxygen, will only get its blood supply, okay, during diastole, not during systole. During systole, there's compression of the coronary vessels. Cerebral blood vessels have autoregulation. They are, please ang pinakakialaman ng sympathetic parasympathetic nervous system. Okay? Vasoactive metabolites will include H+, carbon dioxide. Okay? For the muscles, vasodilator metabolites will include lactic acid, potassium, and adenosine. Skin, okay? Skin arterioles vasodilate if you want to lose heat. Skin arterioles vasoconstrict to shunt blood towards the core of the body when it's cold. Okay? So skin, namumula ka, skin arterioles will vasodilate pag mainit. Namumutla ka, okay? Skin arterioles will vasoconstrict when it's cold. Okay? And that's it for cardiac physiology pearls. Thank you so much. Let's now go to respiratory physiology. So, some Q&A. Okay? Is trachea part of your upper airway or lower airway? A previous board exam question. So, the trachea is already considered part of the lower airways. So, the upper airways will include the nose, sinuses, and the larynx. Lower airways is from the trachea all the way to your alveoli. Function of sinuses, to lighten the skull and to offer resonance to voice. Okay? Another previous med boards question, which is the one capable of gas exchange? The terminal bronchiole or the respiratory bronchiole? So this is your respiratory bronchiole. Remember, there are only 3 areas in the respiratory system capable of gas exchange. Those 3, yan yung respiratory bronchiole, alveolar ducts, alveolar sacs. So everything from the nose to the terminal bronchiole, walang gas exchange. Ang tawag natin dun sa air, from the nose all the way to the terminal bronchiole, we call that your anatomic dead space. The normal value of anatomic dead space is 150 ml. Okay? Hyperplasia, hypertrophy in chronic smokers produces mucus. These are your goblet cells and submucosal glands. Goblet cells were called goblet cells because they literally would look like goblets or cups. Cups that contain mucus. The mucus is for lubrication of the respiratory epithelium. Okay? Pag dry air lang yung nandyan, tapos wala kang lubrication sa respiratory epithelium, it will excoriate the respiratory epithelium, destroying the respiratory epithelium. Next, what is the histologic type of your respiratory epithelium? So, probably something that's been asked ever since first year, pinukpok sa ating lahat. Pseudostratified ciliated columnar epithelium with goblet cells. Next, what do you call? Previous board exam question, non-ciliated cells in the respiratory epithelium. So, dapat may cilia yung respiratory epithelium, okay, to push the debris back to the mouth, where hopefully you'll be able to swallow that dust and debris to your stomach. So, non-ciliated areas, non-ciliated cells in the respiratory epithelium, okay, these are your club cells, also called Clara cells, after the Maxi doctor, Dr. Max Clara. The initiating stimulus of a sneeze reflex, a previous board exam question, relatively easy, irritation of the nasal passageways. Next, what is the total gas exchange area? Another previous board exam question, 70 to 85 square meters. Next, the type of pneumocytes or the type of alveolar cell that secretes surfactant. These are your type 2 alveolar cells or type 2 pneumocytes. And finally, what do you call the macrophages of your respiratory system? Another previous board exam question, pre-pandemic. We call them alveolar macrophages or, synonymous term, dust cells. Lung volumes and capacities. Remember our classic mnemonic, ITER 4, 3, 2, 1. Okay? So we have 4 lung volumes, IRV, TV, ERV, and RV. 3, the sum of the upper 3, IRV, TV, and ERV, that's your vital capacity. 2, the sum of the upper 2, the sum of the lower 2. Upper 2, IRV and TV is inspiratory capacity. ERV and RV, the lower 2 volumes, the sum of that, we call them FRC. And finally, 1, the sum of them all 4 lung volumes, that is your TLC, total lung capacity. Okay? So, the spirometer, take note, it measures exhaled air. It can measure directly everything except RV, okay, and anything with RV in its formula. So your spirometer cannot measure FRC. Your spirometer cannot measure TLC. Okay? The one that can be directly measured by your spirometer, that is anything, any volume, any capacity other than these three. RV, FRC, and TLC. Hindi niya mami-measure directly. However, it can measure, okay? It can measure it indirectly, these three, okay, by calculating from the lung volumes. Okay? Next, let's identify the following. The lung volume that cannot be measured directly by spirometry, this is your residual volume. Okay? Residual volume is the amount of air remaining in the lungs after maximal exhalation. So, hindi na siya na-exhale, hindi na yan mami-measure ng spirometer. Kasi ang spirometer can only measure exhaled air. Next, the volume of air inspired or expired with each normal breath. That's called tidal volume. Approximate amount of your tidal volume is 500 ml. Yung 500 ml na yan divided into 2. 150 ml, 350 ml. 150 ml of that 500 is anatomic dead space, nose to the terminal bronchiole. 350 ml is the respiratory unit of the lung. So that's your respiratory bronchiole, alveolar ducts, alveolar sacs. Okay? So, you will inhale 500 ml, exhale 500, inhale 500, exhale 500. Okay? Air that can still be breathed in after normal inspiration. So, the air from the top of your TV all the way up, okay? That is your IRV, inspiratory reserve volume. Remember, ITER, IRV, TV, ERV, RV. So, above that tidal volume, yung pwede mo papahinga after normal inspiration, okay, that's your IRV. Can still be breathed out after maximal expiration. So, at this point, if this is your tidal volume, yung amount of air na may inhale, may exhale mo pa from this point up to this point, that is your ERV, expiratory reserve volume. Air that remains in the lungs after normal expiration, okay, I didn't say volume, I said air. So this can refer to either volume or capacity. Air that remains in the lungs after normal expiration, that is your FRC. Doc, bakit naging FRC? ITER. Okay? Vital capacity, respiratory capacity, FRC, TLC. So at the end of normal expiration, so if this is your tidal volume, the air from this point up to this point is basically ERV and RV. ERV and RV is your FRC. So, previous board exam question, the air that remains in the lungs after normal expiration, that is your FRC. Air in the lungs after maximal expiration. So, if this is your tidal volume, nag-exhale ka pa, ang matitirang hangin na lang dyan is this part, your residual volume. Okay? And finally, the volume of air utilized for continuous gas exchange in between breaths. So that is your RV, residual volume. Volume that remains in the lungs after tidal volume is expired, FRC, similar to the question earlier. Air that can still be breathed in after normal expiration. Okay? So can still be breathed in after normal expiration. So it's referring to basically ERV and RV. Can still be breathed in after normal expiration. So this is IRV and tidal volume. So that is your inspiratory capacity. And finally, the volume of gas present in the lungs after maximal inspiration. Okay? So that is your total lung capacity. Maximum volume of gas that can be expired after maximal inspiration. So huminga ka maximally, and then nag-exhale ka maximally, yung may exhale mo will be vital capacity. Maximum volume of air that can be inhaled or exhaled, that's also your vital capacity. So parang lahat ng permutations, Doc, tinira nyo na regarding the lung volumes and capacity. So well, basically that's it. Okay? Very helpful, okay, for you to remember that mnemonic. ITER 4, 3, 2, 1. You're expected to be able to write this diagram. Okay? Vital capacity, upper 3. Inspiratory capacity, IRV and TV. FRC is ERV and RV. And then 1, everything is called, all 4 lung volumes collectively are called total lung capacity. The normal value of total lung capacity is approximately 6 liters. Will vary according to the reference again that you use. Some will say 5.9, 5.8, others 6.2. So for physio teachers, it's basically 6 liters. Okay? Next. Descriptions about each tidal volume, IRV, ERV, and RV are in your PEARLS handout, also in your main handout. Natira at na-discuss na naman natin yung mga pinaka-importante. So we'll skip this portion. Okay? Pang boards. Take note, all physio-normal values are lower in female in comparison to the male. There are only 2 physio-normal values that are higher in female compared to male. That is fat percentage and life expectancy. Everything else, including hemoglobin, hematocrit, lung volumes and capacities, cardiac output, everything else, all physio-normal values are lower in females. So lung volumes and capacities, previous board exam question, are 20 to 25% lower in females. Next, another previous board exam question. If a person is at rest, arrangement of lung volumes and capacities from highest to lowest will be, highest will be total lung capacity, approximately 6 liters. And the lowest will be tidal volume, approximately 500 ml. Another previous board exam question taken from Physio BRS. So you also see this in the main handout. If you have a 35-year-old male, given the following lung volumes and capacities, vital capacity of 5, tidal volume of 0.5, IC of 3.5, FRC of 2.5, what is the ERV? So basically, kung alam mo yung ITER 4321, okay, mako-compute mo yan basically by substituting values and simple addition and subtraction. So you can track the computation using the main handout. Actually, pwede nyo nang gawin dito, exercise, computin nyo kung bakit naging 1.5 liters yan using just this diagram. Kaya siya guys. Kaya nyo actually ma-deduce lahat ng lung volumes and capacities given these values. Next, a favorite in the med boards. Okay? Low FEV1, low FVC. FEV1 is less than FVC. High FRC. What is the lung disease? Is it an obstructive or restrictive lung disease? It's an obstructive lung disease. Okay? While kapag yung FEV1 is greater than FVC, okay? What is the lung disease given all the others are the same except FEV1 is greater than FVC and there is a low FRC. So this is restrictive lung disease. Okay? Obstructive versus restrictive lung disease. In obstructive lung disease, the best examples are asthma and COPD, emphysema, chronic bronchitis. Restrictive lung disease, the best example is lung fibrosis. So many ways, synonymous with lung fibrosis, honeycomb lungs, end-stage lungs. Okay? Basically, pag nagpipeklat ang lungs. Okay? Cirrhosis is to the liver, what fibrosis is to the lungs. So, obstructive lung diseases versus restrictive lung diseases. Obstructive lung disease, the problem is expiration. Hirap ka mag-exhale. Like for example, ang patients with asthma, problema nila hindi inspiration. They can do that. Their problem is expiration. Hindi sila maka-exhale properly. Restrictive lung disease, Okay? The problem is inspiration. Hirap silang mag-inhale. Okay? So, very important table. Okay? Obstructive versus restrictive lung disease. Obstructive lung disease, OLD. Restrictive lung disease, RLD. Okay? If you take a look, forced expiratory volume in 1 second, forced vital capacity, okay, measured using a spirometer, is decreased in both obstructive and restrictive lung disease. However, the magnitude is different. Obstructive lung disease, mas malaki yung pagbagsak ng FEV1. Restrictive lung disease, mas malaki ang pagbagsak ng FVC. Ergo, mathematically, because FEV1 decreases more than FVC, the FEV1-FVC ratio, dahil mas malaki ang binagsak ng numerator kaysa denominator, the ratio will decrease in obstructive lung disease. Compare that with restrictive. In restrictive, mas malaki ang binagsak ng FVC kaysa sa binagsak ng FEV1. If your numerator and denominator both decrease, pero mas malaki yung bagsak ng denominator ng FVC, the quotient will result in an increased FEV1-FVC ratio. Okay? Now, for the other parameters, residual volume, FRC and TLC are increased in obstructive lung disease. What's happening, Doc? Air trapping. Okay? For example, in asthma, you may bronchoconstriction ka doon, tas may mucus plug production, there's trapping of air. Hirap ka mag-exhale. Air is trapped. In COPD and emphysema, okay, air is trapped also. Okay? In emphysema, basically, kulang yung gas exchange, sira yung alveolar walls, they will contain more air, but the air cannot undergo gas exchange. So it just remains there. There's air trapping, increasing the RV, FRC, TLC, causing you to have hypoxemia, hypoxia because it's not undergoing gas exchange in the pulmonary capillaries. Restrictive lung disease, hirap ka mag-inhale, di ba? So wala talagang hangin papasok. You will expect your residual volume, FRC and TLC, to all decrease. Okay? So, very important table. This is a table that you don't utilize as a last minute note. Kailangan naintindihan mo yung principle as early as now kasi clinically relevant din siya. Hindi lang siyang board exam relevant. Decreases the airway radius by a factor of 4. What is the effect on resistance and airflow? Okay, so resistance will increase by a factor of 256. Airflow will decrease by a factor of 256. So, paano na-compute yun, Doc? Resistance here will utilize once again the law of Poiseuille. So, resistance is equal to 8 and L over pi r raised to the 4th power. So, basically, if you have your r raised to the 4th power here and you decrease it by 1/4 by a factor of 4, so basically, 1 over 4 times 1 over 4 times 1 over 4 times 1 over 4. Okay, 4 times 4 times 4 times 4. 4 times 4, 16. 16 times 4, 64. 64 times 4, 64 times 4. So that is 256. So your resistance will increase by a factor of 256. And because airflow and resistance are inversely proportional, so airflow will decrease also by a factor of 256. Okay? What happens to the net diffusion of oxygen when the partial pressures of oxygen in the alveolar air and pulmonary capillary are equal? So this is a condition that we call equilibration. Nag-equilibrate. Okay? Remember, gas molecules will always move from high pressure to lower pressure until mag-equilibrate sila, until maging equal sila. So kapag yung oxygen mo mataas sa isang compartment, halimbawa sa alveoli, tapos mababa siya dun sa pulmonary capillaries, yung oxygen mo mag-move from alveoli to the pulmonary capillary until mag-equilibrate. Once they are already equal, yung partial pressures ng oxygen in both alveoli and pulmonary capillary, there is no more net diffusion of oxygen. Okay? So the diffusion rate of oxygen and carbon dioxide are dependent on the partial pressure differences across the membrane and the area available for diffusion. Remember what I told you during my main lectures. Okay? Air and blood will always flow from high pressure to low. Okay? Air and blood will always flow from high pressure to low. Okay? Expected alveoli finding in an infant born prematurely with neonatal RDS. So in this patient, okay, you're going to expect a collapsed alveoli. Okay? Collapsing pressure is equal to 2 times the surface tension T over the radius R. So, ang mga premature na babies, malas nila kasi ang surfactant, ang surface tension nila sobrang mataas. Okay? Dahil immature pa yung surfactant level nila. So, surface tension nila will be high because they have immature surfactant production. So, surface tension T will be high. At the same time, because they are premature, their alveoli is very small, smaller than normal neonate. So you expect the radius now to be smaller than usual. So mababa ngayon yung denominator mo. Pag tumaas yung numerator, bumaba ang denominator, boom, sobrang taas ng collapsing pressure. So expect collapsed alveoli in patients with neonatal RDS. Next, hypoxia will cause vasoconstriction in the vascular bed. In this vascular bed, so you actually have two choices here: systemic arterioles and pulmonary arterioles. So hypoxia in systemic arterioles will cause vasodilation. But hypoxia in pulmonary arterioles, the effect is vasoconstriction. So hypoxia will cause vasoconstriction in which bed? Your pulmonary arterioles or your pulmonary vascular beds. It's a fancy way of describing okay, your pulmonary arterioles. Next, the normal FEV1 FVC ratio is 0.8, 80%. Entirely by coincidence, the normal ventilation perfusion ratio is also 80%. V is ventilation, hangin. Q is perfusion, blood flow. Hindi na nila malagay yung P kasi P is already symbolizes pressure for most formulas. So they took the letter after P, which is Q. Q is perfusion in this case. Ventilation and perfusion matching is important to achieve the ideal exchange of oxygen and carbon dioxide. Pag mataas ang VQ ratio, mataas ang gas exchange. Okay? If this is the alveoli, and if this is the pulmonary capillary, oxygen will go more towards the pulmonary capillary. Carbon dioxide in the blood, pulmonary capillary, will then go more to the alveoli. Nangyayari ito kapag mataas ang ventilation-perfusion ratio. Ventilation itself is not important. Perfusion itself is by itself not important. It is the ratio, okay, the relationship which is more important. The ventilation-perfusion ratio. Pang boards. If we divide the lungs into three areas: base, middle, and apex. Okay? Ventilation alone, perfusion alone, is highest in the base. If you compare apex, middle, base, ventilation alone, perfusion alone, highest in the base. However, okay, their ventilation-perfusion ratio, which basically describes efficiency of gas exchange, is highest in the apex. And because highest sa apex ang ventilation-perfusion ratio, dito pinakamaganda ang gas exchange. Ergo, tingnan nyo to, arterial PO2 is highest in the apex. Compared to the base, highest in the apex. Bakit, Doc? Okay? Highest dyan kasi yung oxygen na nasa alveoli mas nakakapunta sa pulmonary capillary. So, yung pulmonary capillary serving the apex, mataas ang arterial PO2 niya. At the same time, dahil maganda ang gas exchange sa blood vessels na nandun sa apex, the arterial PCO2 is lowest in the apex. Kasi yung carbon dioxide na nandito sa pulmonary capillary, natatanggal kaagad. In a very efficient manner, it goes to your alveoli. So yung alveolar Yung arterial PO2 mo dito sa pulmonary capillary, mababa. So, lowest ang arterial PCO2 dito sa apex. Again, ventilation, perfusion alone are highest at the base. Ventilation perfusion ratio is highest in the apex. Arterial PO2 is highest in the apex. Arterial PCO2 is lowest in the apex. So this assumes a relaxed state, standing position. Okay? If you have exercise, if you have a supine position, blood flow will equalize all throughout the lungs. So magbabago siya. This assumes what I just said here assumes a standing position, relaxed state. Okay? So where is blood flow highest in the standing patient? Base. Where is PCO2 in the lungs? Highest in the standing patient? Base. It's lowest in the apex. So the reasons why perfusion and ventilation are highest at the base are listed here. Something to do mainly with gravity. Okay? When you are standing. Again, apex gas exchange is more efficient. That implies a high ventilation perfusion ratio. Total opposite for that of the base. In which ventilation perfusion defect is supplemental O2 beneficial? Oxygenation. Important. Given the following choices: A. Low ventilation perfusion ratio. B. High ventilation perfusion ratio. C. Ventilation perfusion ratio of 0. Or D. Ventilation perfusion ratio that is infinite. Pag infinite, it means yung Q mo is equal to 0. Okay? Pag ventilation perfusion ratio is equal to 0, okay? It means yung V mo is equal to 0. Okay? So, in which case is oxygen supplementation beneficial? Low VQ ratio. Okay? Pag mababa yung V at meron ka pang Q. Kasi kapag binigyan mo ngayon ng oxygen, tataas yung V mo, tataas ngayon yung ventilation perfusion ratio mo. Doc, the lowest possible V is 0. So, bakit hindi ventilation perfusion ratio na 0 ang sagot dito? Kasi kung ang V mo 0, it means wala ka ng way para ma-oxygenate yung blood. Halimbawa, meron ka dyang matindi-tinding very large mucus plug. So, yung VQ ratio mo na 0 to that particular area of the lung, oxygen will not be useful. Kasi it will not be, there's no way. It's blocked. It's completely blocked. Hindi na yan pupunta doon sa blood for that particular region of the lungs. Okay? So, a ventilation perfusion ratio of 0, we call that condition a shunt. Okay? Bakit shunt, Doc? Because hindi naman uniformly 0 ang ventilation perfusion ratio sa lung. So, ibig sabihin nito, kung ma-entire lang, part lang dyan ang may ventilation perfusion ratio na 0. So, ang mangyayari, yung blood flow mo, dahil completely wala kang hangin dito na block, it's going to be shunted towards better ventilated areas. Okay? Next, ventilation perfusion ratio that is infinite. It implies that Q, your perfusion, is equal to 0. Any number divided by 0, if you do that sa calculator, mag-error yung calculator mo. So dito ang reporting ng infinite, that's basically an error in mathematics. So this can happen, for example, if you have pulmonary embolism. So, shunt, example is an airway obstruction like a mucus plug. Okay? Dead space, VQ na infinite, this can happen pag block naman yung blood flow. So, this can happen, for example, in pulmonary embolism. If you have a patient with pulmoembo, with complete blocked blood flow to the left lung, what is now the effect of alveolar PO2 on the left lung? Okay? Alveolar PO2 on the left lung will be approximately equal to the PO2 in inspired air. Doc, di ko na gets. Hindi, itong alveolar PO2 mo, hindi na makakapag-equilibrate with the blood. Kasi may complete blocked blood flow eh. So, saan makikipag-equalize siya ng pressure? Inspired air na. Okay? Again, this is something to do with the fact that there is no blood flow to the lung, no gas exchange now will happen between alveolar air and pulmonary capillary blood. So instead, alveolar PO2 will just equilibrate with the preceding passageway. So it will equilibrate with the PO2 in inspired air. Next, intrapleural pressure. So you have your visceral and parietal pleura of your lungs. There's an intrapleural pressure sa pagitan nila. So what happens during inspiration? When you inhale, intrapleural pressure becomes more negative. Okay? Alveolar pressure becomes more negative. Okay? When that happens, because now alveolar pressure is less than atmospheric pressure, air is expected to move from the atmosphere to your alveoli. Air and blood will only flow from high pressure to low. If you want air to flow into your alveoli, dapat mas mababa ang alveolar pressure kesa atmospheric pressure. So, ang gimmick ng katawan, when you contract now your diaphragm, okay, the thorax will move upward, okay, and forward, increasing both the height and the antero-posterior diameter. That bony thorax, okay, is attached to your parietal epithelium. Okay, it will now cause a suction cup effect on the. That bony thorax has your parietal pleura. It will cause a suction cup effect on the visceral pleura. The visceral pleura, that's the one tightly attached to the lungs. So, ang nangyayari, when you inhale, okay, nahatak ng bony thorax basically yung lungs. Okay, so magmo-move, okay, forward. And then yung contraction ng diaphragm will cause naman yung height ng lungs to change. So when that happens, intrapleural pressure decreases, alveolar pressure decreases, air goes into the lungs, air goes from the atmosphere to the alveoli, okay, causing the increase in lung volumes. Okay? So it becomes more negative, their intrapleural pressure during inspiration. Strenuous exercise causes the O2 hemoglobin dissociation curve to shift to the right or to the left. Of course, doc, to the right. We know the formula. We know the mnemonic, doc. Kabit. Do the right thing. Let go. Kabit. An increase in your kabit will cause a shift to the right. And shift to the right means hemoglobin will let go of oxygen. There is increased unloading of oxygen from hemoglobin. Ano uli yung kabit, doc? Carbon dioxide, acidosis, 2,3-biphosphoglycerate, exercise, temperature. Okay, what is common to all of these five? Common to an increase in your CO2, acidosis, 2,3-BPG, exercise, and temperature. Common to all of these five is hypoxia. Okay, it makes sense that when tissues are experiencing hypoxia, tumataas dapat ang unloading nila ng oxygen from hemoglobin. Okay, it makes sense that when tissues experience hypoxia, there is a shift to the right para ma-release ka agad ng hemoglobin yung oxygen, makapunta ka agad sa starving tissues. So exercise is shift to the right. Okay, high altitude. When you move to Colorado, 10,000 feet above sea level, that's even higher than Baguio. Okay, there's also going to be a shift to the right. Doc, why? Okay, when you go to places of high altitude, tumataas ang 2,3-biphosphoglycerate. And then, what's the effect of P50 when you have a shift to the right of the O2 hemoglobin dissociation curve? So P50, if you remember our physio lecture, this is the arterial PO2 in which there is 50% hemoglobin saturation. So the normal value of P50 is 25 millimeters mercury. When you have a shift to the right, it becomes more than 25. So previous board exam question, when you have a shift to the right, what happens to P50? P50 will go up. It will increase. Okay? So, take a look. This is the normal O2 hemoglobin dissociation curve. Okay? This is 50% hemoglobin saturation. If you look at the x-intercept here, this is 25 millimeters mercury. When you now have a shift to the right, this is now the 50% hemoglobin saturation, and this is now your new P50. This is greater than 25 millimeters mercury. So previous board exam question, again, P50 will increase when you have a shift to the right. Okay? Must know itong O2 hemoglobin dissociation curve. Favorite yan. Clinically relevant din siya. Gusto ko, pangarap ko for you guys, all guys and girls, everyone, is that once you have passed the med boards, you become residents, you become moonlighters, that you'll be able to teach the clerks and interns about the O2 hemoglobin dissociation curve. Okay? I truly believe that a good physician hindi lang niya alam mag-diagnose at mag-treat. Pero alam niya i-correlate yung basic sciences sa clinical sciences. Okay? So shift to the right, there is increase unloading of oxygen from hemoglobin. Shift to the left, there is increase binding of oxygen to hemoglobin. The one that causes the shift to the right, your kabit. The one that causes a shift to the left is an increase meanwhile. So shift to the left is caused by an increase in your carbon monoxide and fetal hemoglobin. So if you increase carbon monoxide, not dioxide, if you increase your fetal hemoglobin, shift to the left. Okay? Summary of respiratory responses to exercise. When you exercise, oxygen consumption will increase. Of course, Doc. CO2 production will increase because of increased metabolism. Of course, Doc. Respiratory rate will also increase to match oxygen consumption, carbon dioxide production. Of course, Doc. Now, arterial PO2 and PCO2 will not change in moderate exercise because of compensatory mechanism. Hindi ka dapat maging hypoxemic, hindi ka dapat magkaroon ng any changes sa arterial PCO2. Now, arterial pH, dahil hindi nag-change yung arterial PCO2 mo, in moderate exercise, dapat walang change sa arterial pH. However, strenuous exercise, when you have anaerobic glycolysis, you're going to produce, as a product of anaerobic glycolysis, lactic acid. Remember, ang glucose, dapat nako-convert mo yan ultimately into pyruvate and then acetyl-CoA. Pag kulang ka sa oxygen, nako-convert mo ang glucose into lactic acid. That lactic acid is an acid. So it can cause this metabolic acidosis. So it will decrease arterial pH. Okay? Venous, not arterial, venous PCO2 will increase because of increased metabolism. Pulmonary blood flow, cardiac output will increase. And finally, previous board exam question, the ventilation perfusion ratio, will become more evenly distributed throughout the lungs. This is something to do with an increase in V and an increase in Q. Okay? So, nag-increase sila parehas. Next, respiratory responses to high altitude. Okay? If you go to a place of high altitude, the problem is you're going to experience hypoxia. Manipis yung hangin eh. Konti yung oxygen dyan eh. So, pag pumasok yan, dahil because of the low pressure, makaka-experience ka rin ng low oxygen sa blood, hypoxemia, which will cause low oxygen sa tissues, hypoxia. So as a response, take a look. Bibilis ang paghinga mo, increase in respiratory rate. Pag bumilis yung paghinga mo, tataas ang arterial pH. You're going to have respiratory alkalosis. Hemoglobin concentration will increase. This is something to do with the increased RBC production, as a form of acclimatization. You'll have an increase in 2,3-BPG because 2,3-BPG is produced inside the RBCs. So if you have polycythemia secondary to the response to high altitude, tataas din ng 2,3-BPG. And because you experience hypoxia, the pulmonary arterioles will vasoconstrict. When they do, tataas yung pulmonary vascular resistance. The one that decreases in response to high altitude is arterial PO2. You're going to experience hypoxemia, and alveolar PO2. Hypoxia with decreased arterial PO2 and an increased AA gradient. Previous board exam question. So this is your right to left shunt, your ventilation perfusion defect, and your diffusion defect like fibrosis. So mababa na yung arterial PO2. The same time, tumataas yung AA gradient, meaning hindi mo na ipupunta yung oxygen from alveoli, yung capital letter A, yung hindi ma-transfer ang oxygen from the alveoli, papunta doon sa small letter A, sa arterial. So, tumataas dramatically yung difference ng alveolar and arterial PO2, yung AA gradient. So, the AA gradient, once again, is just the difference between alveolar PO2 and arterial PO2. The normal value is between 0 to 10. So, approximately 10. More than 10, you have increased AA gradient. This is seen in diffusion defect, like lung fibrosis, ventilation perfusion defect, and right to left shunts. Okay? So, hypoxemia is a decrease in arterial PO2, while hypoxia is a decrease in tissue PO2. Okay? Hypoxemia will lead to hypoxia, but not all cases of hypoxia comes from hypoxemia. Hypoxia will have hypoxemia as one cause, but it also has other causes listed here, like decrease in cardiac output, anemia, carbon monoxide poisoning, and even, previous board exam question, cyanide poisoning. Some computations from Fisher BRS, 62-year-old breathes a gas mixture containing 21% oxygen. So ABG revealed arterial PO2 of 60, so this is hypoxemia. Arterial PCO2 of 70, so more than 40, so this is hypercarbia. So what is the cause of his hypoxemia? For this patient, the cause of his hypoxemia is hypoventilation. Okay? Mabagal ang kanyang paghinga. Okay? Kaya nare-retain yung carbon dioxide, yung arterial PCO2 niya mataas. May carbon dioxide retention. At the same time, mababa yung arterial PO2 niya. So, hypoventilation is the answer here. Okay? Next, 12-year-old has a severe asthmatic attack with arterial PO2 of 60 and arterial PCO2 of 30 millimeters mercury. What is the explanation for the low PCO2? So, it's lower than 40. Normal arterial PO2 should be 100. So, mababa ang kanyang arterial PO2. Meron siyang hypoxemia. But at the same time, mababa ang kanyang arterial PCO2. 30 lang. So, what's the explanation for the low PCO2? Okay? It has something to do with hyperventilation. When you hyperventilate, it's because his arterial PCO2 is lower than normal because the hypoxemia, okay, that he is experiencing is causing him to hyperventilate. Nung nag-hyperventilate siya, nabawasan yung carbon dioxide sa blood, bumaba ang arterial PCO2. So, itong arterial PO2 mo is na 60, this is hypoxemia. Peripheral chemoreceptors, the main trigger, peripheral, not central, peripheral chemoreceptors, the main trigger is hypoxemia. Pag na-trigger ang peripheral chemoreceptors mo, the response is an increase in respiratory rate. So that increase in respiratory rate, that hyperventilation that will occur, will cause you to have carbon dioxide being removed more from the blood. It will go now to your alveoli, causing you to have a lower arterial PCO2. Okay? Treatment for a patient with asthma, of course, you give them beta agonist. Beta 2, adrenergic agonist to be more specific. Okay? So, in the control of respiration, again, the main respiratory center, dorsal respiratory group. Supplemental to your dorsal respiratory group, VRG, the ventral respiratory group. Okay? Pneumotax, your DRG and VRG are found in the medulla. Okay? Pneumotaxic and apneusic center, they modify the output of your DRG. Pneumotaxic and apneusic centers are found in the pons. Pneumotaxic center, para kay may pneumonia, mabilis ang paghinga. So the pneumotaxic center will increase your respiratory rate. The apneusic center, para kay may apnea, mabagal ang paghinga. So the apneusic center will decrease your respiratory rate. So pneumotaxic center is able to increase the respiratory rate by shortening the duration of inspiration. By shortening the duration of inspiration, more cycles are formed per minute, respiratory rate will increase. The opposite is true for apneustic. Yung apneusic center, pinapahaba niya yung duration of inspiration. Less cycles are formed per minute. Okay? Bababa ngayon ang respiratory rate. Stimulated by lung distension, initiates the Henning-Brewer reflex, a reflex to prevent over-distension of the lungs, preventing it from rupturing lung stretch receptors. Stimulated by leaf movement, causes anticipatory increase in the respiratory rate during exercise, joint and muscle receptors. Stimulated by noxious chemicals, irritant receptors, and found in juxtacapillary areas, responsible for the feelings of dyspnea. That's the mnemonic. Your J receptors, responsible for the feelings of dyspnea. Dyspnea. That's it for your respiratory physiology pearls. Thank you so much. Let's go to renal physiology now. Remember, again, the classic mnemonic 60-40-20-15-5 rule. Habado ka. 60-40-20-15-5 rule. Anong ibig sabihin noon? Okay? So, 60% of your body weight is water. That's further divided into two, ECF and ICF. So, 40%, okay, 40% of your body weight is ICF. Then, 20% of your body weight is in the ECF. So, 40 plus 20, 60. Ngayon, itong 20% na to can further be divided into two. Okay? 75% of that ECF is your interstitial fluid. So, 75% of 20, that's 15% of your body weight. That's interstitial fluid. And then 25% of your ECF is plasma, the water component of blood, the liquid component of blood. So, 25% of 20, that is 5% of your body weight, okay, is found in plasma. So, 60, 40, 20, 15, 5 rule. Okay, 60% of your body weight, tubig. 40% ng body weight mo, nasa ICF, okay, found inside the cells, the trillions of cells that you have. 20% of your body weight is in the ECF, divided into two, IF and plasma. 15% of your body weight is in the interstitial fluid, and 5% of your body weight is in plasma. Normal blood volume, 5 liters. Contrast that to air. Normal value of your total lung capacity, 6 liters. Okay? We have here indicator molecules that will help determine the volume, your total body water, the volume in your ECF, the volume in plasma, the volume in your interstitial fluid and ICF. If you know the amount and you know the concentration of these volume markers, you will be able to compute for the various components listed here. So for example, titrated water is a volume marker for total body water, a previous board exam question. Mannitol is a volume marker for ECF. Risa in Evans Blue is a volume marker for plasma. So let's answer the following. Distributed, whatever water is found, what is a marker for total body water? A previous board exam question, titrated water. A large molecule that cannot cross the cell membrane, it is a marker for ECF. So this is your mannitol. A dye that binds to serum albumin and is a marker, volume marker for plasma. So that is your Evans Blue. So a previous board exam question, how do you actually do the computation, Doc? You need to know the amount and you need to know the concentration. 1 gram of mannitol was injected into a person. Plasma mannitol concentration is 0.08. But 20% of the mannitol that was injected was excreted into the urine. So the actual amount of mannitol in the blood is 1 gram minus 20% of 1 gram, 0.2 grams. So this will give you an amount of 0.8 grams, okay, doon sa blood, and a concentration of 0.08 grams per liter. So amount over concentration, 0.8 divided by 0.08 will give you 10. So 10 liters, okay, ang kanyang, ano yung for mannitol dito? ECF volume. Okay? Next, clearance equations. So again, clearance is equal to UV over P. Okay? Urine concentration, U. Urine flow rate, ang bilis ng pag-ihi, urine flow rate, V. And finally, plasma concentration, P. So given the following, urine sodium of 700, plasma sodium of 140, urine flow rate of 1, what is the clearance of sodium? So this is 700 times 1 divided by 140. So 700 times 1 divided by 140. So this will give you 5 ml per minute. Okay? Next, the nephron. Again, very quick review. Nephron is the structural and functional unit of the kidneys. It comes in two types. Majority is cortical nephron, okay, found in the renal cortex. Second type is juxtamedullary nephron, found in the corticomedullary junction. The cortical nephrons will have peritubular capillaries whose interstitial cells in these peritubular capillaries will secrete EPO. Juxtamedullary nephrons, meanwhile, you're going to see their vasa recta. This vasa recta will act as countercurrent exchangers. Okay, maintaining the graded osmolarity in the renal interstitium. Okay, the nephron has two major parts: an initial filtrating segment that we call the renal or Malpighian corpuscle, and a renal tubular system. In the renal corpuscle, this is where filtration occurs. In the renal tubular system, this is where reabsorption and secretion occurs. So that renal corpuscle, okay, what will you find there? In the renal corpuscle, you're going to find the afferent arteriole, the glomerulus or glomerular capillaries, and then the efferent arteriole. Okay? Then you're going to find there podocytes, okay? Also called your visual epithelium. You're going to find there intraglomerular mesangial cells, which basically acts as the similar to macrophages. Okay. Then you're going to find the JG apparatus. The JG apparatus, you have the macula densa, okay, found here in the walls of your distal tubule. This is your macula densa. And then in the walls of your afferent arteriole, you're going to find the JG cell. The JG cell, that's the one that will secrete your renin. JG cell secretes renin. Macula densa, okay, that's the one that detects changes in sodium concentration. Macula densa is found in the walls of the distal tubule, early distal tubule to be more specific, while the JG cell is found in the walls of your afferent arterioles. Okay? So the amount filtered per unit of time in the glomerular capillaries, the amount that goes out from the glomerular capillaries to the Bowman space, okay, we call that amount filtered, they call that filtration. Okay, yung movement from glomerular capillaries to the Bowman space. The amount filtered per unit of time in the glomerular capillaries, that is now what we call GFR. Normal GFR is must know. 125 ml per minute. Okay? Converted, this is 180 liters per day. Okay? Renal tubular system is made up of the proximal convoluted tubule, the loop of Henle, distal tubule, and collecting duct. Quick review, the PCT is once again the workhorse of the nephron. Most of the reabsorption and secretion occurs here. This is where you reabsorb 66% of filtered sodium, potassium, water. PCT, this is where you reabsorb 100% of filtered glucose. You're going to reabsorb them using SGLT type 2. Okay? The PCT is also where you secrete para-aminohippuric acid. Okay? What happens in the PCT? In the PCT, you have isoosmotic reabsorption. You will reabsorb the same percentage kasi of sodium and water, 66%. Okay? Loop of Henle, you have descending limb and ascending limb of the loop of Henle. Descending limb is permeable to water, impermeable to solutes. Ascending limb is permeable to solutes, impermeable to water. Ascending limb, okay, a part here is called thick ascending limb of the loop of Henle. That thick ascending limb of the loop of Henle, that's where we're going to find the very famous sodium potassium 2-chloride symport, the one inhibited by furosemide. Okay? That tal of LH, because you can only reabsorb solutes, not water, it's also called your diluting segment. Okay? Because sodium is going to be reabsorbed, it's not going to be followed by water, so nagiging dilute yung content sa tal of LH. Then you have the distal tubule, divided into two: early distal tubule, late distal tubule. Early distal tubule, okay, it's called your cortical diluting segment because it's already found in the renal cortex. Okay, it also has properties similar to tal of LH. It can only reabsorb solutes, not water. So naging dilute yung concentration niyan because of sodium reabsorption mechanisms found in the early distal tubule. So the early distal tubule, another claim to fame is that this is where you're going to find your macula densa. While the late distal tubule, okay, this is where you're going to find your principal cells and your intercalated cells. Both principal and intercalated cells, if you remember, they are stimulated by aldosterone. And then finally, you have your collecting duct. The collecting duct, this is where ADH will exert its effects. ADH will insert aquaporin type 2 to cause water reabsorption. Okay? PCT, LH distal tubule, collecting duct, you have specific diuretics acting on them. PCT, this is where acetazolamide will exert its effects. Acetazolamide, side effect, remember, is metabolic acidosis. Remember the mnemonic acetazolamide. Furosemide, your loop diuretic will act on the loop of Henle, specifically the sodium-potassium 2-chloride symport. Okay? Thiazide diuretics will act on the distal tubule. Potassium-sparing diuretics like spironolactone, amiloride, and triamterene will act on the collecting duct. And finally, acting on almost all areas of the renal tubules, you have your mannitol. Basic movements. When you say filtration, again, it means movement from the glomerular capillaries to the Bowman space. When a substance is filtered, it's not automatically going to go to the urine because it can still be reabsorbed. Reabsorption. Substance was initially filtered. When a substance is then reabsorbed, it's going to move from the lumen to the interstitial space and then finally to the peritubular capillaries or vasa recta. So when a substance is reabsorbed, it's going to go to the blood. Secretion. Okay? Secretion, it was able to bypass filtration. So it's going to move from afferent to efferent arteriole. When you say secretion, you're going to move now from peritubular capillaries, okay, to the renal interstitium and then to the lumen of the renal tubules. When a substance is secreted, it's not initially filtered. When a substance is secreted, you're going to find it in the urine. When a substance is reabsorbed, you're going to find it eventually in the blood. It's reabsorbed back to the blood. When a substance is secreted, it's going to be secreted into the urine. And then excretion, when you say excretion, it's the amount filtered minus the amount reabsorbed plus the amount secreted. Okay, different substances will have different basic movements. Glucose, for example, is filtered, 100% reabsorbed. It will therefore have the lowest clearance, a clearance of 0. When you say clearance, you clear the blood of something. Okay? So, it then goes to the urine. So, kapag mataas yung clearance, nakikita kita sa urine. Pag mababa ang clearance, hindi kita nakikita sa urine. Hindi ko na-clear yung blood, nasa blood ka. So, glucose, because it's filtered, 100% reabsorbed, never secreted. Okay? Normally, all of your glucose will go back to the blood. 0 clearance. Contrast that with para-aminohypuric acid. It's filtered, secreted, never reabsorbed. So it will have the highest clearance. Kasi wala kang reabsorption, yung naka-escape ng filtration, nase-secrete. Okay? So clearance of para-aminohypuric acid will be used to estimate for renal blood flow, renal plasma flow. And finally, inulin and creatinine. They are filtered alone. Never secreted, never reabsorbed. So the clearance of inulin and creatinine can be used to estimate for GFR. Different substances will have different clearances. The one with the highest clearance is para-aminohypuric acid. The one with the lowest clearance, a clearance of 0, is glucose. Remember this mnemonic. In a patient with a high potassium diet, okay, the relative clearances are listed here. Okay, the mnemonic is PAC, syunga. PAH, okay, CIUNGA, PAC, syunga. Para-aminohypuric acid will have the highest clearance. Glucose will have the lowest clearance. Inulin and creatinine will be somewhere in between. Computation. Inulin is infused in a patient. Plasma concentration, urine flow rate, and urine concentration are listed here. So just do the math, UV over P, and you will get 120 ml per minute. Okay? Mathematics, GFR is 120 ml per minute, plasma glucose concentration 400, urine glucose concentration of 2,500, urine flow rate of 4. What's the clearance rate? So, for glucose, UV over P, so U is 2,500, V is 4, P is 400. So, it's 25 times 4 divided by 400, giving you a value of 25 ml per minute. Okay? Now, given the following values, urine flow rate of 1, plasma pH of 1, urine pH of 600, hematocrit of 45%. What is the effective renal blood flow? Okay? So, renal blood flow here, the computation is renal plasma flow over 1 minus hematocrit. So, renal plasma flow is computed for the clearance of pH. So, U is 600, V is 1, P is 1. So, clearance of pH is 600. So, renal blood flow now is equal to 600 over 1 minus the hematocrit of 0.45. So, this is 600 minus 0.55, giving you a value of 1091 ml per minute. What happens to the filtered load of sodium if GFR spontaneously increases? It will also increase. The filtered load of sodium will also increase. Given the formula, filtration fraction equals GFR over RPF. If you dilate your afferent arteriole, glomerular capillaries, efferent arteriole. If you dilate your afferent arteriole, there will be more blood going to the glomerular capillaries. Yung glomerular capillaries mo, hindi naman yan nagdadilate eh. Capillaries yan, wala yan tunica media, wala yan smooth muscles. So, tataas yung glomerular capillary hydrostatic pressure. Pag tumaas to, tataas ngayon ang GFR. So, when you vasodilate your afferent arteriole, GFR will increase. At the same time, renal plasma flow is basically blood flow. So, nagdilate ka ng arteriole dito, so tataas din ang renal plasma flow. So, if you dilate the afferent arteriole, both GFR and renal plasma flow will increase. Okay? Table found in your main handout, found in Physio BRS. Okay? Let's take one example. If you vasoconstrict your efferent arteriole naman, what will happen? If you vasoconstrict your efferent arteriole, okay, blood will be trapped in the glomerular capillaries. GC hydrostatic pressure will increase, GFR will increase. So, tataas ang GFR if you vasoconstrict your efferent arteriole. At the same time, because you vasoconstricted a blood vessel, we expect blood flow to decrease and renal plasma flow to also decrease. So, what's the effect now on filtration fraction? Filtration fraction is again a formula, GFR over RPF. So, in this case, if you vasoconstrict the efferent arteriole, the GFR will increase, but the renal plasma flow will decrease. If the numerator increases and the denominator at the same time decreases, it will produce the highest possible quotient. Vasoconstriction of efferent arteriole. Okay? So, insulin deficiency, beta-adrenergic, antagonist, acidosis, cell lysis, hyperosmolarity. What will it cause? Hyperkalemia, hypokalemia. It's going to cause, okay, hyperkalemia. Okay, it will cause potassium to shift out of the cell. Insulin deficiency will do that because insulin normally, if it's not deficient, it's going to cause potassium influx. So, it's going to cause plasma potassium levels to decrease. So, if you have insulin deficiency, it can lead to hyperkalemia. So, very nice table showing you the causes of potassium efflux and potassium influx. Causes of increased potassium secretion in the distal tubules are listed here. High potassium diet makes sense that If you eat plenty of bananas, for example, why won't you die of hyperkalemia? Dahil tumataas din ang potassium secretion to the urine. Okay, hyperaldosteronism. Okay, if you one of the effects of aldosterone is potassium secretion. Ergo, for example, if you have Conn's syndrome, a tumor producing large levels of aldosterone, we expect more than the usual na potassium secretion. Okay? Other causes of increase and decrease potassium secretion are listed here. Is secretion synonymous with excretion? No. When you say excretion, again, it's the amount filtered minus the amount reabsorbed plus the amount secreted. Sodium, for example, is filtered, partially secreted, partially reabsorbed. So the total excretion of sodium will depend on filtration of sodium minus reabsorption of sodium plus the secretion of sodium. If you deprive someone of water, tumataas ang kanilang plasma osmolarity. Okay? Because you sweat all the time, you don't drink water, the water that's lost through sweat is not replaced, plasma osmolarity will become more than 300 milliosmoles per liter. The increase in plasma osmolarity is the most potent trigger, okay, for ADH secretion. When ADH is now secreted, what will be the result? It will increase water reabsorption. When you increase the water reabsorption done through insertion of aquaporin type 2 in the collecting duct, okay, bababa na ngayon, hopefully, yung plasma osmolarity mo. At mag-i-increase na, hopefully ngayon, ang iyong plasma volume. Okay? Free water clearance. Okay, so again, free water is solute-free water produced in the diluting segments of the kidney, the tall of LH and the early distal tubule. Okay? When you don't have ADH, free water clearance is positive. When you have high ADH secretion, free water clearance is negative. Okay? Hindi, teka. Titignan ko lang kung tama yung ano ko dito. So, tama. Walang kailangan ayusin dito. I-cut mo na lang yung kung saan pumalakpak-palakpak to ka. So, pag mababa yung ADH, walang water reabsorption. Hindi mo ni-reabsorb itong free water na to. So, anong mangyayari? Yung free water mo, iihi mo. So, yung free water clearance will be high. It will be positive. Meaning, pumunta siya sa urine. Pag mataas ang ADH, yung free water, yung solute free water, na-reabsorb. So, yung free water clearance mo, mababa or negative. Kasi na-reabsorb siya, hindi siya nakita sa ihi. Okay? So, free water clearance, take a look at the formula. Okay? It's urine flow rate minus osmolar clearance. So, osmolar clearance, the formula is listed here. UV over P din siya basically. So, given the following values, okay, urine flow rate of V, okay, so that is 10 ml per minute minus the osmolar clearance, so UV over P, so urine osmolarity 100 times V of 10, okay, over plasma osmolarity of 300. So, if you input the values, you'll get 10 minus 3.3 or positive 6.7 ml per minute. Next, elderly with small cell lung carcinoma or oat cell lung carcinoma excretes urine with an osmolarity of 1,000 milliosmoles per liter. What is the free water clearance? Negative ang free water clearance niya because if you have SIADH, syndrome of inappropriate ADH secretion, seen in a person with oat cell carcinoma, you will reabsorb the water. Hindi mo maiihi yung free water. So, mababa or negative ang free water clearance mo. Differentiates a person with severe water deprivation from those with SIADH plasma osmolarity. So, those with severe water deprivation, we expect their plasma osmolarity to be high. While for those with SIADH, nadadilute ng increased water reabsorption, yung plasma osmolarity nila. So in SIADH, we expect plasma osmolarity to be low. Okay? So that's how you differentiate a person with severe water deprivation from those with SIADH. A previous board exam question. This is actually an MCQ found in Physio BRS. Okay? Effect of hyperaldosteronism on potassium levels and ammonium synthesis. So hyperaldosteronism can cause hypokalemia because aldosterone, remember, it increases sodium reabsorption, potassium secretion to the urine, and H plus secretion to the urine. So because you increase potassium secretion to the urine, kukunti yung potassium na natira sa blood. So it's going to increase the risk of hypokalemia. The hypokalemia will stimulate NH3 synthesis, producing an increase in H plus secretion. Patient with severe diarrhea has acidosis, PCO2 of 24, bicarbonate of 10. Okay? So this patient has metabolic acidosis, to be more specific. So what is the cause of decreased potassium in this patient? Okay? It's secondary to an increase in which hormone? So this is secondary to aldosterone. Ano nangyari, Doc? Anong sequence of events? Nagdiarrhea, nagkaroon ng dehydration, nung na-dehydrate yung patient, bumaba yung blood pressure, nung bumaba yung blood pressure, na-trigger yung RAAS. Kung tumaas yung aldosterone, okay, one of the, remember, the effects of aldosterone is sodium reabsorption, potassium, and H plus secretion. So, kung tumaas yung potassium secretion to the urine, bumaba ang plasma potassium. Okay? So, remember your RAAS sequence of events. Pag, it tries to maintain, RAAS is for long-term control of blood pressure. Acute, short-term control is mainly done, of blood pressure, it's mainly done via the baroreceptor reflex. When the baroreceptor reflex is insufficient in maintaining a normal BP, for example, in severe acute hemorrhage, RAAS will take over. So that RAAS, ano yung sequence of events? Pag supot ang baroreceptor reflex, mababa pa rin yung BP despite an increase na in heart rate. The low blood pressure will be detected as decreased sodium concentration in the lumen of the distal tubule. It will be detected by your macula densa. The macula densa will then trigger, okay, the JG cells to secrete renin. Renin, okay, will convert angiotensinogen to angiotensin 1. Angiotensin 1 will then be converted to angiotensin 2 using ACE from the lungs. Angiotensin 2 will already have a variety of effects. It's a vasoconstrictor, for example. But the most important effect of angiotensin 2 is that it's going to increase aldosterone secretion. Aldosterone then will cause sodium reabsorption, potassium, and H plus secretion. The potassium and H plus secretion, that's a sacrifice. The one that's important is the sodium reabsorption. Aldosterone will cause sodium reabsorption. Where sodium goes, water follows. The sodium reabsorption will be followed by water reabsorption. When that happens, when you reabsorb both sodium and water back to the blood, you're going to increase your intravascular volume. You're going to increase your venous return. You're going to increase your cardiac output. You're going to increase your blood pressure. So the cause, once again, of decreased potassium in our patient, okay, it's caused by an increase in your aldosterone. Patient X arrives at the ER with low arterial pressure, presenting with alkalosis. So what happens now to patients H plus and potassium? Okay, so this is metabolic alkalosis. There is exchange of intracellular H plus for extracellular potassium. Okay. Diagnosis in this patient, okay, again, remember your normal values. Normal pH is 7.35 to 7.45. Normal arterial PCO2 is 40. Normal plasma bicarbonate is 24. So in this patient, meron siyang acidosis. Sino yung compatible sa acidosis dito? Okay, the low bicarbonate. So this patient has metabolic acidosis. Okay? Effect on ionized calcium. 7.52. So this is alkalosis. Okay, PCO2 is low. Okay, that can contribute now to the alkalosis. Bicarbonate is also low. When bicarbonate is low, that will not contribute to the alkalosis. So this patient will have respiratory alkalosis. So bakit? Anong effect ng respiratory alkalosis sa ionized calcium? It's going to decrease the ionized calcium. Remember, okay, yung binigay ko sa inyo noon na mnemonic, yung trio of electrolytes. Remember, I told you, pag mataas ang plasma H+, tumataas ang plasma calcium, tumataas ang plasma potassium. Pag mababa ang plasma H+, bumababa ang plasma calcium, bumababa ang plasma potassium. Trio of electrolytes. So, acidosis, alkalosis will cause the following. Okay? So, dito, halimbawa, pag mataas yung plasma H+, bakit daw tumataas ang calcium at potassium? Because once again, we prioritize acid-base above all else, above the normal concentration of calcium and potassium. So, pag mataas yung plasma H+, one way para mapababa siya, ginagawa natin yung mga calcium na nakabind sa proteins. Proteins are negatively charged, calcium is positively charged. Tinatanggal natin yung calcium, tinidikit natin yung H+. By doing that, okay, bababa yung plasma H+. We prioritize acid-base above all else. Okay, next, kung marami yung H+ sa plasma, ang gimmick natin, ititrade natin siya with the potassium inside the cells. Remember, most of your potassium is found inside the cells. So, kapag meron kang acidosis, ipa-prioritize natin yan. Ipapasok natin yung H+, lalabas ngayon si potassium. So, pag nangyari yon, na-liberate yung calcium, tapos yung potassium mo lumabas ng cell, tataas ngayon ng calcium and potassium as a result of acidosis. The opposite, if you have alkalosis, bababa ang plasma calcium, bababa ang plasma potassium. Previous board exam question now, look at this. If you have alkalosis, it doesn't matter whether this is respiratory alkalosis or metabolic alkalosis. It will decrease plasma calcium. It will also decrease plasma potassium. Okay, pag may alkalosis ka. Opposite is true for acidosis. It will increase both plasma potassium and plasma calcium. Patient with partially compensated respiratory alkalosis after 1 month of mechanical ventilator. What will be the result? So in this patient, there will be respiratory alkalosis. So respiratory alkalosis, this is the one compatible with that. There's alkalosis. And the decrease in PCO2 is the one compatible. So respiratory to. Okay. So decrease PCO2 and decrease H+ and bicarbonate is by mass action. The bicarbonate is further decreased by renal compensation for chronic respiratory alkalosis. Patient with chronic renal failure and decreased urinary excretion of NH4. What is the appropriate ABG interpretation or result here? So this is metabolic acidosis. So this is letter E. Okay. You have acidosis. You have the low bicarbonate being the one compatible with the pH change na acidosis. So in patients who have chronic renal failure and ingest normal amounts of protein, the fixed acids will be produced from the protein catabolism. Because the failing kidney does not produce enough NH4 to excrete all of the fixed acid, metabolic acidosis will occur. Next, patient with untreated DM and increased urinary excretion of NH4. What's the ABG interpretation of result? Metabolic acidosis also. So untreated DM will result in the production of ketone bodies or keto acids that will cause the metabolic acidosis. Patient with 5-day history of vomiting. So vomiting is obviously metabolic alkalosis. So the one compatible with that is letter A. Okay. Next, computation. Medboard's question, I think, October 2022 or March of 2022. So, 50-year-old untreated DM with the following. Okay, and then you're asked about the rate of the glucose filtration, reabsorption rate, secretion rate, and excretion rate. So, you now will have to use the formulas listed here. So, you just do the mathematics for that, for filtered load, excretion rate, reabsorption rate, secretion rate. Okay? So 480, 100, 380, negative 380. Several questions were asked. Actually, tinanong yata lahat ng apat eh. Ano yung filtration load? Then ano yung excretion rate? Ano yung reabsorption rate? At ano ang secretion rate? Okay? So, that's it for renal physiology. Thank you so much. GI physiology now. So if you remember, there are 5 official GI hormones. Your gastrin, CCK, secretin, GIP, and then motilin. This is a master table containing the stimulus, the source, and the actions of each of these 5 official GI hormones. So everything highlighted here, actually everything in this table is must know. Okay? So gastrin, for example, ano yung mga kailangan? Ano yung mga natanong na dyan? What are the triggers for gastrin? So it's the amino acids phenylalanine, tryptophan, and methionine. Remember, gastrin can cause an increase in hydrochloric acid secretion, which will denature proteins. So it makes sense that the amino acids like phenylalanine, tryptophan, and methionine will stimulate gastrin secretion. Gastrin, secreted by the G cells of the gastric antrum. Okay, so not the cardiafundic area ng stomach nyo, but the gastric antrum. Main function is hydrochloric acid secretion. Secretin is the complete opposite. Okay, produced by S cells. Stimulus is hydrochloric acid entering the duodenum. And its action is basically an anti-gastrin hormone. It will decrease or inhibit H+ secretion, and it will cause bicarbonate secretion to neutralize the H+ entering your duodenum. Okay? Cholecystokinin, the main trigger is fatty acids. All types of food, proteins, carbohydrates, and fat can trigger CCK, but the main trigger is fatty acids. It is produced by the I cells in the duodenum with 2 main functions. There are multiple functions listed here in your handout, but the 2 most important is bile secretion for emulsification of fat and the decrease in gastric emptying, or synonymous with the term increased gastric emptying time. Basically, food stays longer in the stomach, okay, for you to be able to mechanically digest the fat. Next, GIP. The main trigger for GIP is oral glucose, not IV glucose, produced by K cells. Okay. Function, it causes insulin secretion. So the moment there's glucose in your mouth, okay, GIP will be secreted to cause insulin secretion. So it's going to anticipate. It's basically an anticipatory hormone. It anticipates that plasma glucose will eventually increase. So inuunahan niya na by causing insulin secretion. Finally, motilin, the main trigger is fasting, secreted by M cells. Okay? And it causes your interdigestive or migrating myoelectric complex. This complex, okay, that will act mainly on the stomach and small intestines, not the large intestines. So those are your 5 official GI hormones: gastrin, CCK, secretin, GIP, and motilin. Neurocrines will cause an action potential. Paracrines will act on nearby cells. So GI neurocrines will include VIP, enkephalins, and GRP. VIP is the ultimate GI tract smooth muscle relaxant. Look at your main handout in Physio. That VIP, your visointestinal peptide, will cause the relaxation of the oral stomach, the lower esophageal sphincter, the pyloric sphincter, and the ileocecal valve. Okay? GI paracrines, meanwhile, will include your PYY, somatostatin, and your histamine. Candidate GI hormones will include your pancreatic polypeptide, enteroglucagon, and GLP-1. GLP-1 is produced by the L cells, as opposed from GIP, which is produced by K cells. Both GLP-1 and GIP will cause an increase in insulin. Okay? Let's answer. Okay, based on Physio BRS question. Increases H+ secretion stimulates gastric mucosal growth. So which GI hormone? Of course, Doc, that's gastrin. Secretion is inhibited by low pH, by acidity, also gastrin. And site of gastrin secretion, gastric antrum. Okay? So, it is methionine, tryptophan, and phenylalanine, okay, which will trigger, okay, gastrin secretion. Okay? G cells of the gastric antrum is the source. Then we have here, okay, increases both exocrine and endocrine secretion of the pancreas, that is cholecystokinin. Effect of cholecystokinin on gastric emptying, it will decrease your gastric emptying. Okay, gastric emptying is movement from the stomach to your duodenum. So, basically, food will stay longer in the stomach because of CCK, for mechanical pulverization of fat. Decreased gastric emptying is synonymous with the term increased gastric emptying time. So, be careful with that. It is synonymous with the term increased gastric emptying time. And the similarity of CCK and gastrin, another previous board exam question, is that they have 5 identical C-terminal amino acids. Increases bicarbonate secretion. This is secretin, the anti-gastrin hormone. Secreted by the S cells once again. It inhibits HCl secretion, increases biliary and pancreatic bicarbonate. Secreted in response to oral glucose load, GIP, your glucose-dependent insulinotropic peptide. Increases insulin secretion and decreases H plus secretion. Okay, GIP also. Okay, main action is to increase insulin secretion. Location of the satiety center, the ventromedial nucleus of the hypothalamus. Remember the mnemonic vuchog. Okay, when stimulated, ventromedial nucleus, you will feel satiated, vuchog. Location of the feeding center or appetite center, lateral hypothalamic area. Remember the mnemonic lamon. When stimulated, your hunger center, appetite center, okay, feeding center, that's your lateral hypothalamic area. So inhibits appetite following the ventromedial hypothalamus, satiety center, stimulates appetite, lateral hypothalamic area, appetite or hunger center. Sends signals to satiety and hunger centers, arcuate nucleus, releases POMC, pro-opiomelanocartin, to decrease appetite, anorexigenic neurons. Okay, anorexia, nawawalan ka ng gana. Orexi means appetite. Releases neuropeptide Y to increase appetite, orexigenic neurons. Stimulates anorexigenic neurons, you have leptin, insulin, GLP-1. Inhibits anorexigenic neurons, you have ghrelin. And inhibits ghrelin, you have peptide YY. Okay? Hydrochloric acid secretion. So, super basic. Kailangan din even for clinical practice. In your gastric parietal cells, carbon dioxide plus water with the help of the enzyme carbonic anhydrase, it will convert these two into carbonic acid, H2CO3. Carbonic acid will then dissociate freely without any enzyme needed into bicarbonate and H+. Bicarbonate will go to the blood in exchange for chloride. Your bicarbonate-chloride exchange. This is what we call your alkaline tide, yung pagpunta ng bicarbonate sa blood because bicarbonate is an alkali. Okay? So it will make the blood more alkaline. Eventually, that bicarbonate will find itself as part of your pancreatic secretions sa bicarbonate, pancreatic bicarbonate that will neutralize hydrochloric acid going to your duodenum. Yung H+ naman, okay? Bicarbonate, H+. Yung H+ mo naman dito will be secreted into the lumen of the stomach in exchange for potassium. This will require the use of ATP. So this is your hydrogen, potassium, ATPase exchange pump, also called your proton pump. The proton pump or hydrogen potassium ATPase exchange pump is an example of a primary active transport. It's an example of a primary active transport na counter transport. Okay? So, chloride will then go to the lumen. H+ will go to the lumen, forming hydrochloric acid. Once that hydrochloric acid goes to your duodenum, okay, bicarbonate, pancreatic bicarbonate is secreted to counteract the hydrochloric acid. So, yung bicarbonate na nandun sa blood, eventually, it will become your pancreatic bicarbonate. Once you have pancreatic bicarbonate and hydrochloric acid mixing, it will produce, once again, carbon dioxide and water. So, characteristics of gastric HCl, a previous board exam question. Highly acidic, pH of 0.8. That's the one written in Guyton and Hall, and the one asked in the med boards. In your Physio BRS, they tend to round this off, a pH of 1 to 3.5. Gastric HCl is secreted at this rate, 160 millimoles per liter. Its hydrogen concentration is 3 million times higher than arterial blood. So what will cause increased HCl secretion? Three things. Histamine, acetylcholine, and gastrin are the three triggers for HCl secretion. Histamine acting on H2 receptors, acetylcholine acting on M3 receptors, gastrin acting on CCKB receptors. Okay, these three can potentiate, meaning they have a synergistic effect. Okay, the net effect is more than the sum of their individual components. Synergy. Okay? Factors that can inhibit hydrochloric acid, meanwhile, will include low pH, somatostatin, and prostaglandins. Phases of HCl secretion. Cephalic, when you're thinking about food, seeing food, tasting food. Okay? Gastric phase, when food is already in your stomach, you will produce most or majority of your secretion at that time. And intestinal phase, even when the food is already in your duodenum, hydrochloric acid secretion will still be stimulated. Okay? Secretion of parietal cells, dalawa. A previous board exam question, quite easy, even in med school, you probably knew this. Your hydrochloric acid and intrinsic factor. IF, or intrinsic factor, was called intrinsic because it is the only secretion considered, only gastric secretion considered essential for life. You can live without pepsin, you can live without hydrochloric acid, you cannot live without intrinsic factor because intrinsic factor is needed to absorb B12. Without B12, okay, you cannot synthesize DNA properly. Okay, so you need the IF to be able to absorb B12. Location of parietal cells, gastric fundus. Okay, G cells, gastric antrum. Parietal cells, gastric fundus. Okay, so your parietal cells are located basically in the upper stomach in the gastric fundus, while your G cells, okay, are located in the lower stomach in the gastric antrum. Please be careful about their location. Na-emphasize ko yan kasi natanong na rin talaga dati. Drug that directly inhibits hydrogen potassium ATPase pump. Another previous board exam question, quite easy to be honest. That's your proton pump inhibitor, like your omeprazole. 38-year-old male with duodenal ulcers treated with cimetidine. What's the mechanism of action? It's an H2 blocker, your cimetidine. Cimetidine has another adverse effect. Okay, it can cause gynecomastia. Remember the classic mnemonic? Some drugs create awesome knockers. Some drugs create awesome knockers. So what will cause gynecomastia? Okay, spironolactone, digoxin, okay, cimetidine, okay, alcohol, and ketoconazole. Drug that blocks H+ secretion by inhibiting cholinergic muscarinic receptors on your parietal cells, the anti-muscarinic drug atropine. Okay? GI secretion high in bicarbonate and is hypotonic. So that is your saliva. Remember, saliva is alkaline. Okay? Because it's high in bicarbonate to neutralize acids in the mouth produced by the bacteria in your mouth, to counteract acids from the acidic food that you may have taken, and to counteract the acids from reflux. Okay, galing sa stomach. GI secretion high in bicarbonate and is isotonic. Meanwhile, that is your pancreatic secretion. Remember, acinar cells will produce the initial saliva. Okay, then ductal cells will make modifications to the initial saliva to form your final saliva. Initial saliva is similar to plasma. Final saliva, okay, is characterized by hypotonicity, mababa ang kanyang sodium. Okay? Final saliva is characterized by being high in potassium and bicarbonate. So it's going to be alkaline because of the high bicarbonate. It's going to be rich in potassium also. Hormone involved in absorbing sodium at the ductal cells, that's your aldosterone. Okay, at high flow rate, saliva will have a high sodium, okay, high potassium, low potassium, and high bicarbonate. So bicarbonate secretion is not part of what we call the contact time hypothesis. Kaya it's not affected. The higher the flow rate in the ductal cells, the higher, okay, the bicarbonate secretion. That's why high pa rin siya. Hindi katulad ng sa potassium and sodium, they are both affected by what we call the contact time hypothesis. So at high flow rates, mabilis masyado, hindi na reabsorb masyado yung sodium, so mataas yung sodium. Hindi masyado nase-secrete yung potassium dahil ang bilis niya mag-flow. Okay, so mababa yung potassium. Bicarbonate secretion is the exception to the contact time hypothesis. Okay? So, pancreatic secretions, okay, the ductal cells there, you also have ductal cells, it's permeable to water, while the saliva, the ductal cells there are impermeable to water. Site of sodium bile acid co-transport, duodenum, jejunum, or ileum? Ileum. Okay? Which vitamin will require micelle formation? So micelles, that's the form to absorb fat towards your small intestinal cell. So the vitamins that will require that, okay, will be fat-soluble vitamins. Your ADEC, vitamins A, D, E, and K. 49-year-old male with Crohn's, status post-ileal resection. Tinanggal yung ileum, now complains of steatorrhea, lipids in the stool. So what's the reason for that? Okay, impaired fat absorption. Micelles do not form in the intestinal lumen. So for bile, again, the most common component is water, but the active components are bile salts. Take note that all bile salts come from cholesterol, converted first to primary bile acids, then secondary bile acids, before they're finally converted into bile salts. In the med boards before, they tend to ask which is the primary bile acid, which is the secondary, which is the bile salt. So primary bile acids, mnemonic, they start with the letter C. Cholic and chenodeoxycholic are primary bile acids. Okay? Intestinal bacteria, another previous board exam question, will convert primary to secondary bile acids. Secondary bile acids, they don't start with the letter C. So this will include deoxycholic and litocholic. And then finally, okay, the conversion of secondary bile acids to bile salts will require conjugation. You conjugate them to either glycine or taurine. That's why take a look at their names. May glyco o may tauro sa pangalan because you added glycine or taurine. By adding glycine or taurine, by conjugating them, you will convert them into a water-soluble form. So now you're able to, the glyco and tauro, okay, the water-soluble form, they are now properly termed bile salts, okay, after undergoing conjugation. With these bile salts now, you can cause emulsification of fats. So, bile will have bile salts as its active component. Okay, bile is produced in the liver. Bile is stored and concentrated in the gallbladder. Bile is secreted into the duodenum. And then bile salts will be reabsorbed in your terminal ileum. Okay? Enterohepatic circulation refers to the recycling of these bile salts. So, intestines to your liver. Enterohepatic. So, composition and function of bile, it will contain, again, bile salts, among other substances listed here. Bile salts are amphipathic. They have both water-soluble and lipid-soluble side. Okay, these bile salts will emulsify on solubilizing them in micelles. So when you say emulsification of fats, you will turn the large lipid droplets into smaller lipid droplets, increasing the surface area. Okay? Next. Okay, some questions. What is the only form of carbohydrate that the GI tract can absorb? Only monosaccharides. We're less maarte when it comes to proteins. We can absorb amino acids, dipeptides, tripeptides. But for carbs, we're very maarte. We can only absorb monosaccharides. Glucose, galactose, and fructose. Transport of monosaccharides in the GI tract, must know. So luminal side, basolateral side, luminal side, you have SGLT1, secondary active transport for the transport of glucose and galactose. GLUT5, facilitated diffusion for the transport of fructose. At the basolateral side, all of them, glucose, galactose, and fructose, will use GLUT2. Main site for salivary amylase secretion. Okay, salivary amylase is also called thiolin, so parotid gland. Activates trypsinogen. So trypsinogen is a zymogen, an inactive protease. They are activated by, number 1, the brush border enterokinase. Brush border is synonymous with the term microvilli. So EK will convert trypsinogen into trypsin. Now take note, trypsin itself can convert trypsinogen into trypsin. So both EK and trypsin can activate trypsinogen. Which is an essential protease, the one you cannot live without? Trypsin. Pepsin is merely supplementary. Lingual lipase, gastric lipase, pancreatic lipase, which one is acid labile, meaning it is destroyed by hydrochloric acid? Pancreatic lipase. The other two, lingual lipase and gastric lipase, are acid stable. They are not destroyed by hydrochloric acid. In fact, lingual lipase and gastric lipase, their site of action is in the stomach, where you will find the hydrochloric acid. They are acid stable. They're not destroyed. What is mainly absorbed now in your duodenum? Iron and vitamin C. What is the proper spelling? Pang-trip lang, jejunum or jejenum. So, J-E-J-U. Do not be a jejemon. J-E-J-U ang proper spelling yan. What is mainly absorbed in the jejunum? All nutrients, carbs, proteins, fats, and water are mainly absorbed in the jejunum, including water. It's a misconception that water is mainly absorbed in the large intestines. No, 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 no. Only 1.5 liters of water is absorbed in the proximal large intestines or proximal colon. 7.5 liters will actually be absorbed in the small intestines. To be more specific, most of it in the jejunum. What is mainly absorbed in the ileum? The most board relevant. Fat-soluble vitamins, A, D, E, and K. IF-B12 complex. And finally, bile salts. So that's it for, GI physiology pearls. Endocrine physiology. So the mechanism of hormone action ng ADH2-V2 receptors. So remember, ang antidiuretic hormone or vasopressin will have two types of receptors, V1 and V2. V1 is found in the blood vessel. V2 is found in the kidneys. So V1 when stimulated will cause vasoconstriction. Okay, kaya tinawag tong vasopressin. V2 when stimulated will cause insertion of aquaporin type 2 in the collecting duct. So iba ang second messenger system ng V1 versus V2. So for V2, the second messenger system is cyclic AMP. Cyclic AMP is the most common second messenger system. Okay? So it will utilize ATP, ang cyclic AMP. Then may cyclic AMP. Ang cyclic GMP is an equivalent, but instead of using ATP, GTP ang gagamitin. Okay? IP3-DAG is used by all hypothalamic hormones with the exception of CRH, corticotropin-releasing hormones. All of these are actually, hypothalamic hormones. Okay? Most of the things listed here are hypothalamic hormones. So all hypothalamic hormones will utilize IP3-DAG. Okay? So this will include GHRH, GnRH, TRH, vasopressin, and oxytocin, because vasopressin and oxytocin are actually produced in the hypothalamus. Okay? So IP3-DAG, all hypothalamic hormones, with the exception of CRH. CRH will utilize cyclic AMP. Intracellular receptor, so it refers to the use of the mechanism used by lipid-soluble hormones, along with thyroid hormones. So they will utilize an attachment to nuclear receptors or cytoplasmic receptors, will cause transcription of genes, production of new intracellular enzymes. Cyclic AMP, again, is the most common second messenger system. if you are asked in the med boards, ano yung second messenger system ng hormone na to, if absolutely hindi mo alam, yung answer is cyclic AMP because it's the most common. So cyclic AMP, ano yung mechanism na yan? Hormone will bind to the receptor. That receptor, cell membrane receptor, will then trigger a G protein, a transducer, a converter of a chemical signal. It will link the first messenger, the hormone, with the second messenger system. Okay? So in this case, okay, the G protein, okay, will trigger cyclic AMP second messenger system. So in here, you have GTP, okay, activating that G protein. Okay, that G protein in turn will activate an enzyme called adenylate cyclase, converting adenosine triphosphate into CAMP. CAMP will then activate protein kinase A. pKa will add a phosphate group to already existing enzymes. It will phosphorylate enzymes or phosphorylate proteins. The phosphorylated enzyme will then cause the final hormonal effect. IP3DAG naman, the protein hormone, cell membrane receptor, G protein, will activate an enzyme, phospholipase C. Phospholipase C will split inositol PIP2 into 2. It will split this PIP2 into inositol 3-phosphate, IP3, and diacylglycerol, DAG. Okay? Protein kinase C will then be activated. Protein kinase C will add phosphate to already existing enzymes, causing the final hormonal effect. Okay? Intracellular receptors, like your lipid-soluble hormones, again, binds to nuclear receptors, cause transcription of genes, cause the synthesis of new enzymes, okay, causing the final hormonal effect. Kinase receptors, tyrosine kinase, anything that makes things grow, anything that can increase the cell number, okay, will utilize tyrosine kinase. Anything that makes things grow, think tyrosine kinase. That's the mnemonic. So lahat ng growth factors, whether it's epidermal growth factor, nerve growth factor, VEGF, EPO, insulin, insulin-like growth factor 1, they will all utilize TK, tyrosine kinase. Mechanism of action of insulin, tyrosine kinase. Because insulin, okay, will cause an increase in the cell number. Okay? So it's an anabolic hormone. PTH, okay, will utilize cyclic AMP. CRH, okay, even though produced from the hypothalamus, it's the exception to the use of IP3DAG. It will utilize CAMP. ACTH, cyclic AMP. MSH is cyclic AMP. ADHV1 is IP3DAG. Atrial natriuretic peptide, cyclic GMP. IGF-1 is TK. EDRF is cyclic GMP. Oxytocin is IP3DAG because oxytocin, once again, is actually a hypothalamic hormone. Thyroid hormones, they're not made from cholesterol, but they will act similar to steroid hormones. They're able to penetrate cell membranes because they're also lipid soluble. So T3 and T4 will use an intracellular receptor. That intracellular receptor can either be a nuclear receptor or a cytoplasmic receptor. Estrogen and progesterone will utilize intracellular receptors, nuclear receptors. Effect of sleep on GH secretion. Sleep will increase your GH. Stress, puberty, starvation, all of these will increase growth hormone. Remember that growth hormone is both catabolic and anabolic. That's why both sleep and stress can trigger GH. Sleep can trigger the anabolic effects of GH. Stress can trigger the catabolic effect of growth hormone. So growth hormone, take note of its direct and indirect actions. Direct actions, it's going to increase your plasma glucose by decreasing glucose uptake into the cells. A previous board exam question, that's why it's in red. It will increase lipolysis, protein synthesis, production of IGF-1, okay, increase lean body mass. Indirect actions, add that, indirect actions of GH is done via IGF-1. This is actually the one that will cause you to grow. So IGF-1, synonymous with the term somatomidine, the one that directly mediates growth. It's the one that will cause bone lengthening and bone thickening. Okay, your somatomedin or IGF-1. Okay, so factors that will increase GH and decrease GH are listed here. Okay, take note that both sleep, okay, and stress, trauma, stress can increase growth hormone secretion. 38-year-old male with galactorrhea and prolactinoma treated with bromocriptine. So what is the therapeutic action of this bromocriptine? It's anti-prolactin. Okay. Bromocriptine is a dopamine analog. So bromocriptine, dopamine, they will inhibit prolactin release from the anterior pituitary. Okay. So effect of dopamine and prolactin secretion, it will decrease prolactin secretion. Another previous board exam question, what's the effect of TRH on prolactin secretion? So halos trivial, no? For me, this is already trivial. Okay, it increases prolactin secretion. Okay, your TRH. Prolactin should be differentiated from oxytocin. Prolactin, P2P, production of milk. Oxytocin, S to S, oxytocin, secretion of milk. Okay? 61-year-old with hyperthyroidism treated with PTU. PTU inhibits the oxidation of what? Iodide. Take note, iodide is I negative. Okay, iodine is I subscript 2. Okay, so steps in thyroid hormone synthesis and secretion. First, you have iodide trapping using sodium iodide symporter. Okay, iodide will go, okay, from the blood to the follicular cells and be trapped here. Okay, from there, okay, your iodide. So you produce thyroglobulin, then you do your iodide trapping. Thyroglobulin is the storage protein for thyroid hormone in the thyroid gland. Iodide trapping is the second step. Okay, you get iodide from the plasma and trap it inside the follicular cell. Then, okay, from here you transport this iodide into the follicular lumen using pendrin. After that, you organify, you convert the iodide into iodine. So I negative becomes I subscript 2. Okay? Next is organification of this iodine. When you say organification, you're adding carbon, okay, to the iodine. That organification will result in monoiodo and diiodotyrosine being formed. From there, you do coupling. Monoiodo plus diiodo will give you T3. Diiodo plus diiodo will give you T4. Stored in the thyroglobulin, your monoiodo, diiodo, tyrosine, T3 and T4. Then when you have TSH binding to the TSH receptor, okay, that will cause the endocytosis of this thyroglobulin complex. Then pipitasin mo yung mga bunga na nandiyan sa thyroglobulin, including T4 and T3. T4 and T3 are lipid soluble. They will directly penetrate the membrane, go to the blood. In the blood, okay, it's free forms ng T4 and T3, which is important. T4 is predominant, mas madami, but T3 is the one that is more active. Effect of parathyroid hormones on the following: calcium, phosphate, and vitamin D. So parathyroid hormone, remember our mnemonic, phosphate rushing hormone. So PTH will increase calcium reabsorption in the distal tubule. Eventually, take note, it will increase plasma calcium. Phosphate, PTH is a phosphate rushing hormone, so it will inhibit phosphate reabsorption. So eventually, it will cause a decrease in plasma phosphate. And then in terms of vitamin D, previous board exam question, this PTH will stimulate 1-alpha hydroxylase, an enzyme needed in the final activation of vitamin D in your kidneys. Remember the story that I told you as a way to remember PTH, vitamin D, and calcium. I told you about girl calcium, boy PTH, and the Beshi ng Bayan vitamin D. So you can go back to that story in your main handout. Okay? So PTH, the main trigger is hypocalcemia. PTH will cause bone resorption. Calcium and phosphate will go from bone to blood. In the kidneys, it will decrease phosphate reabsorption, increase calcium reabsorption. Okay? In the small intestines, PTH has no direct effects. The effects of PTH on the intestines is indirect via the activation of vitamin D. Overall effect, plasma levels, increase plasma calcium, decrease plasma phosphate. Vitamin D ang beshi ng bayan. Okay? It's going to cause bone deposition, not bone resorption. So it's going to cause calcium and phosphate to go from blood to bone. At high toxic levels of vitamin D, it may do the opposite, bone resorption. In the kidneys, it's going to increase both phosphate and calcium reabsorption. Hindi siya phosphate rushing. In the small intestines, it's going to increase both calcium and phosphate absorption. So overall effect, okay, on plasma calcium and phosphate, it's to increase. It's going to increase because of vitamin D. What is the active form of vitamin D? 1,25-dihydroxycholecalciferol is the active form of vitamin D. Okay? What is the inactive storage form of vitamin D? That's 24,25-dihydroxycholecalciferol. Okay? 41-year-old female with hypocalcemia, hyperphosphatemia, decreased urinary phosphate excretion, PTH injection increases cyclic AMP. So what is the diagnosis? Hypoparathyroidism after thyroid surgery. So this is not primary hyperparathyroid, not vitamin D intoxication, not vitamin D deficiency because of the reason cited here. Next, selective destruction of the zona glomerulosa will cause a deficiency in, of course, Doc, aldosterone. Remember, okay, cortex, medulla, in the adrenals. Cortex is further divided into three: glomerulosa, fasciculata, reticularis. Outermost is glomerulosa, middle is fasciculata, innermost is reticularis. Glomerulosa will produce aldosterone, fasciculata will produce cortisol, reticularis will produce your weak androgens. So if you destroy the zona glomerulosa, boom, you will have a deficiency in aldosterone. Step in steroid hormone biosynthesis stimulated ACTH, okay, cholesterol to pregnenolone, the rate-limiting enzyme for adrenocorticotropin, for the pathway for the production of adrenal hormones. Okay? Cholesterol to pregnenolone. Okay? What is the enzyme involved here? Desmolase. Parent molecule of ACTH, okay, pro-opiomelanocortin. So remember that ACTH will actually stimulate desmolase to convert cholesterol to pregnenolone. Ito siya. ACTH will stimulate desmolase. Desmolase is the one that converts cholesterol to pregnenolone. The rate-limiting step for adrenocortical hormone synthesis pathway. Okay? From here, okay, you will eventually be able to produce your aldosterone, cortisol, okay, and your weak androgens. Okay? Enzyme in steroid hormone biosynthesis, converting testosterone to dihydrotestosterone. So this is 5-alpha reductase. Okay, step that blocks the production of all androgenic compounds, not the production of glucocorticoids. The conversion of 17-hydroxypregnenolone to dihydroepiandrosterone. Next, 46-year-old male with hirsutism, hypergly, obesity, muscle wasting, and increased ACTH. Okay, so this is Cushing disease. Okay, mataas yung ACTH. Okay, produced by your pituitary. Okay, meron kang hirsutism, hypergly, obesity. So yeah, classic for Cushing's. Okay. So male reproduction, meanwhile, the path of semen, as previously mentioned, is 7 up. Seminiferous tubules, epididymis, vas, ejaculatory ducts, nothing, urea, and the penis. Okay? So remember that the sperm is produced in the seminiferous tubules. Okay? It will mature in the epididymis. It is stored in the vas deferens. It gets its nutrition from the seminal vesicle. The source of nutrition is fructose. And it becomes alkaline because of the prostate gland. Okay? What do you tell a patient prior to sperm analysis? Abstain for sexual intercourse for several days. Take note, the testis temperature is cooler than the body core. Okay? To prevent for spermatogenesis to occur properly. Para hindi siya hindi siya maging fried egg, basically. Activation of sperm in the female genital tract, we call that capacitation. Neurotransmitters used in erection, we have nitric oxide and acetylcholine. Okay, so nitric oxide is a vasodilator. An inhibitory neurotransmitter and vasodilator, that's the classic description for nitric oxide. Oligospermia, okay, controversial. Certain references, less than 15 million. Other references, less than 20 million. Okay? Ano yung natanong, Doc, sa exam? Walang 20 million na option. Ang meron na option, 15. So, obviously, kung may 15 as a choice, you choose that. Less than 15 million sperm per ml. Viability of your sperm, average of 3 days. Viability of the human egg cell, average of 24 hours. Okay, now, in your handout, I listed the forms of testosterone in the blood. I told you in the handout that 60% of testosterone is bound to sex hormone binding globulin, 38% is bound to albumin, and 2% is found as free testosterone. Now, there's, I think, a question in one of your practice tests that stated differently, na mas marami basically yung albumin-bound testosterone kaysa sex hormone binding globulin. So, ngayon nagtanong yung mga students, so ano tamang sagot dito? Okay? When you look at several sources, okay, they vary. For some of the internet references, mas marami talaga yung albumin. Okay? For other sources, mas madami yung sex hormone binding globulin. Okay? So, ano yung nakasulat, Doc? Byrne and Levy, mas marami yung sex hormone binding globulin. References sa internet, some of them, mas madami yung albumin bound. Guyton, okay? Guyton, pag naisip just lump them together, it said parang SHBG tsaka yung albumin, they will make up 97% of the testosterone in the blood. So, nilump nyo together. So, both are equally valid references. Yung nandoon sa internet, yung mga sources na nandoon, titingnan natin. And yung Byrne and Levy, where I base my handout. Okay? This part in your handout, that's Byrne and Levy. Doc, ano gagamitin natin sa exam ngayon? Yung nakasulat ba dun sa mga internet references or yung nakasulat sa Byrne and Levy? You're not sure if the Board of Medicine is using Byrne and Levy. They might be using these internet references. But kapag ganyan kasi, important na uniform ang answer across the entire top-notch system. So, in this case, if it's asked again in the med boards, choose, okay, pinakamadami, predominant form ng testosterone, choose the one said in Byrne and Levy. Okay, sex hormone binding globulin. Okay? Release of Sertoli cells for negative feedback control, FSH, inhibin. 16-year-old female, 46XY, diagnosed with androgen insensitivity disorder. So, genetically male, phenotypically female. No uterus, cervix, or ovaries. What is expected? So, genotype is male, 46XY, but phenotype is female. Testosterone level is expected to be elevated. The problem with this is the testosterone receptor. Okay, not testosterone itself. Okay. Again, in the menstrual cycle, 400 cycles in a given lifetime, divided into two, the proliferative phase and the luteal phase. Proliferative phase and the secretory phase, also called your follicular phase and luteal phase. Follicular proliferative phase, the main hormone is estrogen. It's going to cause selective negative feedback. Bumababa lang yung LH. Okay? Hindi bumababa yung FSH during the follicular phase. Okay? Yung FSH, Stimulates the follicle, so it makes sense that during the follicular phase, tumataas lang yung FSH levels mo. Okay? At the peak of estrogen secretion, there's a slight dip in your FSH levels to ensure that only one follicle will fully mature. The day after, instead of causing selective negative feedback, it will now cause positive feedback on the pituitary, causing an LH surge and an FSH surge. It's the LH surge which will cause ovulation. Okay, during this time, you will convert granulosa cells, okay, and theca cells into luteal cells. You will now have corpus luteum. The corpus luteum in the luteal phase, secretory phase, will produce both estrogen and progesterone, but mainly progesterone. Progesterone, non-selective negative feedback. It will inhibit both LH and FSH. Now, for the boards. Yung yellow boxes ang pinaka-importante. Nilagay ko na dyan yung mga natanong nila dati. Okay? So, what I've just discussed is this one. Okay, LH serves a trigger for ovulation. LH levels are highest in ovulation. Okay? Ano pa? Follicular phase, previous board exam question, is the main determinant of menstrual cycle length. Key terms, menorrhagia, polymenorrhea, menometorrhagia, metorrhagia, natanong na rin yan dati. Case of girl who had her first menses, which will regenerate functional or basal layers. Functional layer. What do you measure in the urine as a sign that ovulation has happened? LH. Sign of the example of double negative question, the one that I've told you during the main lecture and the intro for the pearls. So it's the release of genetic material, which is the answer to that question. Another trivial question for physio. Type of human placenta? Hemochorial. Okay? Not an excretory product of the mother? Glucose. Okay? So these are based on previous board exam question, the relatively trivial questions there. Lactation is suppressed during pregnancy. Okay? What is the explanation? Blood levels of estrogen and progesterone are high. So it inhibits now the action of prolactin on the breast. So that's it for our endocrine physiology. Last module, hemophysia and special topics. So let's identify the following. Biconcave, secondary to uprooting called spectrine. Last 120 days, enucleated, relies on anaerobic glycolysis. Acid-base buffer, secondary to carbonic anhydrase. So this is a red blood cell. Dadagdag pa natin. Size of your red blood cell, 8 micrometers. Derived from megakaryocytes, last 7 to 10 days, forms the initial thrombi. So these are your platelets. So platelets, they form what we call a loose platelet plug. It's basically your primary hemostasis. You need to strengthen that further using thrombin. So we'll discuss that later. Okay? Next, granulocytes. Your 3 granulocytes are your BEN. Basophils, eosinophils, and neutrophils. Baso, eo, and neutrophils will have intracellular granules. Those intracellular granules have different functions. So for example, yung sa basophils, meron siyang histamine. Okay? Eosinophils and neutrophils, may kanya-kanyang respective functions yung mga granules nila, intracellular granules. Next, identify, derived from B cells and secretes antibodies or immunoglobulins, your plasma cells. B cells are immature, plasma cells are mature. You convert B cells to plasma cells. Plasma cells will be the one to secrete, okay, your antibodies or immunoglobulins. Involved in the cell-mediated response, T cells. Involved in innate immunity, okay, anything other than lymphocytes. Yun yung shortcut dyan. So anything other than lymphocytes, your neutrophils, basophils, natural killer cells, dendritic cells, complement, they are involved in innate immunity. Innate immunity, again, is first line, non-specific, non-lymphocyte mediated. Involved in adaptive immunity, well, dyan na papasok yung lymphocytes, your T cells and B cells. Adaptive immunity is second line, specific, requires prior exposure, and it is lymphocyte mediated. Okay? C3b, C3A, C4A, C5A, C5B to C9, these are complement proteins. C3B, remember, is an opsonin. C3A, C4A, C5A are anaphylatoxins involved in inflammation. C5B to C9, the most board relevant, it forms what we call your membrane attack complex, the one that causes the perforations or holes in the cell membrane of bacteria. Okay? Activated by interferon gamma, phagocytizes cellular debris in senescent RBCs, acts as an antigen-presenting cell via MHC2, long lifespan compared to monocytes. These are macrophages. Monocytes are immature and they are found in the blood. Macrophages are mature and they are found in the tissues. Okay? Macrophage of the liver, Kupffer cell. Macrophage of the brain, microglia. Macrophage of the bone, osteoclast. Macrophage of your lungs, dust cells. Macrophage of your skin and soft tissue, okay, Langerhans cells. Next, key points about red blood cells. Erythropoietin, the trigger is hypoxia. Site of secretion, interstitial cells of the peritubular capillaries. Interstitial cells, not intercalated. Iba yun. Okay? Effect of EPO is that it will increase RBC production by the bone marrow. Okay? It will produce initially what we call reticulocytes. That's the one secreted in your blood by the bone marrow. It will take several days for the reticulocytes to be converted into mature RBCs. Appearance of RBCs is biconcave, once again secondary to spectrin. Spectrin will give it bag pliability, the ability to bend in very narrow passageways. Hemoglobin is the storage protein for oxygen. Building blocks will include succinyl-CoA, okay, and glycine. Adult hemoglobin, so very basic question, 2 alpha, 2 beta chains. Fetal hemoglobin, 2 alpha, 2 gamma chains. Okay? Previous board exam question, binds more with 2,3-BPG, that's adult hemoglobin. Okay, binds less, fetal hemoglobin. Because 2,3-BPG binds more with adult hemoglobin, ang result niyan, okay, because 2,3-BPG will cause shift to the right, it will cause oxygen to unload from adult hemoglobin and eventually find its way to fetal hemoglobin. Okay? 1 gram of hemoglobin will carry 1.34 ml of oxygen. Iron. The ferrous form Fe2+, and not the ferric form Fe3+, is the one that is biologically active. Transferrin transfers iron in blood. So it's a plasma iron transport protein. Ferritin, okay, is a storage protein, the primary storage protein for iron in the liver. So whenever you have an excess of iron beyond your daily needs, it's going to be stored in ferritin. Okay, that's why yung lasa ng chicken liver, it's parang metallic. It's because of the ferritin in there along with the iron. Hemosiderin is a secondary supplemental storage protein. Once you've utilized your ferritin stores, you're going to utilize hemosiderin, okay? Your supplemental storage protein for iron. It's found outside of the liver. For example, you can find hemosiderin in macrophages. Spleen, okay, is where old or damaged RBCs come to die. We call it the graveyard of RBCs because of its very narrow passageways. So old defective RBCs will die there. Okay? B12 and folic acid will both cause megaloblastic anemia. Okay? The difference is B12 deficiency will cause neural deficits, while folic acid deficiency in pregnant women, you're going to have a higher chance of having a baby with neural tube disorders. So neural deficits, neural tube defects. Neural deficits for B12, neural tube defects for folic acid. So sources of B12 and folic acid, okay? So B12, you will find it, okay, in meats alone, like baboy, baka. Folic acid, you will find it in vegetables, green leafy vegetables, like broccoli and cauliflower. That's why these are mnemonic. B12, baboy. Folic acid, broccoli, and cauliflower. Give me a meal that will prevent megaloblastic anemia. Beef with broccoli for one. Okay, beef with broccoli. May B12 ka na, may folic acid ka pa. So safe ka na for megaloblastic anemia with those two. Okay, let's identify. Most common white blood cell, it's letter C, your neutrophils. Least common, letter A, basophils. Has a highly lobulated nucleus, 3 to 5. Okay, this is your letter C, neutrophils. Bilobulated in pink, the white blood cell, letter B, eosinophils. Bilobulated in blue, this is your A, basophils. Blood cell with an extensive frosted glass or ground glass cytoplasm, eccentrically placed nucleus. A previous board exam question, letter D, monocytes. Take note, the answer is monocytes and not macrophages. Frosted glass cytoplasm. Last 7 to 10 days, letter E, platelets. Round, densely stained nucleus with pale basophilic non-granular cytoplasm. Letter F, lymphocytes. Largest white blood cell, monocyte. And adaptive immunity, okay, lymphocytes. Okay, innate versus adaptive immunity. Again, innate is non-lymphocyte mediated. Adaptive immunity is lymphocyte mediated. Innate immunity is non-specific. Adaptive immunity, specific. Requires prior exposure. Previous board exam question, links innate to adaptive immunity, dendritic cells. So what are bound to antigens that serves as markers for complement proteins? So we have antibodies. When antibodies are bound to antigens, you have antigen-antibody complex or immune complex. They will attract complement proteins. Can be monomeric or dimeric, that's IgA. Pentameric and cheap and has 10 binding sites. The largest, IgM. Primary response, largest is IgM. Secondary response, smallest and can cross the placenta, IgA. Found in human body secretions, saliva, tears, Peyer's patches, for example, IgA. Involved in allergies, IgE. Recent medboards lang, activates complement or fixes complement, IgG, IgM. Hindi kasama ang IgA. Found in naive B cells, IgD. Most common overall and most common in serum respectively. Most common overall is actually IgA. But the one most common in the serum, plasma, IgG. So kindly take a look at this grand table. Of course, we've discussed in here yung mga pinaka-importante, but this is the more complete version. Okay? So, remember for your complement proteins, you only need to remember the functions of several important complement proteins. C3b is the opsonin. C5a is for chemotaxis. Okay? C3a, C4a, C5a are anaphylatoxins involved in inflammation. And C5b to C9, the members of your membrane attack complex. Let's do blood typing. Okay? You place blood into two samples, one containing anti-A, the other containing anti-B. If there's no clumping, what is the blood type? Blood type O. Kung nag-clumping lang with anti-A, the blood type is blood type A. Kung may clumping lang with anti-B, the blood type is B. And pag may clumping with both, blood type AB. Universal donor is blood type O. Universal recipient is blood type AB. The steps in hemostasis, we have 4. Whenever you have a ruptured blood vessel, the first step is vascular constriction. This is triggered by local myogenic spasm and endothelin 1, a previous board exam question. Okay? The vasoconstriction will prevent exsanguination. Primary hemostasis, or the formation of a loose platelet plug, is further divided into 3 substeps. Platelet adhesion, activation, aggregation. The one involved in platelet aggregation is von Willebrand factor and glycoprotein 1b. The one involved in platelet aggregation, meanwhile, is fibrinogen and glycoprotein 2b3a. Secondary hemostasis or blood coagulation, we have extrinsic and intrinsic factor. Okay? This extrinsic and intrinsic factor will lead to the formation of thrombin. That thrombin its action is to convert fibrinogen, okay, here in the loose platelet plug, it will convert it to fibrin. Okay? So once you have that fibrin, the loose platelet plug will be strengthened by this fibrin net or fibrin meshwork. Yan yung itatapon mo dun sa loose platelet plug. So yung thrombin, let me refine kung ano yung sinabi ko earlier. Thrombin will not cause the strengthening directly ng loose platelet plug mo. Thrombin will merely convert fibrinogen into fibrin. Fibrin itself will be the one to directly strengthen the loose platelet plug. And then finally, we have resolution. The one that will dissolve the blood clot when you no longer need it is plasmin. TFP, thrombin, fibrin, plasmin. Thrombin will convert fibrinogen to fibrin. Fibrin is the fibrin net or fibrin meshwork, the one that will strengthen the loose platelet plug. Plasmin is the one that will dissolve, okay, the blood clot. So for this one, okay, especially the cytokine table, the cytokine table is must take a look in 30 minutes, 1 hour before the board. So part yan ng last minute notes nyo. The highlighted portions are the ones that had appeared before in the med boards. So activation of T cells and macrophages is interleukin 1. Chemotaxis of neutrophils, basophils and T cells is interleukin 8. So this one, don't memorize it now. Just take a very quick look on the day of your board exams for physiology. Just store it in your short-term memory. Just be familiar with it. Kasi it doesn't make sense for you to memorize this one because it's not clinically relevant. And it's very hard. It's very hard to memorize. Very, very easy to forget. Okay? Start of high altitude sickness. 12,000 feet. Seizures, when will it happen? 18,000 feet. And death in acclimatized individuals, when it will happen? 23,000 feet. Adaptation to high altitude, we have an increase in your respiratory rate. That's one. Makes sense for you to get more oxygen. Increased RBC production is also an adaptation. Makes sense para mas efficient yung transport. Increased diffusing capacity of oxygen from the lungs to the blood. Also makes sense. Next, increased blood vessel formation. Okay? Para mas maraming mapuntahan yung blood and oxygen mo. Okay? And increased mitochondria, making your cells more efficient in utilizing oxygen. So these 5 are the adaptations to high altitude. Adaptations to the hypoxemia. Adaptations to the hypoxia caused by high altitude. When you say natural acclimatization, it means you were born in a place of high altitude. You grew up in that place. So their adaptations are quite different. They will have larger hearts and lungs, smaller height. Okay, para decrease yung demand, tapos yung increase yung supply. Okay? Larger hearts and lungs for increased supply, smaller height, smaller body size for decreased demand. Okay? Phosphagen energy system, glycogen lactic acid system, and oxidative metabolism. In sequence, these are the energy systems used in athletic events. First 10 seconds is phosphagen. Next 2 minutes is glycogen lactic acid system. And after 2 minutes, oxidative. So the one that will require carbo loading to replenish your muscle glycogen are sports that will utilize exclusively oxidative metabolism. So this will include long distance jogging, ODAX, marathon. Phosphagen energy system, okay? So your sport event will only last for a few seconds. For example, 10 seconds lang yan. You don't require carbo loading in those sports. Okay? Sometimes used by athletes to increase muscle strength, creatine. Source of most energy used for long-term muscle contraction, oxidative metabolism. Okay? In terms of G-forces, positive G-forces are more dangerous because blood is shunted away from the brain. So you can tolerate anywhere from positive 6 to positive 10. Pag negative G-forces, you can tolerate more, negative 20 G. Caused by formation of nitrogen bubbles in blood that blocks blood vessels, decompression sickness. So nitrogen bubbles can cause the bends or the chokes. They can block blood vessels in the extremities or in the pulmonary vessels. Maximum safe depth to dive is 200 feet. Used for deep dives instead of something that contains nitrogen, we will use something that contains helium. Your journey is almost about to end. At the start of your journey here in Top Notch, I told you to burn your ships, burn the ships of anger, the ships of fear, okay, the ships of hate. You need to burn them all, and you need to be completely concentrated on the task at hand. Okay, passing the med boards, okay, getting the best score possible in the exam. Burn your ships and conquer the world. That was my lesson to you at the start of the program. So I will end my pearls with another lesson also from the Romans. Okay? Caesar. He conquered the world by first conquering Rome. Okay? During that time, 2,000 years ago, okay, the border of Rome was basically a river, okay, called Rubicon. By law, no Roman general, okay, is supposed to cross the borders of Rome. Okay, no one is supposed to cross the river Rubicon with an army still intact. He must basically give up his army when they cross the borders of Rome, when they cross the Rubicon. So when Caesar decided to actually conquer Rome itself, okay, they were marching, and when they saw this river, everyone in that army stopped. Okay, what did Caesar do? He took the step, okay, and he said, the die is cast. We have crossed the river Rubicon. We must now proceed with our task. We must conquer Rome. Okay? So, what is the lesson that I'm trying to impress upon you? The fear, the anger, the hate, you've burned them. Now, the med boards is just a few days away. You need to take a leap of faith in what you're about to do. You need to take a leap of faith on yourself that you can actually do it. You need to take a leap of faith in God. Okay? You need to take a leap of faith in your med school and in Top Notch. Everyone who has helped you, your parents. Take a leap of faith as much as possible. Take the med boards and just give it your very best. Okay? The die is cast. Take the med boards. And in a few days, in a few weeks, hopefully, okay, you'll be able to conquer Rome, conquer the world. Just a few days and just a few weeks, you'll be able to become licensed physicians. I'll see you on the other side. Thank you so much. Okay? See you during your oath taking in PRC. That's it for our Pearls Physiology.